Michael Curry.
Good morning. Okay, we got to start this off with a lot more energy than that. Good morning. Welcome to the 2025 Health Equity Trends Summit. Whether you're here with us in person at the iconic John Fitzgerald Kennedy Presidential Library and Museum, or joining us virtually from across the Commonwealth and beyond, we are grateful to have you here. With all the competing demands on your time and your attention, you're giving the day to this effort to advance health equity in the Commonwealth. On behalf of the Health Equity Compact, thank you for joining us. It's powerful to be in community with leaders and change makers from different sectors and corners of the state. Thank you for prioritizing this gathering and being part of the health equity movement. Before we begin, I want to recognize some key partners. The John F. Kennedy Presidential Library and Museum for hosting us in the place that honors the civil rights movement and bold leadership. Give them a round of applause, please. You'll see this iconic picture of John F. Kennedy meeting with civil rights leaders just, I believe, right after the March on Washington. Thank you to our generous sponsors whose support helped make today possible. Please give them a round of applause as well. And lastly, to our elected officials, agency leaders, and longtime partners, your presence today signals that this work matters deeply and at the highest levels. Give them a round of applause as well. This year's summit comes at a time of significant challenge and change in our health and policy landscape. We are witnessing disturbing attacks on vital programs and services across the country and right here in Massachusetts. We face the threat of $1.75 billion in cuts to Medicaid that could strip coverage from 250,000 Bay Staters and jeopardize the stability of our healthcare system. Deep cuts to SNAP are also on the table, threatening food security for more than 1 million Massachusetts residents. Hundreds of millions of dollars in NIH research funding have already been abruptly terminated. And executive orders dismantling programs that advance equity, diversity, and inclusion here and across the country. These policy decisions are fueling a climate of fear and uncertainty. Families are unsure how they'll afford food and medication. Patients receiving gender-affirming treatment don't know whether it will continue. For immigrant communities, the fear is incredibly acute. How safe is it to go see the doctor? How will the next person be detained without cause like Marcelo Gomes or Romesco Oster? These policies are now not just harmful, they are terrorizing our communities. They are devastating the health and well-being of people who already face systemic inequities. This fear is not accidental. It is the product of a broader pattern. Let's be clear. This movement is not new. Let's be clear. I'm going to say it again. This moment is not new. Those who know our history well know that every step toward justice has been met with backlash, from Reconstruction to the Civil Rights era, here in Boston, the busing crisis, and the Patriot Front today. And right now, in this climate, some leaders and organizations are feeling the pressure to comply, to pull back, or just to stay quiet, or wait it out. But here's the reality. The communities most impacted by these inequities do not have the luxury of waiting, and neither do we. Because what we are facing is not business as usual. We are in a crisis. If we fail to meet the moment, we all pay the price together. But if we face it head on, we have the chance to forge a future rooted in justice, health, and shared prosperity. The Health Equity Compact was born to meet this moment. Out of the darkest days of COVID-19, the pandemic, The glaring racial disparities in illness and death forced the world to reckon with the long-standing health inequities like barriers to care and lack of economic opportunity. So many organizations and agencies made commitments then to not return to a pre-pandemic normal that created these harms, but to build something better, and we know we haven't gotten there yet. We're going to have to do that as a community. And now we are in the midst of another crisis, not a viral outbreak, but a convergence of challenges to our health, our economy, and our civil rights. And once again, the very same communities that were hit the hardest by COVID-19 remain the most likely to bear the disproportionate suffering and harm. Health Equity Compact members are a group of over 85 leaders of color who are united by a shared conviction. We will not go back to a pre-pandemic normal that created the very conditions for those disparities. Instead, we are working to build a new normal, one rooted in equity, evidence, and accountability, where everyone has the opportunity to live their healthiest lives no matter their race, ethnicity, gender identity, sexual orientation, ability, income, or zip code. Me being a student of history and a student of civil rights history, I know that this moment is not unique, but it is special. I'm going to ask all the members of the Health Equity Compact that are in the room today to please stand, and I'm going to ask you to give them a rousing round of applause for their courage and conviction. Here in Massachusetts, the stakes are incredibly high. Even before these recent federal threats, our healthcare system was already under strain. Sky-high healthcare costs, a burnt-out, stretched-thin workforce, a financially stressed health safety net, and persistent racial health disparities. Our community health centers that deliver care that is both equitable and economically effective are under even greater threat in this moment. And the economic cost is staggering. The current racial health inequities cost Massachusetts $5.9 billion every year. These billions are avoidable spending, lost productivity, and avoidable suffering. And with looming federal cuts to Medicaid and other public benefits, we can expect that number to go up sharply. If we don't act now, we will pay greater later. We know that when we build a system that works for the most marginalized, we build a system that works better for everyone. These cuts don't just affect people on Medicaid or food assistance, it affects all of us. Emergency rooms get overcrowded, care gets delayed, and hospitals and businesses absorb extra costs, driving up insurance premiums for everyone. But the reverse is also true. We invest in a system that is equitable, we all benefit. A healthier, more stable, more productive Massachusetts is better for everyone. We have a choice to make. We can wait and hope things get better on their own, or we can act now to protect our health and economic future, again, together. Thankfully, Massachusetts is pushing forward. While other states are rolling back DEI efforts and investments in health equity, Massachusetts is choosing a different path, one of continued progress. Just 2 weeks ago, I stood alongside Governor Healy, Senators Warren and Markey, Senator Lydia Edwards, Assistant Secretary Levine, and members of the Cambridge Health Alliance to push back against devastating Medicaid cuts. And in a moment like this, when it is easier for institutions to stay quiet, influential voices like Sanofi and the Boston Globe are stepping up, doubling down on health equity and elevating the urgency of this work. And just last week, I joined a panel at Nutter Law Firm entitled, "How Does Massachusetts Remain Competitive?" Thank you, Billy Kennedy. What stood out to me was the shared spirit and conviction of my fellow panelists. Their answers: Steve Walsh, head of the Massachusetts Health and Hospital Association; J.D. Chesloff, who's here with us today, head of the Mass Business Roundtable; and Doug Howgate, with us today, head of the Mass Taxpayer Foundation. They each underscored the importance of equity and racial justice as central to our economic strength here in the Commonwealth. I'm grateful to call Massachusetts home, especially now. Later this afternoon, we'll hear directly from leaders from state government and health systems about how they are meeting the moment and how we can meet that moment together. We also have policymakers who understand the importance of health equity. Last session, a half dozen of the compact's priorities became law through the Mass Leads Act, the PACT Act, and the Healthcare Market Review bills. Thank you to the legislature, and special thanks to the Senate President Spilka and Speaker Mariano for their leadership and for being here with us today. In this session, the compact will be advocating for the refiled omnibus bill entitled An Act to Advance Health Equity, which tackles the drivers of inequitable health outcomes in three major domains. First, improving access and quality of care. Two, investing in communities and a sustainable health workforce. Three, strengthening health equity leadership and oversight. Thank you to our lead sponsors, Senator Payano and Miranda, and Representative Williams and Garcia. Chair Lawn and Chair Friedman, we look forward to continuing to partner with you as we move this forward. But passing bold legislation takes more than good leaders. It takes public will. That's where all of you come in, here in this room and watching live stream. Out in the hallway and on our website, thehealthequitycompact.org, you'll find materials on the bill and how to get involved. Whether it's joining us at the upcoming bill hearing, contacting your legislator, or bringing others into the conversation, your voice matters. This is how we keep moving forward. If I could sing, I'd sing Ain't No Stopping Us Now, but I don't have a singing voice. Let's progress. Let's continue to make the progress. The continued dedication to health equity and the presence of all people in this room and online remind us that we are not alone. Because this is Massachusetts, we have the people, the talent, the infrastructure, and the relationships to lead through this moment, if we choose to. Each of us, whether you're working in healthcare, business, government, or community, or you're a student or a retiree, whatever community you're part of, each of you has a role to play in this movement. You don't have to have marched in Selma to be part of history. This movement is your Selma. This is your Freedom Summer. This is your We Shall Overcome moment. What you choose to do now will define who you are and how history remembers you. The forces that are working to undo equity are acting with purpose. We must meet them in kind with equal purpose, grounded in moral clarity, equipped with the economic imperative, and tethered to the facts and science. We are living in a moment that demands courage. As Reverend Dr. Martin Luther King said, the ultimate measure of a man or woman is not where he or she stands in moments of comfort and convenience, but where he or she stands at times of challenge and controversy. Now is that time. And yes, the work is hard. Some who seem like allies will retreat when the pressure mounts. Some will choose comfort over courage. But we can't afford to retreat or stand still when so many lives depend on us, on you. So I ask you, stand with us, bring others in, act where you are, have the power that you have in your hands within your organizations, your community, and your circle. Because as the African proverb reminds us, rivers are filled one drop at a time. Thank you for doing your part, for being part of the health equity movement. I'm going to now introduce our very special guests. I have the distinct honor to welcome a leader who has consistently stood firm in her values and commitment to advancing equity in Massachusetts. As Attorney General, Governor Maura Healey made clear that the true health equity requires addressing root causes, racism, poverty, disinvestment, and she never hesitated to name them. In just 2 years, Governor Healey has partnered with the Massachusetts legislature and championed major legislation to improve maternal health outcomes, strengthen the healthcare workforce, expand access to affordable housing, invest in transportation, and tackle climate change, all with equity in mind. and with clear attention to those most impacted, closer to the pain. At a time that demands both vision and courage, Governor Healey continues to move Massachusetts forward and calls for all of us to do the same. She is the right person in the right place at the right time. I ask you now to please rise and join me in welcoming the 73rd Governor of Massachusetts, the Honorable Governor Healey.
Well, good morning, everyone. It's really terrific to be here. Michael, thank you for your inspiring words. Thank you for the call to action. Thank you for the affirmation of what folks in this room are doing. And I think it's really appropriate that we're here today at the JFK Library for this convening. And I hope you take a moment, look past me, and look out to the bay, and just soak in where you are. You know, you're JFK's presidential library, and you think about somebody who talked about doing hard things, who had a vision for things that people didn't think were possible, and worked to get them done. You think about Ted Kennedy, and we're right next door to the Institute, right? And the Affordable Care Act, and his lifelong fight for getting people access to health care. And I just, you know, I at least I'm going to fill up my cup this morning, just soaking in the ambiance of where we are this morning. And I think that's important. Let me just say, I'm going to say some words. But if you take nothing else from my comments this morning, I want you to take away the following. Number one, you're doing the right thing. Continue to do the right thing. What Trump and Republicans in Congress are doing by trying to gut Medicaid is catastrophic. We must fight that in every way possible all across this country. Number three, attacks on health equity are wrong. They are misguided, and they're wrong. The work that you do day in and day out, so many of you, the work of the Health Equity Compact is important work. It's necessary work. Do not take your foot off the gas. I say that to everyone in the room, us in government, community health centers, life science companies, hospitals, providers, our clinics, insurers. Do not take your foot off the gas. Number three, RFK is a threat to public health. And I don't know if you ever played opposite day with your kids, but basically, that's how we got to engage, okay? When they want to take down data, we're going to put up data. We're going to provide data. If they want to defund science and research, we will fund science and research. If they want to dismantle the CDC and vaccine infrastructure, we're going to find a way to build and make and distribute our own. And we're going to make sure people have access to it equitably. The next thing I want to say is I want to acknowledge the fear, the trauma in this room that's been inflicted by relentless attacks by the Trump administration on immigrant communities. I appreciate that many of you are in health centers treating people with hypertension off the charts. You are there showing up, finding ways to get food to people who are too scared to go out to a food pantry, taking care of kids who are sick, but people don't even want to leave their homes. So many of you right now are on the front lines. I want to say thank you. I want to wish you continued strength and resilience. Our people need you. Our people need us in this time. And I want to be very clear about our continued need to speak out against what is an affront to the rule of law, to the Constitution and due process in some instances, and what really has revealed itself to be a weaponization of the worst kind and in the worst way in terms of cruelty across this country. I've spoken to you before about this. I was Attorney General. I understand something about putting away bad guys. We all have an interest in safe communities. And what we are seeing all too often across our communities is parents being taken away from children, neighbors being removed from communities, coworkers literally being taken from parking lots in front of other coworkers. It's not right. It's not okay. And it's up to those of us, particularly in positions of privilege and of power, to articulate that. Meanwhile, you are on the front lines, taking care, looking after. Continue to do that work. I'm confident that in time, with people speaking up, with continuing efforts to put a face on what is actually happening out there, we'll restore the semblance of sanity when it comes to the treatment of one another. But I just wanted to say, I know and understand, I think, what it is you're dealing with, what we're seeing. And it's a challenging time. It is a challenging time. What's happening in California right now is horrifying. Donald Trump has created a public safety threat. And we continue to see the consequences, the ripple effects of that every hour. But we must be strong here in our state. We must be resolute. We must be calm and work together and support one another. We need to find the alliances and the ties that bind. By the way, community, government, law enforcement, we're one Commonwealth. I'm confident we can do that. And finally, we're going to celebrate Pride this weekend. And we're going to get an early start on Juneteenth, too, in places. So it is so important that we point to, we look for, and we take advantage of those moments to celebrate, to embrace one another, to have fun, to laugh, to express joy. Lean into that for yourselves, your coworkers, your families. That's also what's going on, and it's very, very important in this moment. All right, I'm not a doctor, but that's my prescription. I'm delighted to be joined here today by members of our team, leaders in our administration, Secretary Kate Walsh, Undersecretary Kiami Mahania, Commissioner Robbie Goldstein, Insurance Commissioner Mike Caljo, Secretary of Veterans Services John Santiago, and so many throughout HHS. Thank you, team. You're awesome. I'm honored to be alongside Speaker Mariano and Senate President Spilka, grateful for the leadership of our legislature on so many fronts. Michael talked about some of those victories in just the last 2 years, and I can say there is no better legislative leadership in the entire country than what we have here when it comes to looking at matters of health. There is a reason why Massachusetts is #1 in healthcare. There is a reason why we have the greatest coverage percentage of any state in the country. There's a reason we care about mental health and maternal health, and we support and embrace, and we're here in furtherance of this wonderful effort, Michael, around the Health Equity Compact. And it's because we have people in positions of power in the legislature, good morning, John Lawn, who care. Is Senator Friedman here? Yeah, that's what happens. And you help animate. You all inform the laws and the policies that are made. Across every sector, I look out at this room and I see members of the Health Equity Compact, doctors, nurses, hospital and healthcare center leaders, public health experts, local government leaders, health plan executives, scientists and biotech leaders, philanthropists, equity advocates, all together advancing the work of health equity. Because across every sector, we have people in this room and beyond online who share a deep belief in the health and well-being of our fellow residents. Whatever their age or income, race or religion, wherever they were born, and wherever they live today, we believe that everyone deserves access to high-quality care. The moment that we're in is very serious. We're facing challenges even before this administration came in, and I spoke to some of that just a moment ago. But I think when we think about, Medicaid right now, I've been trying to put a human face on it. I think others have as well. We need to continue to do that. We need to talk about the moms and the children and the babies, the seniors, the veterans, people with disabilities, the poor. We need to talk about the fact that Medicaid cuts hurt everyone. We're going to see longer wait times in emergency rooms. We're going to see premiums go up for everybody. Small business owners aren't going to be able to survive this. Nursing homes are going to go under. Healthcare centers stretched to the limits. This is bad across the board. You've been sounding the alarm. We need to continue to do that. The attack on equity, I think we've shown here in Massachusetts that in the face of those who will want to take us away from efforts around equity, who want to whitewash everything, we're just leaning into it even more. It's so important because we know that that's a better way forward. We're leaning into our partnerships, we're leaning into our progress, we lean into health equity and the work that has made us a state with such great rates of health care coverage. We're going to lean into primary care, and we're going to lean into the workforce that delivers it. And I want to thank Undersecretary Mahania and HPC's David Seltz for their work on the Task Force on Primary Care Access, Delivery, and Financial Stability. We know that investments in primary care are going to not only improve health outcomes, but are going to yield great savings. So you're doing important work. I look forward to the findings from that task force, and let's just keep going. I want to thank the work led by Secretary Kate Walsh, who I know you're going to hear from later today. Our signature healthcare initiative, Advancing Health Equity in Massachusetts, AHAM. Is it AHAM or AHAM? AHAM? AHAM, okay. You know, that thing that we called it, that I apparently launched, that I don't know how to say. It is really, really important, right? The goal, eliminating racial, economic, and regional disparities in healthcare. And we've already been out getting to work, improving maternal health, addressing the social determinants of health. It's been invested in, or I should say it's been directed at a lot of community-based work. Most recently, we secured partnerships in Brockton, Lawrence, and Lowell with .32 Health Foundation and Healthcare for All. We backed the Atrius Health Equity Foundation and Blue Cross Blue Shield of Massachusetts Foundation for their partnership in Chicopee and New Bedford. Atrius is also supporting the Boston Public Health Commission's work in Dorchester, Mattapan, and Roxbury. And I'll also share a multi-year investment today, and that is in the Health Foundation of Central Mass and the Health Equity Partnership of North Central Massachusetts. So Those are just some things, but more to come from AHEM. I'm really grateful to Secretary Walsh for her vision, DPH Commissioner Robbie Goldstein, and Undersecretary Kiami Mahania for their leadership on these fronts. I also want you to know it extends beyond HHS. It's important that we have a lens, a health equity lens on everything that we do. So in housing, our $800 million reauthorization of, economic development, our $800 million reauthorization of the Life Sciences Initiative for the first time names health equity as a focus area. Just yesterday, we announced a new round of research grants in the Health Equity Accelerator through the Mass Life Sciences Centers. And as I said, as the Trump administration is looking to cut research and funding, not only is this integral, essential to our economic infrastructure as a state, we know it is so, so important for advancing the work that you all have been doing. In public safety, we're also prioritizing trauma-informed and survivor-centered care. Yesterday, I convened the governor's first ever Victim Services Conference, and we talked a lot about these issues. In housing, we know it's about providing safe and secure, affordable housing, and that's why our $5 billion Housing Act is making historic investments in public housing, supportive housing, and first-time home ownership aimed at closing wealth gaps. In education, we're leading the nation in childcare investments and childcare access, so important at a time when parents need to work and kids need to be cared for. At a time when the Trump administration is attacking our college access, our Mass Educate initiative has made community college cost-free, bringing thousands more students into higher education who didn't have access to before. And our expansion of financial aid last year saved students $110 million. That's economic mobility for them and their families. I just listed all those areas, okay? And I want to thank the Speaker and the Senate President for all that you did to help get through those important pieces of legislation, for your partnership and work on this front. Difficult moments bring us together in Massachusetts, and I believe will bring out the very best in all of us. My pledge to you today is to do everything as governor that I can and that my team will do to work with you more collaboratively than ever, to advance the ball even faster, notwithstanding the headwinds, and to be unrelenting in our push for equitable outcomes. That's the strength of our state. It's one of collective commitment. We've been about having the best health care in the world for a long time. We know it's not perfect. We know there's more work to do. But I think now is the time for us to be more innovative than ever, to be more nimble than ever, to take more chances than ever, because the urgency of the time necessitates that. So let's just go for it. Thank you for all you do. Have a wonderful, wonderful conference. Thank you to Michael and the team.
Please welcome to the stage President and CEO of the Health Foundation of Central Massachusetts, Chair of the Health Equity Compact Board of Directors, Dr. Amy Shea.
Thank you. Let's give it up one more time for our governor. If we were playing basketball, she'd be our MVP. Instead, we are playing a new game on quicksand with no rule book. Testing.
It's working.
Okay. So if we were, thank you everyone. If we were playing basketball, she'd be our MVP. Instead, we are playing a new game on quicksand with no rule book, and she continues to rise to the occasion and lead Team Massachusetts forward. Governor Healey's leadership is present at the national level and also at the local level, where she and her team show up for our communities. Her administration's partnership with the Health Foundation of Central Massachusetts and the Health Equity Partnership of North Central Mass on the newest AHEM initiative is evidence of that. This initiative is centered in Ayer, a community that lost a beloved community hospital last year and that has among the worst health outcomes in the state. But it is also a community where people and organizations have come together to develop solutions, so the future is bright. I'm grateful for all of you who are here today. We are over 400 strong in person, with hundreds more tuning in online, and even more who will watch the recording afterwards. Your being here is an act of resistance and a show of solidarity. Thank you. Take a moment to look around and admire the big, beautiful sea of humanity in this room. You have all chosen to be here today. In this room, in this state, we will not shy away from saying the words health equity. Instead, we will advance equity boldly and without reservation. We will let equity be our North Star. We are lucky to be in Massachusetts, where our fellow residents believe in equity, diversity, science, and democracy. We understand the importance of having a balance of power between the branches of our state government, and so we are fortunate to be able to hear from leaders from the executive, legislative, and judicial branches today. Our next speaker serves a critical role at the helm of one of our legislative branches, and her record of leadership speaks for itself. Senate President Karen Spilka has led the Massachusetts State Senate since 2018. She has consistently championed legislation to support our most vulnerable residents, and she has led successful efforts to expand access to quality education, from early education all the way up to community college. Her signature mental health care reform bill, signed into law in 2022, has been cited as a national model. Senate President Spilka is a social worker and attorney by training. In addition to her professional accomplishments, she is also an avid animal lover, which I think says a lot about the type of person that she is. Her family pets have ranged from warm and furry ones to cold-blooded and bearded ones, a diverse mix in the very best way. I'm grateful for her leadership, compassion, and commitment to equity. Please join me in warmly welcoming Senate President Karen Spilka.
It's true, we have had a very wide assortment. I think we should have bought a farm years ago, from Labradors to assorted rescue to little pitties that were terrific, to another dog that we recently adopted. We've also had bearded dragons, an assortment of lizards and reptiles, snakes. One got loose one time. That was not fun. I drew the line at that point. But we've been open to many animals, and it's really made our lives a lot richer as well. I can't imagine my kids and my family growing up without them. So thank you, Amy, for that very kind introduction, and thank you for inviting me to speak with you today. I'd like to recognize Alan Price and everyone at the JFK Library for hosting this summit today at such a beautiful place. Yes, as the governor said, take a look around. And I do want to acknowledge that we are all very grateful that the library doors remain open. I'd like to commend the incredible work and the words of Michael Curry and his efforts to ensure healthcare is accessible to all of our residents in Massachusetts. And I'd like to thank also my good friend Governor Healy and Lieutenant Governor and her administration for their partnership, as well as my friend Speaker Mariano for his partnership throughout all the last few years in actually getting work done for the people of Massachusetts. Working towards the best possible health outcomes for all of our residents is central to who we are as a state. And I can assure you that the three of us will continue to work closely and collaboratively together towards that goal. I'd also like to thank my good friend and Senate Healthcare Finance Chair, Cindy Friedman, who will be leading a panel later on today, for her fierce advocacy for health equity in every corner of our state, and actually in every aspect of healthcare in our state. She's a tireless advocate. I know she's currently working on primary care and other areas, so stay tuned for more of that. Finally, I would like to thank every single one of you here today. You are all on the front lines of pushing for, advocating, fighting to either expand, create health equity in our Commonwealth. Despite what is going on a federal level, I know if you're like me, I wake up starting some days with anxiety and feeling that there's so much going on. But your fight, your actions, your words make a difference, not only for where you work, but for all of the residents of the Commonwealth. So from the bottom of my heart, I thank all of you, not only for supporting the Health Equity Compact itself, but for all you do to make Massachusetts a better, more inclusive, a healthier place to live, work, and play. It's wonderful to see so many friends and familiar faces in this audience, and it is truly inspiring a necessary effort. In many ways, the work of the Health Equity Compact feels more important than it did even a year ago. But it also feels more heavy to contemplate this work in the current political climate. I won't belabor it. You've heard it before. You hear it all the time. The Trump administration and Republicans in Congress seem determined to make Americans sicker, to make Americans poorer. And we all know, unfortunately, who will be hardest hit by these efforts in America in 2025 and beyond, unfortunately. That's why it feels so necessary to stand before you now and promise, and I promise to you, that the Massachusetts Senate will continue to seek to do the exact opposite by finding ways to cut costs and expand opportunities so that every single Massachusetts resident, regardless of background, where they live, where they came from, they have a shot at the American dream right here in Massachusetts. Because the Senate knows that health equity may be the topic of today's summit, but true equity must be our Commonwealth's goal. The Senate will continue to act boldly. We will not back off from our values and our priorities. We initiated a Senate Response 2025, and we will continue to take action to fight back against what is being, I believe, inflicted on Massachusetts, other states, and other residents in an effort to create chaos and clearly not doing well, not making Massachusetts or our country great. We need to fight back. I'd like to think that our initiatives that we've championed, such as universal free community college, many grants to help others in other areas of public higher ed stay in higher ed and graduate to achieve their American dream, early childhood education and care reform, and the Student Opportunity Act, these will catalyze an expansion of opportunity across the state. While our efforts to lower prescription drug costs, leading first in the PACT Act and signed into law last session, and most recently, the Senate's initiative in its budget, the 2026 budget, along with addressing high costs to housing, taxes, and transportation. We will start to make our great state more affordable, continuing to make it more affordable for residents. And when it comes to the vital work of addressing health inequities, I am proud that the Senate has taken steps in partnership with everyone in this room, seriously, everyone, and that has made a big difference. We have passed a bill that would address disparities in local and regional public health system, the statewide Accelerated Public Health for Every Community Act, otherwise fondly known as the SAFE Act, SAFE 2.0. We have sought to expand access to life-saving HIV medication, known as PrEP, the last 2 sessions. Our comprehensive maternal health bill, now law, is designed to address barriers to access care and to reduce racial inequities in maternal health, among so many other important provisions. In addition, we have expanded eligibility for connector care, which helps bridge the gap for those who are not eligible for subsidized coverage under Mass Health, but also experience challenges affording insurance. We also increased oversight of private equity in healthcare and long-term care to ensure that our most vulnerable residents stay protected against those who put profit against people. We've increased programs and services for mental health across the state for both children and adults, and I'm proud to say that our economic development bill that we passed last session, we also look at health equity under an umbrella of everything that comes through the Senate. So we were able to bolster and include a pathway for Massachusetts for physicians who are licensed outside the United States to practice in underserved regions of the Commonwealth. We also added a provision in the Economic Development Bill to admit in Massachusetts the National Nurse Licensure Compact, which will help alleviate the critical workforce challenges facing our healthcare by pumping more nurses into our system. Also, we bolstered our crucial life sciences sector with important funding while adding health equity, biosecurity, digital health, and artificial intelligence to the mission of the Life Sciences Center. Most recently, we sought to strengthen our healthcare ecosystem through our 2026 budget. Amid uncertainty in Washington, our budget maintains access to comprehensive healthcare coverage for over 2 million Massachusetts residents. As I mentioned earlier, I'm proud that our budget also includes a provision which would rein in costs of certain prescription drugs. And the Senate continues to find ways to support community health centers and hospitals that serve residents who are uninsured and underserved. That is so much a part of the Massachusetts system. And again, we will fight any efforts to prevent that. The next few years, we know, may be uncertain, and the road ahead may not be easy. But the Senate is committed. We are definitely committed, working together, collaborating with all of you to protect our residents, defend our values, and help to lead Massachusetts through this second Trump era. We feel a real sense of urgency here. We cannot rest on our laurels. We need to act. This includes protecting providers and patients through an updated SHIELD bill, because everyone should be free to access the health care that they need. And this SHIELD Act will expand protections for women's health care and gender-affirming care. I'd like to thank Senator Friedman for working so hard on this, and this bill will be done within the coming weeks. Looking forward to it. As I have often said before, and I believe with the bottom of my heart, Massachusetts is a Commonwealth, which means that we must care for each other. And we only succeed when all of us succeed. We will need those bonds of community and the bonds of care more than ever before as we fight to continue to create the equity that I believe we are morally compelled to create, even as the federal forces seek to set us back. I am honored to be in this fight and meeting the moment with all of you, and I look forward to learning from you and working with all of you in the coming months and years to come. Happy Pride, happy Juneteenth, and happy summer. Be well and take care. Enjoy your day.
Please welcome to the stage the principal of Sanchez Strategies and co-founder of the Health Equity Compact, Jeffrey Sanchez.
Buenos días. Aquí estamos presentes. Eso es. What an honor and a pleasure to see all of you here today. You know, sometimes when you have conversations with your friends, things happen. And all of you being here, it's because all of us are having conversations with each other about how we're going to bring our grain of sand and how we're going to bring solutions to the great challenges we have. So to have this room full with all of you today, it's a really big deal for all of us. And I hope all of you feel this, because we feel you here and we feel you present. And I'm lucky myself personally, because I've had so many incredible people. When I was a state rep for a couple of years, and I had some pretty incredible people around me, including the Senate president, who the one thing that they didn't put on her bio was, nobody can work on a car like her. Yeah, we will have conversations about rebuilding engines, and she has got it down packed. Like, she is the real deal. So give her a round of applause, because she goes at everything like that with precision and at the same time elegance, Madam President. Thank you for all you do, as well as all of the folks within the governor's administration. Secretary Walsh, thank you for being here with us today, as well as the rest of the administration. But I'm here because I had the honor of introducing somebody who has been in my life in very profound ways. And I like to say in the beginning with him, because when we started working on this thing called health reform, and remember, Massachusetts started health reform way back in the 80s, but it didn't work out. And we had to go back to the drawing board. And this individual had a big part of that. There's a picture out there that shows when our universal coverage law was signed. And you're going to see a whole bunch of people. You're going to see a governor. You're going to see former Senator Kennedy. You're going to see all kinds of people on a stage celebrating that moment. And I remember the stage was about 12 feet high at Faneuil Hall, and all of us were there celebrating that moment of the promise of what could be a program that could ensure all of our population, or near to it, which is where we're at now at 98% of the population. And in that picture, you will see the person who's going to come up here. And like I said, in the beginning, he was there, and he's still here. And on that picture, he's also the last person that had his hands on what was one of the most consequential health equity initiatives, not only here in Massachusetts, but set the stage around the United States. He's a school teacher. He was a school committee member. He values being in coffee shops, and he values being in with his members in the legislature. He's held all of our hands and so many others as we were trying to figure out how we make our impact. And remember, with that law, there was a lot there. the individual mandate, the employer mandate, the subsidized programs, the health insurance exchange, minimum credible coverage, and the health safety net. Remember that one, Madam Secretary? And what have we succeeded in? High insurance coverage, improved health outcomes, increased access to care, expansion of private insurance. So when we talk about having the right three people present, it's real because they have the details. They understand what we have to be going at in that big cloud that all of us are looking at down south in Washington, D.C. I love this guy dearly. I remember, him expressing himself very eloquent to me on many of the occasion. But, in Spanish, nosotros decimos que ese tío enojón. Yeah, see, and he loves it when I do that, right? Pero se quiere, ¿verdad? You love him, right? In Spanish, we call it, our tío, our uncle, right? And our grumpy uncle. And he's my grumpy uncle, and I love him. But he stays at the table, and he'll call you in, and he'll call you out. And that's my friend, Speaker of the House, the state representative from Quincy, Massachusetts, Ron Mariano.
I just get grumpier. Those of you who know me know that this is embarrassing for me, but I want to thank Jeff for those kind words, and most of it was made up. So he's always had an active imagination, and it's what makes him a passionate individual. I want to begin by thanking the Health Equity Compact for inviting me to speak here. This has been something that is really important to me. As Jeff alluded to, I've been doing this a long time. It was about 20 years ago that I sat down with a few, and I will say this, but I'll deny it and if I'm called in front of witnesses, but a couple of Republicans in the Romney administration who had some ideas about making some changes in health care. And we used to meet secretly because if my boss knew, he would have been very upset. But we continued to talk about some of the things that we were seeing in the marketplace. And there was an awful lot of fear and trepidation about where this was all going. And we made a commitment, and I got the Speaker to make a commitment. The Senate President at the time also joined in that commitment. And we were able to put together what I think was a very, very important piece of legislation that withstood the test of time. It was attacked by Republicans for many, many years as they tried to dismantle it and figure out how they could take it down. But they never could. It still exists. It's had some changes. The changes always weren't beneficial to the efficiency of the program, but the thrust and the impact has remained the same. And for that, we have everyone in this room to thank, because it was the change in philosophy and how we dealt with health care that was the real change. At that time, and I am so proud to say this, that when we were doing the bill, everyone involved in health care was at the table. Everyone. Everyone weighed in. We knew what their concerns were. We knew their limits, what they would do and what they wouldn't do. And we were able to get across the finish line. we are approaching a situation that resembles what we went through 20 years ago. We're being attacked from all angles with all types of crazy, and that's the nicest word I can use, attacks on our system. And it isn't just healthcare. You've heard the governor and you heard the Senate president talk about the wide-ranging effect that we're going to have to live with as we deal with what's going on in Washington daily. The stresses and strains, when you listen to the people talking, one day they're firing all the vaccine people, the next day he's hiring vaccine people. Who knows what it is. It is going to force us to reevaluate how we do everything. And we're going to have to work together. No one is going to be able to stand alone in the face of the potential cuts that are coming down the road. Everyone in here, and I appreciate Michael Curry's call to action, but there are no options in this. We're all going to be forced to preserve what we have today. We're all going to have to work together. I have a thing, but I'm not going to read it. But the fact is that the governor, the Senate president, and myself are committed, and you heard it from all three of us, in maintaining the quality of health care for everyone in the Commonwealth of Massachusetts. We're going to do the best we can. We don't know what hurdles are in front of us just yet, but rest assured, they will be hurdles. This guy's throwing so much stuff against the wall, some of it's bound to stick. And we will have to adjust, and we will adjust. We will adjust to make sure that everyone has access to the health care they deserve. There can be no exceptions. There just cannot be any exceptions. We've been faced with brutal attacks on immigration. I have no idea what he thinks he's going to accomplish in California. But it is a signal that there is something systemically wrong with the guy running this country. And we're in it right in the front, and everyone in here is going to have to fight like hell to preserve what we have. But we're with you. You heard the governor say that. You heard the Senate president say that. And I'm saying it. Every day we open the paper, there's a new challenge. More diverse and more crazy than the day before. And we've learned to not overreact, but to systemically work on fixing the things in front of us that need attention. And you have that commitment from the three of us here today. If nothing else, that's what you should take home, that we're here to help. You know, the Senate president listed a lot of the things that we get done the last term. And I will be the first to admit the maternal health bill had a lot of things in there that I didn't quite understand. I didn't understand the value of the service. But talking to advocates and talking to folks who are in the field, I was persuaded that it made an awful lot of sense. And now we have a bill, and now we have a law. And that cooperation will continue. We're even more aware of the necessity of working together as we stand here today. So with that, I can give this back to my speechwriter, and he can save it. And I'll read it to someone else. But I was really taken aback by the enthusiasm of the group here today, and certainly respect the concerns and the efforts of everyone in this room who's contributed to helping us make the Commonwealth a better place to live. And that is the goal as we welcome immigrants from all over the world. And we want to make them safe, and we want to make them healthy. So that's the goal, so let's go do it.
Please welcome to the stage today's MC, Chief Behavioral Health Officer of the Lynn Community Health Center, Health Equity Compact member, Dr. Carlos Capas.
Wow, what a way to start the day. What a foundational way to begin this conversation. I am so excited to be here with you all. Again, my name is Carlos Capas. I am the Chief Behavioral Health Officer at Lynn Community Health Center, a very proud Health Equity Compact member. And I'm here to walk you throughout the day and hopefully continue to set the tone and really highlight a lot of the things that are going on in this very great conversation. So before I do so, I was asked to put out a couple of reflections and the importance for me about this summit. And I couldn't help but think about my clinical days as a clinician. Just as a little bit of background, I am a clinical psychologist by training. My career has been focused on integrating behavioral health into primary care practices, particularly in community health centers. I strongly believe that's the way to provide behavioral health and increase access to care and familiar places to our communities and to our patients. So I was thinking back about 15 years ago when I began working at the Greater Lawrence Family Health Center. I was brought there to two things. One, train family medicine residents, and two, integrate a behavioral health practice at their main site, which happened to be also their training site. And as we succeeded in building this practice, I began getting referrals from both residents, PCPs, and as you can imagine, by the time that patients got to me, they were struggling. There were a lot of challenges. Patients were struggling with depression, anxiety, isolation, coupled with multiple medical conditions and social needs, right? So inspired by the primary care approach of being so solution-oriented, but yet being met with the challenges that were unbearable for my patients, I started struggling. To see how can I actually continue to help patients address overall health. And when I started thinking about this, I decided to do something different. Patients continued to see me for follow-up sessions, but at one point I decided, you know what, I'm gonna start my sessions by asking a different question. What's been going well? And I saw and heard a few of you just go, To me, that's just not just a nod of agreement. To me, that's just, you just made me think differently. But of course, what's a perfectly natural human response to a question like, what's been going well? Anybody? ¿Qué? A mí? Nada. What? Me? Nothing. But I say that's because eventually patients, as we continue the conversation, they started thinking about, you know what, Carlos? Last week, X and Y happened and I felt pretty good. Or fíjate, doctor, esto pasó y me hizo sentir bien. So why do I share this with you today? couple of months ago, I was at a Zoom meeting with a couple of colleagues here locally in Boston and in California, actually. And we were having a discussion on improving our dashboards to address health equity issues. And as people were joining the meeting, we all gravitated to start talking about the challenges that we are facing at our larger organizations, personally, et cetera. And as I heard these colleagues talk about all the challenges, I started reflecting on all the stories that I hear from my patients every week, all the stories that I'm hearing from my patients, from my providers, from staff, and clinicians. And as someone turned to me and asked, so Carlos, so what's going on at Lynn? What's going on at the health center? I paused for a second and I said, we are doing the work. We're doing the work. And today here is no different. You've heard a lot from Michael, the governor. We are doing the right thing, and we need to meet the moment here. We have leaders across industries, sectors, geographies. We have emerging leaders. We have aspiring leaders and health equity champions that we need to be together in order to actually make this moment, meet this moment, and look for that North Star. So thank you all for being here, being committed to the work, and helping us address a lot of the issues that we'll be facing going forward. So, thank you. I'm also in charge of logistics, so I'm going to take a couple of minutes to walk us through. So we do have a full day plan ahead. We have breaks and lunch. Please follow the agenda. We do have a lot of folks online in the live stream. Speaker bios are on the healthequitycompact.org website if you want to learn a little bit more about all of us. And then for those of you here in the library, don't forget to visit the signature wall and add your name to the mosaic. Then snap a photo, take a selfie, and post it on social with the hashtag HETS2025. You will be entered into a raffle to win a copy of the Not All In: Race, Immigration, and Healthcare Exclusion in the Age of Obamacare. So we hope to see you all there, and we hope that you can actually engage in this activity as well. Now, we have a packed room today. We're also rolling pretty deep online, so we want to make sure that we do engage everybody here and online. So we are using this as with an app called Mentimeter. So I believe up in the screen or in your agendas, there is a QR code that you can snap a picture. If you can't, go to menti.com and enter the code 8838-7268. This is going to help us with the Q&A. This is going to help us continue to have you engage here and online. So here we go. Thank you. So please, and so to start, just to kind of, we'll give a second for folks to get in the QR code and then flip the slide so that you can see the first question. It's an easy question. So first, how are you joining us today? So clearly, here online. Oh, there's also on the agendas in case. So just leave this up for a little bit. As soon as you log in, you'll probably see the first question. So again, how are you joining us today? And we'll start putting the results. I believe Angel, you're on the back. We'll start putting the results. All right. So most of us here, as you have logged on. Yeah, we have the online live stream increasing, so great. So this is just to demonstrate how this works. Next question is, what part of Massachusetts are you from or are you working from? And this is actually a multiple choice, so please log in and try to. So most of us here in the greater Boston, we have representation from Central Mass, Western Mass, Northeast. Ourselves, I have a group here from Lynn, City of First. Excellent. All right, so I think we have all gotten used to this already, correct? So let's let's go to our last question. So, this is what we're all here for, and I'm asking for all of you to be intentional and bold about this. So when I fight for health equity, I am fighting for, I will share that at our health center, when we fight for health equity, we're bold and we want to eradicate health disparities. And the way that we do that is through the integration of behavioral health, primary care, community support programs, and using data to really drive access to ensure that our patients get the care that they need. So what am I hearing here? What am I seeing? Justice, my community, excellent, everyone. So something that I've actually started doing recently is, sometimes we actually gravitate to the larger words, and because mostly we can't see the small words, but I can't see them right now, but next time you actually, or if this is posted in our website, try to look at the smaller words. I often identify things that I have never thought before or things that are very unique to the questions or the things that we're actually wanting to post. So, all right, so I think we got a sense of how this works. And so I have the pleasure of introducing the session and our first presenter, in the session being Navigating Towards Our North Star with Health Equity Benchmarks. So what we're building towards starts with clarity and a shared commitment to measurable progress. In our first session, we'll explore how statewide health equity benchmarks can serve as a North Star to guide collective action. These benchmarks are a powerful tool to help align on shared priorities, drive smarter investments, and foster meaningful cross-sector collaboration, especially as we all navigate through the complex challenges. We'll start with a brief presentation that grounds us in the why behind this work and the opportunity we have to bring powerful but fragmented efforts into a more unified, outcomes-based framework. Then we'll hear from leaders from different sectors, discuss the proposed framework for our statewide health equity benchmarks. And as you listen, we ask that you consider how this shared vision could shape the work in your organization and communities. So it's now my distinct pleasure to introduce Dr. Elsie Taveras, who is a fellow Health Equity Compact member, a friend, and esteemed colleague. She brings deep clinical, academic, and community expertise to her work. She serves as the Chief Community Health and Equity Officer, as well as leads the Kraft Center for Community Health at Mass General Brigham. She's a practicing pediatrician and professor at Harvard. You can read more about her impressive background on site. Please give me a round of applause and give a warm welcome to Dr. Elsie Taveras.
Good morning, everyone. I told Carlos that, as many of you know, the time that I'm most nervous when I am speaking is when I'm getting introduced. I asked him to keep it short, and I will also try to keep my opening remarks brief so that you can hear the incredible panel that we have to start off our panel sessions today. I want to begin not with data or policy, but with a reflection, one that continues to influence the work that I do, the work that my team does across Mass General Brigham and community health and health equity. At the height of the COVID pandemic, the week I remember still of April 17th, 2020, when we had reached the peak of the number of deaths every single day that we were seeing from COVID mortality, the inpatient census at Mass General Hospital showed that 65% of our patients were Latino, were Spanish-speaking, and had a Chelsea address. Many were essential workers, living in crowded housing, were food insecure, had chronic conditions that went untreated, like obesity, asthma, diabetes, hypertension. Many were not connected to care. Chelsea was one of several epicenters that many of us have seen in our own work and communities that became crystal clear with the onset of the pandemic and the epicenter of the relationship of social drivers of health, poor access to care, and health outcomes. COVID exposed deep structural inequities like barriers to health care, nutrition, and economic opportunity that drove stark disparities in illness and death that we saw in Chelsea and so many other communities. But COVID also revealed what we will focus on today, and that is the story of what came next. Unprecedented, in my next slide, collaboration. And now let me say that again, because we are in a city, a state of incredible health organizations, health systems, community-based organizations. Never before had we seen, in the next slide, unprecedented collaboration across multiple health systems and community organizations with a singular focus on reducing mortality and increasing vaccinations that led to measurable successes. Partnerships between public, private, and philanthropic partners. Efforts that led to Chelsea going from the community with some of the highest mortality rates to being a standout in one of our proudest moments, at least for me, because that is my team actually in Chelsea delivering those vaccinations. Chelsea later became, and not to take credit, we were part of a larger effort that made us all so proud to see what a collective effort really does lead to. Chelsea later became a standout for vaccinations and an outlier among communities with high social vulnerabilities. And for that, that's the example of what we are here to talk about today, that collectiveness that we keep talking about, and that, reducing those fragments in our efforts to really drive towards that North Star that you heard mentioned earlier. Today, though, we still see the consequences of systemic inequities, not only in what our communities face each day, but also in hard data. One of the most telling indicators of how our systems are serving, how well our systems are serving people, is whether they're able to live full, healthy lives. And I'm going to show and share some data with you on premature mortality. From 2018 to 2023, there were over 146,000 premature deaths, lives lost before the age of 75 in Massachusetts. This figure comes from an unpublished analysis of the Department of Public Health, with thanks to the TALV Corporation and the Blue Cross Blue Shield of Massachusetts Foundation. These are lives that were cut short, and many of these deaths were avoidable, either through primary prevention efforts or treatable through timely medical care. These losses also are not equally distributed across the population. If you live in one of the 30 communities with the highest health disparities, as defined by the state's Advancing Health Equity in Massachusetts initiative, also known as AHEM, your risk of premature death was 1.5 times higher than someone living elsewhere in the state. That is 50% more premature deaths when compared with other areas in the state. Where you live shapes your health outcomes, independent of your race, ethnicity, or language. But it's important to recognize that communities of color bear the greatest burden, making up 49% of the population in these most impacted areas, compared to just 21% in other parts of Massachusetts. While the worst days of the pandemic are behind us, the structural inequities that drove the severe disparities in COVID illness and death are still here. Now, as we face cuts to Medicaid, SNAP benefits, and other vital programs, these inequities are threatening to grow wider. If we don't act, the communities hit hardest in the pandemic will bear the greatest burden of what's to come. And we also know that by addressing inequities, we can create a stronger, healthier system that benefits us all collectively. Not to mention that these enormous inequities have an economic toll of billions of dollars each year, as you heard Michael Curry reference. That is why we must prioritize health equity. Health equity must be literally the North Star that helps guide us, no matter how the Earth and Washington, D.C. shifts under our feet or what storms come our way. And crucially, it's not enough to admire that North Star from the distance. We must make measurable progress and movement toward it. Massachusetts is already doing great work, and we are so incredibly fortunate, as you heard so many of our leaders already this morning. We're fortunate to live in Massachusetts. The question now is, how can we better align our efforts to go farther together and be outcomes-oriented? not just activity for the sake of activity. There's amazing work we can leverage, and you'll hear so much of that throughout the day. Take MassHealth's 1115 Medicaid waiver program that's already driving real change by tying hospital financial incentives to key health equity outcomes. But it's time limited, reliant on federal funding and approval, and focused specifically on Medicaid. You'll hear more about the waiver later today by Dr. Clara Felice, CMO of MassHealth. We're also fortunate to have one of the strongest data infrastructures in the country and organizations that collect and analyze data that help us do our job and help guide improvements to our state's policies and programs, including the Department of Public Health, the Center for Health Information and Analysis, the Health Policy Commission, the Institute of Health Equity Research, Evaluation, and Policy, and Massachusetts Health Quality Partners. This data infrastructure is a critical foundation for health equity because, as we all know, we cannot fix what we don't measure. We also have important investments happening in the state, including the AHIM initiative I mentioned earlier, that is place-based, community-led solutions in 30 communities across the state. You'll hear more about AHIM from the Commissioner of the Department of Public Health, or the Commissioner, Robbie Goldstein, later today, about AHIM and how the Department of Public Health is meeting the moment. There are many more great efforts underway, too many to list, and their impact multiplies when they're intentionally connected and coordinated towards the same goals. The Health Equity Compact is calling for something bold and concrete, a shared statewide commitment to measurable health equity benchmarks, specific, trackable, measurable goals to reach meaningful health outcomes over a certain defined time. This is not a new idea. Health equity benchmarks have been recommended by the state's COVID task force, the Health Policy Commission, and the Attorney General's office. It's time we move from recommendations to solutions in action. Compact members and partners have been working together to develop a starting framework for statewide health equity benchmarks, and I'd like to give special thanks to my fellow Compact members leading this work, Juan Fernando Lopera, Cheryl Clark, Guale Valdez, Izzy Lopes, and Monica Burrell. We'll be sharing some initial high-level goals as a starting point to get the conversation going. This framework is about setting the course now for where we want to be by 2050. It's a vision for what we want health to look like in Massachusetts, one that helps us keep our eye on that North Star by pairing bold, long-term goals with a clear, achievable path forward. Our draft framework proposes 2 ambitious, measurable goals. Number 1, save lives by reducing premature deaths. Number 2, advancing shared prosperity by reducing the economic burden of health inequities. These goals are designed to benefit everyone across Massachusetts and to close the gaps in racial, ethnic, and geographic disparities in our state. They build on and align with major efforts already underway, including AHIM. To reach these goals, we propose a focus on 4 primary drivers of premature mortality, health disparities, and economic burden. Those are, and will not come as a surprise to those in the room, cardiometabolic disease, maternal and perinatal health, mental health and substance use disorder, and cancer. These priority areas would help align and anchor measurable, focused action across the state, including the root causes of health inequities. Setting bold, shared goals across public and private sectors is the first part of the framework. We need to set clear, ambitious targets that define what success looks like, what we're all collectively working towards. But second, we need a measurement framework that lifts up the key changes we want to see in the short and medium term. This includes process metrics that show how we're getting there and shared responsibilities so we all know what role we play and how progress will be tracked. And keep in mind, as Michael said earlier, we all have a role to play. Third, we need an implementation structure, the system for accountability, coordination, improvement support, evaluation, and financing to ensure this work doesn't sit on a shelf and to ensure that it moves. The Health Equity Compact's bill, an act to advance health equity, outlines a path to build this framework. It proposes creating a time-limited legislative commission to define these elements and make them real. But we don't have to wait for the legislation to pass. No one loses sleep or doesn't get more gray hair by waiting for any legislation to pass. This initial framework we've shared with you is intended to get the conversation going, and the Compact wants to jumpstart this work with all of you here today. We know we cannot solve systemic challenges in silos. That is why we're inviting all of you, state leaders, healthcare systems, CBOs, the private sector, researchers, policymakers, and communities to join us. We need your support to pass an act to advance health equity, including the new provision on health equity benchmarks. And today, we are calling for public sector leaders in partnership with all of us here today to jumpstart the development of health equity benchmarks. We have seen what's possible. With COVID, we witnessed the power of that shared purpose. We saw successes when we put away our biases, when we put away that tendency to think of turfs and geographies or ownership of communities. No one owns a community. We witnessed the power of that collectiveness, the shared purpose, data transparency, and collective action that leveraged all of the strengths of being in Massachusetts, that spirit of urgency, innovation, and collaboration that literally helped save lives. We were all, I can tell you, I was bitten by that bug and want to see so much more of that. We may have lost some of that muscle in recent weeks and months, but imagine what we could do if we strengthen it again with intention. Just imagine the thousands of lives saved, the billions of dollars in economic benefit, the dignity and justice restored to communities who have waited way too long. This is not easy work. It will be harder now, especially in this moment, but it is also full of hope because together we have the power not just to respond to crises, but to redefine the future of Massachusetts. Thank you. And with that, I'd like to welcome the panelists of our next panel up to the stage. Each of them brings a unique perspective from a different sector, and together they'll help us explore what it would mean, what does it look like to implement health equity benchmarks. And to guide the conversation, I'm so pleased to introduce our moderator, my colleague, fellow Compact member and friend, Dr. Bisola Ojikutu. Dr. Ojikutu is the Executive Director of the Boston Public Health Commission and the Commissioner of Public Health for the City of Boston. Dr. Ojikutu, over to you.
Sure. Okay. Hi. Okay, thank you all so much. Hi. Okay, good morning, everyone.
Good morning.
It's so wonderful to see so many of you out here today, and I want to thank Dr. Tavares again for that insightful presentation. Just to be honest with you, oftentimes talking about data is not that exciting. I just keep it real, right? But we're talking about more than numbers. We're talking about more than data. We're talking about shared vision. We're talking about collective action. And that's what Michael said. That's what all the speakers have said. So that's what we're here to do today. Many speakers have said that health equity, it's our North Star. Well, these benchmarks, the data, the numbers, this is how we make that North Star real. We make it tangible. We make it measurable. And we need things to guide clarity, especially in this time of uncertainty and even chaos. So We have a wonderful panel here today. We have amazing leaders. I'm going to introduce them, and then we're going to dive into the discussion. But I do want to encourage you to ask questions using the platform throughout. We will have time for questions, and I think that, you know, questions, discussion, that's what's going to motivate and catalyze our collective action. So, all right, to our panelists. So we have Juan Fernando Lopera, who's our Chief Diversity, Equity, Inclusion Officer at Beth Israel Lahey. He's also a founding member of the Health Equity Compact. So welcome, Juan. We also have Dr. Sandhya Rao, who is the Chief Medical Officer and the Senior Vice President for Blue Cross Blue Shield of Massachusetts. And we also have Lauren Peters, who's the Executive Director of CHIA, the Center for Health Information and Analysis. And last but certainly not least, we have Audrey Shelto, who's the President and CEO of Blue Cross Blue Shield of Massachusetts Foundation. Okay, so welcome panelists. You know, throughout this morning, we've heard about how lucky we are as a state. And I think that that's very true. We are incredibly lucky to have elected leaders who are doing amazing work. But we also have extraordinary institutions that have really taken the charge, that have really looked at health equity and said, we are going to do this work, and we're going to keep doing it, even in light of what's happening at the federal level. So what I'd like each of you to do is talk about the health equity work that you're doing, and give us a sense of what that's been like and what some of the challenges have been, and then we'll get into benchmarks. So why don't we start with you, Juan?
Great. All right. This works. Well, thank you. Thanks, everyone. I first want to just take in this moment. I know the governor asked us to look behind us, the beautiful view, but what a beautiful view that you get to see from here with this incredible crowd. And just to reflect, too, on the affirmation that the governor gave us about doing this work. This is the right work to do. We need to do it now. I think the compact was created for this moment. It came after COVID, but it was created for this particular moment to continue the work, because this is the right work. So thank you all for being here, being committed to the work. As a founding member of the compact, when I joined, this weekend will be 4 years since I joined Beth Israel Lahey Health. And when I joined Beth Israel Lahey Health, after COVID and after the summer of 2020, we knew that the work around equity needed to go well beyond the four walls of any one institution. And that's when I reached out to Mike Curry, Jeff Sanchez, Manny Lopes, and what is now 85 plus compact members. So the personal and the organizational commitment that each of us brings is where it all starts. Now, each of us at our respective organizations are advancing the work. We've spent the last several years building the infrastructure at Beth Israel Lahey Health, where we have we serve 1.7 million patients. We have 36,000 employees in 14 hospitals across Massachusetts and in eastern New Hampshire. The work, you can only imagine what it takes to do this work, right? So we built quite a robust infrastructure around health equity. We first knew we needed to understand health disparities, and we did that. As a relatively new system, only 6 years in the making, we had the opportunity to do it right from the beginning, and we rolled out electronic medical record across all of our hospitals, Epic. And in doing so, being able to embed equity into how we design the system to then be able to measure health disparities. But you can't just look at the North Star and stare at the problem. Like, you actually have to do the work. You have to hire the resources, and and many of the resources we've hired are volunteering today. They're here in the room, our health equity program managers. And our community team is also here. So you have to be willing to invest in the resources. So I'm proud that we have done that at Beth Israel Lahey Health. And then beyond that, you then have to have the right interventions, and you're never going to get it right. So you have to continue to innovate around those interventions. And the work, as LT mentioned earlier and shared the data, we know where to go to solve for these problems. We know the communities that are most impacted. So a place-based approach is key to doing the work and doing it in the community with the community. So that's part of what we've done in bringing resources that often were not provided in those communities like Chelsea, as LT mentioned, in communities like Roxbury, in Worcester, Springfield, you name it. So I'm excited that the Commonwealth has now laid out our communities of focus through the Advancing Health Equity in Massachusetts initiative. We know the 10 regions, the 30 zip codes. So the platform has been created. We've also been working closely, as everyone has, on the Medicaid 1115 waiver. The Joint Commission, with its health equity certification, has provided a great platform. But I'll be honest, we are all still in the infancy stage of this work, and we're all kind of working in our respective institutional silos. So the compact is really here to say, especially through this benchmark framework, to say now is the time to bring it all together. We've all learned enough over the past few years. Let's build it together, and the framework that we're presenting to you today is that initial platform to say, great that we're all creating these pilots and we're all advancing the work independently. Let's all come together and have the sustainable, scalable impact that we need to have, because it is 146,877 lives that we could have saved if we were more focused on this work.
Thank you, Juan. Cynthia.
Yeah, well, hi, everybody. I also wish you all could be up on the stage to feel the energy that you give, and I want to thank everyone, especially you, Michael, for such inspiring comments. I personally am getting a lot of needed positive energy in such a challenging moment. Let's talk about benchmarks and why we at Blue Cross are so pumped about the idea of a statewide benchmark. And that's because we have seen through our work the power of bringing data to this problem. We have a three-pronged strategy. All of it centers on the use of data to measure and be very transparent about the inequities and disparities we see across the population we're accountable for. And we've seen results from a multi-year program that frankly have exceeded our expectations, and I think really say that data is a powerful tool to shining an objective light on this problem and for motivating and inspiring a lot of change. So we've done three things. The first was we looked at our data. All health plans are required by a set of regulations to measure a long list of quality measures. They're all familiar to you: chronic disease measures, preventive care measures, et cetera. And so for many years, we've been measuring that at the population level. What we did is looked at at each of those measures across a set of populations, and we now, if you can look publicly at our performance on those measures across groups, and we see differences. And so that was the first step for us to take accountability and be transparent about the differences we see, the disparities in performance on those quality measures, and to take accountability for those by being very transparent about them. That was step one. Step two was to use those data points to collaborate with our partners in the provider and community. And so for each of our provider systems, we created that same data set for our partners like BILH to empower you all to be able to work with those data. And then we built on our existing payment model to create incentives and financial structures to reward and create a business case, frankly, for leaders like Juan to be able to say there's a way for us to fund the types of interventions we need. And I'm curious if you would say that that's been productive. And then finally was infrastructure and a community of bringing providers together to talk about what we're learning across that exercise. And I would say that last piece is what has been so inspiring to me. There are a lot of reasons for groups of us across the healthcare ecosystem to focus on our differences, health plans, providers, often across on other sides of the table. But what I've seen with the power of this data is a real coming together and alignment on this problem.
Thank you. And I first want to start by thanking the Health Equity Compact for putting on this amazing event and for the opportunity to be up here today. For those of you who are less familiar, the Center for Health Information and Analysis, affectionately known as CHIA, is an independent state agency, and our mission is really to advance a more transparent and equitable healthcare system through data and objective reporting. Core to our mission, we look to embed an equity lens in all of the work that we do. So where possible, we're stratifying our data by race, ethnicity, geography, to ensure that disparities that we see are not masked by medians and averages that we're often reporting out. So in terms of what she is doing right now, to amplify a lot of this data stratification, just last week we released our first ever health equity dashboard, which really centralizes our data, our analysis, looking at differences across racial, ethnic, geographic lines, across key measures, utilization, access, coverage. We also are supporting a number of initiatives that some of which have been mentioned earlier today. We're supporting Mass Health in the implementation of their 1115 waiver through data infrastructure. We're supporting EOHHS's AHEM initiative. We're supporting the Quality Measure Alignment Task Force through data standardization. And finally, we are doing a lot in the primary care space to advance and put out data information to advance policies and interventions.
Good morning, everyone. It's great to see you all. And thanks very much for the Compact for putting on the event and for inviting me to be here. The Blue Cross Blue Shield of Massachusetts Foundation has been around for 24 years now, which is kind of hard to believe, especially because we spent so many of the early years here in this very room in sessions like this, making significant strides and ultimately getting to near universal coverage in Massachusetts. So I would say from the very beginning of the foundation's work, we had a focus on cultural competency, racial and ethnic disparities. We had grant programs in those areas, as well as a lot of other areas. So it was really about 5 years ago, like so many other organizations, where we felt like we really needed to have a much more intentional, comprehensive approach to work around structural racism and racial inequities in health. So we started that work, as we often do, with trying to figure out what's already out there. You know, what do we know about these disparities? So we collected all sorts of information from national sources about Massachusetts locally to find out what do we know about racial disparities in healthcare access, quality, and outcomes. There were a lot of gaps in the data, as probably none of you would be surprised, and that's an issue that we will be addressing by moving forward with the idea of a benchmark and collecting more data. But we knew enough to know we had a crisis in terms of disparities, so that the gaps in the data did not stop us from moving forward. At the same time, we went out and did a lot of focus groups in the community to try to really understand what's the right role for the Blue Cross Blue Shield Foundation in this. You know, in this issue of disparities and structural racism, what role can we play that will add value? And what we heard loud and clear was that if we could support capacity building so that we could get more people of color-led organizations at the tables when discussions and policy decisions are being made. And I recognized in hearing that input that really wasn't so much the case with healthcare reform. So we're really excited that back then to start a grant program called Racial Justice in Health, through which we funded the opportunity of many people-led organizations who do advocacy in other areas but are interested in working on healthcare advocacy to develop those skills and relationships. We then did some work that several people have referenced earlier, which is partner with the Health Equity Compact to really try to figure out, you know, how can we provide a sort of business case like we did with healthcare reform? How can we define a sort of a business case, or what's the economic cost of racial and ethnic disparities in Massachusetts, and produced the report that was referenced several times earlier. And then I would say in terms of our more recent work, we did a Health Equity Action Plan. Again, bringing it to the Health Equity Compact and rolling out some next steps from that, where we really tried to envision, by talking to many of you in the community, what would an equitable healthcare system look like in Massachusetts? And what would be the critical components for that system? So there's a lot of work on that in terms of the different areas of components. With what we realized was there's so much work going on in Massachusetts, as many people have referenced. But as several have often referenced, if not all, it's very siloed. So again, asking how we could add value, people said, can you just pull together, like, what is everyone doing? So we did create this inventory that's available on our website that is organized by the different components in the action plan that lays out for every organization that we could find or that came forward to us, what are they working on? What's the goal? What's the clinical area they're focusing on? What's the population they're focusing on? Do they or do they not yet have measurements? And that is available now. It's over 100 organizations and initiatives, I should say initiatives, that I think we can all build on as we move forward with this benchmark initiative, which I'm really excited about. So lastly, I would say Blue Cross Blue Shield of Mass Foundation was one of the two first foundations, along with Atrius Health Foundation, to participate in the AHAM initiative with the state. So we are focusing on the area of Chicopee, Massachusetts, with our partner, the Public Health Institute of Western Mass, which we're really excited about. And lastly, recognizing the really significant disparities and inequities in perinatal health. We're launching a grant program just announced a couple days ago around eliminating disparities in perinatal health. So that's what we've been doing so far.
No, that's great. Thank you, Audrey, and thanks to all of our panelists. What I heard is that each one of you within your institutions and outside of your institutional walls are doing really incredible work to promote health equity, really intentional, deep investments. I think one of the challenges, though, and I'm a public health person, public health leader, so I'm thinking big picture, and we think about benchmarks and how do we really close gaps? How do we really close the gap in life expectancy? How do we really decrease infant mortality? How do we really do the big things for large populations? How can benchmarks help? Will they help us collaborate better? Because I think that's the key word. We can't get to collective action unless we're collaborating. And I know that, data is a challenge to collaborate over. Data sharing, when we start talking about data amongst institutions, I know we've had challenges with that. So I'd love to hear your thoughts. How can benchmarks help? Do you want to start, Juan?
Sure. I mean, I would ask us to think about other very significant aspects of health reform that we've taken on. And all of it starts with the ability to benchmark. Universal coverage was easier to benchmark because you can measure a single number, how many people are, what percentage of our Commonwealth is insured. And we are, by focusing on that as part of that first chapter of health reform, we are able to become now the highest insured state in the country. Now, of course, there's gaps if you stratify that data by community, so there's still plenty of opportunity there. Cost containment, similarly, we now have the ability to measure the cost of healthcare, the total cost of healthcare, and we still have a long ways to go there too, but now we have everyone focused on that. Health equity has been elusive to all of us. We can stratify data, take existing quality measures, and understand disparities, great, but is somewhat amorphous, and no one can sort of get their arms around it. And what we're trying to do is the same thing that we've done for other aspects of health reform, is say, okay, let's all agree on a way to measure it. Let's all take shared responsibility for improving upon that, especially now. If we don't benchmark it now, if we don't baseline where we are now, you can only imagine what it's going to look like in the years to come with the attacks on Medicaid and the like. So, and it is about lives, individual lives at the end of the day. Although that moral imperative, unfortunately, has not moved the dial, we also equally need to be able to have the economic case for their work. 5.9 billion connected to the 146,000 people who died prematurely. We all have our own individual stories. Through the pandemic, there were 4 family members who passed away on both sides of the family, and all had one of those pre-existing conditions that were up there on that framework. We We can do this. But it takes intentionality, it takes shared responsibility. We've done this before in other aspects of reform, so we need the health equity benchmarks to do that now.
Thank you, Juan. Cynthia?
I agree with everything Juan said, and I'll just add a couple practical points. Even setting aside, if you can, the current political climate, the system is very strained on all sides. We're dealing with provider systems and plan to have resource scarcity. So I think at this moment to set a benchmark states a priority, maintains a priority when leaders in this room and outside have so many things on their plate. There's also two other practical aspects, which is when a health plan like ours issues a quality program, providers are having to reconcile different measure definitions and things like that, so it adds some burden. So there's a benefit of harmonization, very practical thing, for providers and other entities who are receiving these measures. So that's one practical benefit from coming together. And then there's a lot of learning that could happen from the power of collective data, having the same measure and being able to have more data points. So I think there are some real practical wins with setting a statewide benchmark.
Absolutely. Thank you. Lauren?
Sure. So just to echo some of the comments from Juan, the Massachusetts healthcare ecosystem really has a long history of collaboration and public-private partnership that has demonstrated the success of what happens when we collaborate, all come together, and steer energies, our strengths, and resources towards one unified goal. We saw this in 2006 with health reform attaining near universal coverage. We saw this again in 2012 with the cost containment benchmark. And while we can sort of sit and debate whether the benchmark is too high or too low, the very establishment of a benchmark has brought the issues of cost containment, affordability to the front and center of the industry, that across the industry, whether you're a payer or provider, everybody's working towards. In my mind, that is the power of a benchmark and why we need to build on these precedents to address health disparities, because addressing them really is bigger than just one agency, organization, or initiative.
Audrey?
I think having a benchmark, whether it's the discrepancy in and disparity in life expectancy, which we've all been using as a very good example of a benchmark, I think that would be incredibly inspiring and motivating for all of us and make our messaging easier. So what I mean by inspiring and motivating is, all across the Commonwealth, people are working on issues of disparities that matter most for their communities. There's data that is supporting that, and it's also emotional. It's also felt like this is what I feel in my community. This is what's hurting the most. And I think it's important to be true to that and allow people and enable and encourage communities to work on what matters most to them. So this concept of sub-goals that all lead up to that mega goal of getting to better life expectancies is really, really important, I think. And I think that I lost my train of thought for a minute. The other issue is I think that recognizing that in addition to communities wanting to focus on different things, but all leading up to that major goal, each sector, each of us has something different to contribute. The government sector has a lot to contribute, the provider organizations, the health plans, through payment incentives, et cetera. And for philanthropy, having an overarching goal like that with sub-goals under it would allow us in our sector, across each other, with each other, to figure out where can we partner and where can we contribute to have bigger impact. Because I know sometimes it feels like, those foundations have tons of money, but when you look at what each of us has compared to like government spending, it's not that much, but we can use that money so much more flexibly, and we can do things so much more quickly and nimbly than government can, that if we're all working together and really talking among all of ourselves about, what's the role that each one of us can play. So what can foundations do? What can government do? What can plans and providers and other organizations do? I just think having that benchmark is really unifying, and we all have the message that that's what we're working towards.
I love that, Audrey. I think that was a really incredibly important point. What can we each do to contribute to these end goals, to this benchmark? So how do we move forward in this context, given what's happening federally, given what's happening nationally? Why is this particularly important now? Or is it? To be quite honest with you, I think this is a really great question because oftentimes, we don't situate ourselves in the moment, and I really think that this issue of health equity, just a few months ago, probably a few weeks ago, and people are still doing this now, people are scrubbing their websites and getting rid of the terms health equity, and they're not talking about this anymore. So why are benchmarks important for us in this room right now? Juan, would you like to go first? I might ask all of you all this question, but Juan.
Yeah, I mean, I'll go back to the why now being that we are, unless we understand where we are now through a benchmark, we are likely to see regression instead of progress, despite all the great work that's gone into getting us to this point. We've had unprecedented level of investments in health equity. If you think about, again, the 1115 waiver, there's $2 billion over 5 years of that program. We also know that deep-rooted, long-standing disparities will take longer than 5 years, and that's the time that we have with the current waiver. And as it gets renegotiated, starting next year for 2027, what's going to happen to those health equity incentives as there's the negotiation at the federal level. So the benchmarks will allow us to assess where we are now, see the impact of what's happening to us, and continue to bring the attention in a easily understandable way, because who can disagree with saving lives? Who can also disagree with the $5.9 billion economic value of saving those lives? So I think is incredibly important now more than ever.
Absolutely. Audrey?
Yeah, I was thinking a lot about this question because it is challenging to think about with everything else that's going on. And I sort of ended up, I think, on where you just ended, which is that I think it's more critical now than ever. We are facing such incredible existential threats to the funding and policies related to our healthcare system and other components of what keeps people healthy and living good lives. And I think it would, I reflect back on what the governor said this morning about, I don't want to go to jail, but I don't want to take my foot off the pedal. And I really think she was right in saying, do not take your foot off the gas pedal. I tried to find ways of thinking, how does this work align with anything the federal government's saying? And I wasn't able really to find anything. So I had to go back and say, well, I'm going to go back to what I know is right. And it sort of, again, reminded me, the governor really resonated with me when she was saying that we know that it is not right that a certain group of people in Massachusetts don't have the same life expectancy as other people. That's just not right. So we would never, in any context, having a goal to try to eliminate that just feels like it's really, really important to remind us not to take our foot off the pedal, and that there are a lot of ways that we can do work of all different sorts to get to that North Star.
Absolutely. Sandia, do you want to add anything to that one, or no? You guys are okay? Okay. So we have a little bit of time before we're going to move to audience questions. And I just wanted to add that in the midst of this chaos that we are undergoing, what I've found most often when I've talked to audiences is a sense of almost paralysis, like people are not necessarily moving forward. And I think with these benchmarks, I think one of the things that it does is it catalyzes action, because you have a target, you have something that you're supposed to be moving towards, and everybody's watching each other, who's moving towards it. So that's almost an act of resistance in and of itself in the midst of, uncertainty and some of the chaos. So just wanted to add I know I'm not, on the panel, but I just wanted to add my piece there. Okay, so why don't we open it up to audience questions? So are we taking them online? I would love to just take them in. Is it okay to take them in the audience? You're not sure? Okay.
I'm just going to read audience questions that have been coming in through Mentimeter.
Oh, okay. We'll come back to you.
So the first question for our panelists, what's next for health equity benchmarks? How do we actually work together to make this a reality?
Juan, would you like to?
Yeah, so we are pursuing the compact. We're pursuing multiple avenues to get to those benchmarks. It is a provision within the Act to Advance Health Equity. It's part of the compact strategic plan, and is one of those critical provisions in the bill. Now we know a bill can take time, so we're not going to wait. We're going to continue to pursue other avenues as well. Whether there's a way to work with the administration to establish a commission immediately to advance the framework beyond a framework to actually make it a reality. And then I think is an open invitation to all of us in this room today to say, let's be part of that journey together. Let's bring your expertise into a task force, a commission, whatever you want to call it. We've laid out the framework. Now we have to establish it. I know the Health Policy Commission, CHIA, that's a stated goal to have these benchmarks established. So we look forward to public-private partnerships in making this possible. So there's a way to do it. I think today we're launching the framework, but I think there's ways of getting it done. We want to get it done with urgency because we know those numbers, the number of premature deaths is only unfortunately going to accelerate unless we act with urgency.
Absolutely. Thank you, Juan. Do we have another question online?
We do.
Okay.
How can health equity benchmarks drive more equitable resource allocation to services and communities that need it most, like reimbursement levels across different types of providers for the same services, for example?
Who would like to weigh in? Audrey?
Yeah, I mean, I should have listened more carefully. I think I wasn't thinking this one was for me, but that's okay. I think that this what came to mind for me was when we were beginning to do the AHAM work, and thinking about the communities that the state had identified as being, having disproportionate inequities. And I was thinking about, I'm dying to see like the data for that community. Like I want to see more about the disparities in that community and understand more about what the assets are, what's available in the community too, because then I think you can get to, okay, so what kind of investments need to be made in this community? How much of it can be done through the insurance system and the payment system because it's a provider issue? How much of it needs to be done directly into the community because it's really more of a community empowerment issue and social determinants of health type issues? So I do think that having the benchmark and being able to then break it down by different parts of the state would enable us to think differently about resource allocation.
Anyone else want to weigh in? Are we good? Okay. Another audience question?
Give the mic to the front.
Another question?
Yes, please.
Thank you.
Grab the mic. We have limited mic.
Thank you so much. This is an act of, my question is very simple. What is the feasibility of a multi-sector adoption of these benchmarks? And this is what I mean by this. I wanted to qualify what I'm asking. I sit in the Public Health Council. Every year we get millions of dollars of proposals of investments that hospitals will be doing in their communities. But none of them are part of this larger North Star vision that each of you can, or each of us can impact in various ways. So as payers, funders, hospitals, I think that the missing piece here will be state government. How feasible is it that we all agree to follow the North Star and contribute our individual pieces to that collective vision in, say, 10 years?
Yes, I love that question. Anyone want to take it? Lauren?
So I would say that is the very reason we're here today. I think this panel, if there's one takeaway, is that it is absolutely feasible. And the reason I say that is that there is precedent for public-private partnership to address some of these really thorny, difficult issues. Let's take the Quality Alignment Measure Task Force. That is an organization that set out to address two goals: reduce administrative burden and to really focus and prioritize a subset of quality improvement areas. Over the last the last couple of years, that group has identified a measure set that payers, providers are adopting in their contracts. As mentioned earlier, we've taken the next step to stratify that data by race, ethnicity, and other demographic data. So there is precedent for public and private sector coming together to, again, tackle these issues. I think the key ingredients to any of these benchmarks is around having the data foundation, having transparency, accountability, and being able to measure progress year over year.
I had one more
Go ahead,
thing.
Audrey.
I think, Lisette, you hit a nail on the head that I've been thinking about too. Is that the right way to say it? I think, there's also been a lot of discussion recently, not as long as the Compact's been doing this work, around state health planning. And I think what you were referring to is there are a lot of existing tools and processes that relate to state health planning. Without getting into all the details of those, I do think these two initiatives are going to have to come together because we don't have good alignment now between what our healthcare delivery system is providing and I won't say we have terrible alignment. I'm saying we don't have great alignment between what our delivery system has the capacity to provide and what our communities need. So I think in order to reach this North Star, it's going to have to include that sort of stream of state health planning so that we really go back to the previous person's question about how do we align resource allocation in such a way that it both meets the needs of communities across the Commonwealth and helps us reach that North Star.
Absolutely, Audrey. I appreciate that. And you did hit the nail on the head, I think, with that question. Because what it also, to me, speaks to is bringing other people to the table. When we think about social determinants of health and how we actually get to the North Star, we're going to actually need other people, not just our healthcare institutions, which are doing wonderful work and doing work outside of their walls in many ways, as you've heard some of our panelists describe, but the other folks need to be in the room too, and how feasible is it for us all to be looking at similar benchmarks? I think that's really part of what I think the Health Equity Compact is also thinking about. Yes, please.
And the compact itself and you're one of our members, the incredible expertise, the lived experience that we bring, that was the reason the compact came together, is a lot of the changes to the healthcare system we've seen in Massachusetts have happened to us. They've been great things that have happened, but they haven't included us as much at the table. And the compact is there to bring our positions of influence, our lived experience to say, we are part of the community, and now we don't speak for all communities, so we need to bring more voices, but we are critical voices in advancing this work. So the compact is there for that reason.
Absolutely. Do we have another question online?
We have one last question that we have time for. So building on the last comment around social determinants of health from our moderator, to reach the high-level goals proposed by the compact related to life expectancy and decreasing premature deaths and decreasing the economic costs of inequities, we would need to address social determinants of health and economic mobility even more than healthcare, or just as much. How do social determinants of health fit into the development and implementation of health equity benchmarks?
Juan, I know you have been very much so a part of the framework development, so do you want to take a stab at that one?
Yeah, so the framework itself, especially as we call out the need to align with the AHAM initiative, focuses on the places that experience the highest inequities. There's no way that we can address issues around cardiometabolic disease, mental health, behavioral health, and cancer issues and maternal health issues without actually going to the community and working with the community and addressing those upstream social determinants of health issues. So that needs to be definitely part of the type of investments that we make, and we're seeing some of those investments in some of those communities already. The investments have to be with community organizations that know their community best. And then the framework itself will allow us to then measure the impact of all those things. There's a lot that the systems need to do to improve how we provide care, but that, as we know, is only 20% of the equation. So 80% of our efforts need to be focused on addressing those issues. We, through the 1115 waiver, the Joint Commission work, systems now are doing a much better job than ever before in screening for social risk factors. And I think we will have much better ability, especially when you start to introduce new technologies to better understand the needs of community and match people with resources than we ever have. Honestly, we've used race, ethnicity as an initial proxy to understand health disparities, but it goes way deeper than that. With better social determinants of health screening, we can now say, okay, what are the outcomes for people who are food insecure, housing insecure? And then it just so happens that I think we're going to find the majority of those communities of color. But I think we'll have a better sense for how to address these issues with better screening for social determinants of health and investing in those communities that have been prioritized based on the great work of the state.
Absolutely. Thank you, Juan, and thanks to all our panelists. We're at time. I did want to end by saying that we talk about a call to action, but we really need next steps. You know, what is it that you're going to do when you leave this room? I think, one, we need to support and act to advance health equity. Okay, we all need to do that. Okay. I think two, we all need to be working with the Health Equity Compact as we think through the benchmarks and the benchmarking framework, because this is the information that you're going to take back to the table when you go back to your institutions and think about, how do we fit in here? How do we work better together? How do we collaborate to get to this North Star? So I think those are things, big things, but they're all things that we can think about throughout the course of the rest of the day and take home with you when you leave. Thank you to all of our panelists again. Thank you all for being here.
Thank you to our great moderator.
Right. If you give me 1 second to fix this so I can face you all. Okay. All right, everyone. Promise we will have some breaks, but thank you for the excellent panel. Thank you for the presentation. A few things that I just want to reflect on the questions that were asked, particularly around cross-sector benchmarking and the need for us to get better at that. I think that's a really key, important thing that we all should be striving for in order to understand how our approaches are affecting public health measures, housing measures, but I think it was also mentioned that transparency is incredibly key for all those things. And I think I also wanted to mention a little bit about the question around social determinants of health and how we're getting better around gathering data to ensure that we understand the impact of social determinants on our patients. And I think one of the things that I think when I hear that is we also need to, not only are we getting better at screening and understanding the needs of our patients, but we need to understand the impact of what community health workers do, right? What impact they actually have on the health outcomes, and really ensure that we are also tracking that and creating benchmarks so that we can learn how to improve and, as Audrey said, invest in it. So thank you, amazing panel for that. I'm here to also introduce our next session. So in this section, we're spotlighting what it looks like to invest in community-led solutions that advance both health and economic opportunity, the very goals at the heart of the benchmark framework we just shared. Initiatives like the Healing Administration's AHIM strategy and the proposed Health Equity Zones Fund and Act to Advance Health Equity are designed to support this kind of place-based investment. We need to sustain and spread the progress underway in communities across the state, like the cross-sector partnerships we just heard about in Boston and Chicopee, supported by the Atrius Health Foundation and the Blue Cross Foundation, and efforts like Takeda's partnership with Partners in Health to support a community health worker-centered community health improvement strategy in New Bedford. Now we're excited for leaders from Brockton's Hometown Healthcare Academy. They're an inspiring example of what's possible when we invest in community-driven partnerships in places prioritized by the AHIM framework. I'd like to introduce my friend and the moderator for this session, Dr. Maria Celli, the Chief Executive Officer at Brockton Neighborhood Health Center. Maria has been with Brockton Neighborhood Health Center for almost 10 years and recently began working on Brockton's Hometown Healthcare Academy alongside our panelists here. Welcome, Maria, and welcome, panelists. Thank you for being here.
All right, this is on. Good afternoon, everybody. Thank you, or morning still, everybody. Thank you so much, Carlos. And thank you to the Health Equity Compact for this incredible day. I realize that we are the panel that is holding all of you before lunch, but I am 100% confident that you will feel so nourished by this panel that you may not even want to go have lunch. I guarantee it. I can almost guarantee it. So yes, my name is Maria Celli. I am the CEO of Brockton Neighborhood Health Center. And I am honored and humbled to be in this wonderful event and to serve as the moderator for this incredible panel. And I'm going to let them introduce themselves briefly. Take it away, Laritza.
Hi, everybody. My name's Laritza Perez. I am the program manager, and I have been with Brockton Neighborhood Health Center for 13 years.
All right. Well, bon dia, everyone. My name is Marissa Rodriguez. I am the youth healthcare program coordinator. Geez, I keep doing that. And I am also a representative of the Cape Verdean Association of Brockton, Inc. And thank you. And I've worked things all health related for over 10 years there.
Good morning, everyone. I'm honored to be here with you guys. My name is Belinda Cesar. I'm also a youth healthcare program coordinator with the Hometown Healthcare Academy, and I'm the representative from Haitian Community Partners Foundation in Brockton.
Good morning, everyone. My name is Berlin Tashina Pierre-Louis. I'm a recent graduate at Brockton High School, and a member of the Hometown Health Academy.
So we have mentioned Hometown Healthcare Academy a few times. This is the program that we are highlighting today in this panel. So I would love the panelists, and we've practiced this, so I'd love the panelists to describe a little bit about Hometown Healthcare Academy, how it came to be, and why it was developed. And Laritza, I'm going to give this question to you first.
Okay. The Hometown Healthcare Academy is a program generously funded by the Atrius Health Equity Foundation. It is a collaborative between 3 community organizations: Brockton Neighborhood Health Center, Cape Verdean Association, Haitian Community Partners. And basically, when I got this role, I told my team that we're a team basically at this. This is a democracy, is not a dictatorship. So I'm not their boss. I'm literally their teammate. So we're one voice, one sound. We're one team together. And it's basically made up of 4 pillars. So the first one would be the Youth Health Advisory Council. It is basically made up of 12 students from 9th to 12th grade, where we amplify the student voices to address critical health issues that inspires the peers. So basically for them, by them, they come up with different healthcare topics that matter to them. And based on those healthcare topics that matter to them, they come up with different events in the community to execute the healthcare topics that they were concerned about. Then we have the general health education sessions. These are usually, they're open to their community, which would be all Brockton High students. And there we basically amplify all the different topics that they wanted to know about, as far as like advocacy. We've had some for mental health, skincare, nutrition, entrepreneurship, and leadership. We also have the Career Step program. That's only for our seniors. There they have a didactic portion where they do their online training. And then the hands-on portion is usually done by me alongside with other clinical staff at Brockton Neighborhood Health Center. And we have 6 seniors so far. And then we have the youth and family mentorship. And it's basically like, how do we help the parents help the youth to be successful in our program? And that could look any way. It could look as housing, legal help, food support, and any other forms that we can help the parents support the child be successful in the program.
Excellent. Belinda and Marissa and Berlin, anything else that you'd like to add in describing the entirety of the Hometown Healthcare Academy?
Yeah, I'd like to go. Thank you, Maria. I would just like to say that I think this partnership works so beautifully because we're focused on the pillars of Hometown Healthcare Academy. More specifically with the YAC, it's a program that's focused on service learning, where students are incorporating community service, academic integration, and reflection into each and every project that they do. Not only that, we've empowered our students to be relentless advocates for themselves, their peers, and their community. So within the YAC itself, they've each taken on a strong role where it's defined council roles for each of our 12 students. Additionally, the Career Step is the other part of our program where we focused on diversity and inclusivity to kind of give these students an introduction to different career path programs and also support them with various resources while they explored what healthcare fields they might be interested in.
And I just wanted to add about the mentorship piece. So it doesn't just end with the YAC and Career Step. We become a part of these kids' lives. I feel like they reach out to us in our group meet chat in the evening, even if it's 10 o'clock at night, they're talking to us about something about their lives. And we also have a summer program that they also can go and work at, and some of them do their internships as a part of that too. So it's like we're a year-round thing. It doesn't just end with each program. It's an ongoing effort, a connection with these parents and these families, and building these bonds in this community.
Thank you so much. I do want to, I'm the moderator, but for a moment I'm just going to be a panelist, and I just want to highlight that. The word partnership, community, collaboration, connection, I dare say love, you know, that's alive in this program, which is part of what makes it so successful. And not on this stage, but another critical member of the leadership team for this program is Marlene Amedi, who is in the audience right now, who's the CEO and president of the Haitian Community Partners. Marlene, stand up for a second. Yes. Moises Rodriguez, who is the president and CEO of the Cape Verdean Association, was not able to be here today, but it was in clandestine 7 a.m. meetings that the three of us had, where we took what all three of us saw as needs individually within our organizations, and brought an idea to life. But it was really brought forth by by the 4 people in this room and the other youth who gave feedback to shape the program that we're describing today. So I did want to highlight Marlene, thank you. So what was the primary issue that motivated the creation of the Hometown Healthcare Academy? And what do you feel is the progress that you have made in addressing that issue? And I think I'll give that question to Marissa to get us started.
Thank you, Maria. We were motivated to address the need for the development of healthcare change agents of now, as well as healthcare leaders and providers of tomorrow that actually represent the community. This program cultivates our future healthcare providers, healthcare leaders, and even informed healthcare consumers now and in the future. It was also important to have a program that increases the cultural and community competency of all healthcare practitioners and leaders. This type of program pours back into the general community and to Brockton High School specifically. It's a way to ensure that Brockton High students and their families have access to healthcare education and workforce development without having to go to another school. Together, we are developing the next generation of healthcare leaders while pouring back into the city we call home. And I think we're doing a great job so far.
Beautiful. Anybody else want to add to that? Nobody can.
Drop the mic.
I think she dropped the mic. Okay, here we go, into the meat of the 3-course meal here. Okay, so what makes the Hometown Healthcare Academy so special is that community is the beating heart of this work. And you, the trifecta, Laritza, Marissa, Belinda, in Berlin, you know that this is the trifecta. You are so much of what brings the magic to making this program so successful. So everyone on this panel has deep roots in and cares deeply about Brockton. How has your life experience shaped your work in this program? And Belinda, I'm going to give that to you first. Thanks.
Thank you. If there's one thing I want to start that stands true for all of us, is that we recognize the need in our community. We all have been community members of Brockton for decades. We all live in the community and exist within it wholeheartedly. Me personally, I went to Brockton High School and I graduated from there. And I made the decision to continue my education and go to college, but I know there's many of my peers who did not have that same opportunity. Whether that was for financial reasons or others, they didn't have access. So I think this program specifically provides an opportunity for students to get another pathway to professional experience. More specifically, this program was designed by a staff from the community, and with these unique perspectives, we've designed it for any kind of student within Brockton. I know for myself personally, if this program had existed when I went to Brockton High School, I would have taken advantage of it.
Thank you so much. And who's next? Marissa? Laritza, take it away.
Okay. Unlike my counterparts here, I also did actually go to Brockton High School. Brockton is my home. I moved there when I was 6. I came from Puerto Rico. So only Puerto Rico and Brockton are my home. So I've been living there ever since. And unlike my counterparts, I didn't actually graduate from Brockton High School. I dropped out. I took the path less followed. So in this program, I honestly, since I was a troubled youth, I take whatever I wanted for myself during that time and I implement it into the program now. Not only that, am I an employee at BNHC? I am a patient there, and it's been my only provider since I've moved here from Puerto Rico. So I also know the aspects of it from a patient's point of view. And also, I have 3 children that attend Brockton High School, 2 that have already graduated. So as a mother, I am also concerned about this program and what happens to Brockton High School. So if this program would have been there when I was in school and I was going through what I was going through, I would definitely took advantage of it. The fact that I want parents to know that this is an option for their kids also in the Brockton community, that they don't have to go to Southeastern to get their kids into a career path, that that's also feasible in Brockton High School and for Brockton students, and to bring back students to Brockton High School, because a lot of things have happened where Brockton High has gotten bad rep in the media and things like that, but we have great students that, you know, we deal with on a regular basis. Like she said, they were hitting us up earlier, and telling us good luck. So I basically put into the program what I wanted for me as a troubled youth when I was going through that time. And I'm helping the kids go a better path than what I went through.
I just want to start by saying I love this team. This is honestly probably one of the jobs I enjoy more than all the jobs I've ever had. I'm just going to say that out loud. We really listen to each other. You can tell that we have such care when it comes to interacting with the youth, interacting with each other. Everyone's opinion matters, everyone's voice matters, and that's what makes it great. Growing up and working in Brockton, I've witnessed the challenges our community faces, especially when it comes to access to healthcare and education. I've spent over a decade in roles that put me face to face with those challenges as a case manager for DCF cases, a youth liaison for Cape Verdean Association of Brockton, and as an educator of the public school system. On top of that, navigating my own chronic illness has made health advocacy deeply personal to me. I know what it's like to feel unheard in medical spaces. So for me, this work is about creating the kind of community care I wish I had earlier, and empowering young people to use their voices to demand better systems. And what makes this vision of HHA, right here, work, is that it's not just one voice. It's a collective effort rooted in trust to improve our community. Thank you.
Wonderful. So, Ms. Berlin, the moment we've all been waiting for. What are some of the ways participating in Hometown Healthcare Academy has impacted your journey and your hopes for the future?
First, I would like to say that the Hometown Health Academy changed my life because I struggled with anxiety for a long time, and I'm not saying that it solved my anxiety right away, but it helped me find my voice. Before HHA, I didn't know how to speak up, not for myself and certainly not for others. But this program helped me find my voice that I didn't even know that I had. As the youth voice representative of the YAC program that Larissa mentioned early on, I grew so much. I never imagined that I'd be even standing here, or in this case, sitting here, in front of people speaking like this. But I'm here because of HHA. They believed in me, and they believe in myself. Through Career Step, which is the second program about medical assisting, I found a path forward, a dream of becoming a nurse in the future. HHA gave me direction, motivation, and support. They made sure we were cared for, our mental health, and they always check in on us. They weren't just a program, to be honest. They were like second moms, giving us advices. They were the kind who look out for us, lift us up, and make sure that we have what we needed, even if we didn't ask for it. That kind of love and care makes all the difference. People talk down on Brockton, and Brockton High School specifically. They called us things like, we're together, and they only focus on the negatives because when you look at the news, it's mostly, you hear about fights and things like that, but what they don't see is the potential, the leadership, the strength that we have, and HHA helped bring that out of us. We also led workshops on things that matters to us. So far, we did mental health, skincare, the importance of sunscreen. We showed, we cared, and we led. Without HHA, honestly, I don't know where I'd be. But because of it, I have hope, I have a purpose, and I found my voice. And I'll continue using it, not just for me, but for others like me.
That was amazing. Thank you, Berlin, and the whole team. I do have some more prepared questions, but I also realize that we want to leave a little bit of room for a question and answer from the audience. And I'd like to encourage anybody in the audience who has questions to use the Mentimeter so that all of the questions can come through there. I did want to, if I could have the liberty of just asking one, actually, you know what, I'll hold it. Yeah, so if please do use the Mentimeter. And I'm not sure who's going to be reading the questions from our audience in person or virtual. Yes.
Okay, our first audience question for this panel. What do we need to do to make wonderful programs like this, once created, not disappear when funding ends, which is unfortunately often the case?
You're going to take that one? Because I was going to say we were going to ask that question.
Right, we were going to talk about that.
Take it. Yes.
You want to? No.
Please go out.
Me?
No, Belinda's got it.
I'll
Go
start.
ahead, Belinda.
I'll start, and then I'll pass it to you after. I think it's important. A key takeaway from today would definitely be to invest in our youth, in our young people, and to not shape the future for them, but instead support them so they can shape it for themselves. Woo! In order to do things like that, we need to pay attention to what matters. We need to understand that health equity doesn't just happen in the exam room, it begins way before then. We have to invest in their education, we have to invest in programs like these, provide funding that goes beyond just a limited amount of time. We need to expand our partnerships. We need to bring the youth to the table. We need to give them the voice to be the advocates that they want to be. If you give them that opportunity, I promise you they'll show you that they can.
Thank you. Others want to add to that?
She did pretty good. I don't know if I can even. I don't know. We don't like to upstage each other.
I know, we don't.
Give
We don't
everybody
like
their
to step
time
on
to
each other's
shine.
toes, no.
Equal opportunists when it comes to shining.
Oh, I love my meetings with this group. Thank you so much. Are there other questions?
I have a question, but I do want to make an announcement. And I do want to thank everyone on the panel for their work. I'm from the HRS Health Equity Foundation. As we mentioned, we funded the work to start this program, and I am very pleased on behalf of our board to announce that we have approved $4.5 million for the Hometown Health Academy.
Oh, thank you. Because you were part of it too. Wow. You ate that. That's crazy.
Sorry, we love each other.
It's okay though.
Wow, thank you. Wow. That.
What do you say after that?
What do you say after that?
Thank you, thank you, thank you, and thank you.
We won't disappoint.
Definitely. Thank you so much. You have no idea.
Yeah.
We have loved working with Atrius and the Mass League. They've been great with this program, FYI. I want to thank them all. Darwin.
Shout out to you.
Thank you. That I'm speechless, which for those of you who know me is a lot. So, other questions from the audience? I don't know who would dare.
Yes.
Ask a question. But we're prepared.
Sorry. Audience question to wrap this up. How can we create programs like this at other healthcare systems and their partners? How do you create buy-in?
Yeah, take it away, Marissa.
Well, the first thing is to start having the conversation. And I feel like that's a simple answer, but it's actually the biggest thing that needs to happen. Start having these conversations. Why do we need them? What's the purpose? What it's going to do? What question or what issue we have to solve? If you want things to move, we have to start talking. And then by talking needs to be action. Put the action behind the words and let's make it happen. We're here. Come and talk to us. We'll tell you all the things we went through. It was rough, let me tell you. Especially getting into the schools, creating those partnerships like Belinda touched upon. It's important to make sure you're seen in the community and known. Because there was a point when they were closing the door on us and we're like, no, we're getting in there. We need to get and see these kids. We need to be there. And now they welcome us in. But it took months where we were worried.
Oh, yeah.
Yeah, we went through it a little bit.
Well, we didn't take no for an answer. I'm very resilient.
Yeah, we were trying to figure out what words to use to describe that.
Passionate.
That we said
Passionately
passionate,
resilient.
We didn't want to say aggressive.
relentless. We were relentless.
Yes.
A lot of trust building.
Unwavering appreciation and determination.
All of it.
Yeah.
Yes.
Another thing I'd add is that it's important to put the resources in the hands of the community, and because we understand not only putting the hands into the resources into their hands, but also allowing them to design the program in a way that works. We are members of the community, so we understand what's going on. We understand what our students are going through and the obstacles that they face. So we specifically designed it and tailored it for them. So give us the funding, and then we create the programs. And we've done so successfully so far.
I want to say incorporate more collaborations between more underinvested communities. I feel like that's definitely some.
Mic up.
Oh, sorry. Yeah, incorporate more collaborations between more uninvested communities, partnerships, engage with each other. I don't know if there's a room full of people here. We have some kids that you can have internships at your centers or anywhere that you work at, site visits for the youth, just giving them a voice, giving them, like she said, a seat at the table, because we've learned that letting them actually talk and hearing them out, it goes a long way. They are very smart, very intellectual, and they have a lot of opinions.
And this isn't just about awareness. It's about access and advancement. And I feel like that needs to be taken more into consideration. Again, the youth deserve to be at the table, especially things that affect them, and they're the ones shaping the future currently.
Questions can go through the Mentimeter. Just following the rules. Definitely I'm in for resistance, but around the questions through the Mentimeter. One of the things that we did want to highlight was around, how does a program like this, we've been talking about, federal issues, statewide government questions, these benchmarks, right? But on the local level, how does a program like this advance health equity and economic prosperity?
So we address health equity by centering youth voices. I know we've kind of said that. It's repetitive, but it's important, especially from historically underserved populations, and equipping them with knowledge and leadership opportunities. For instance, we have educational sessions that provide in-depth exposure to various health issues that impact our community, as well as give our youth the opportunity to have discussions with their peers, with their family, or anyone they come across. Through the Youth Health Advisory Council, the YAC, they're not just learning about health issues, they're actively participating, driving awareness campaigns and community engagement efforts. On the economic side, our Career Step program introduces students to real career pathways in healthcare, build hard and soft skills, and connect them with professionals, helping bridge the gap between potential and opportunity. And I'm gonna say it again, this isn't about awareness, it's about access and advancement to foster a healthier, more vibrant Brockton, which is needed.
All right, I think that wraps up our session, even though I think I said you'd be nourished. We certainly are. But if you have any questions that didn't get answered via the Mentimeter or whatever, we will be here all day and are happy to talk to anybody about how this program was developed, the lessons learned, the hard ones, the sweet ones, and just want to thank you so much. Thank you, panelists, Berlin, Belinda, Marissa, Laritza, for your incredible openness, authenticity, your leadership, and thank you, everybody. Buen provecho.
Thank you, everybody.
Thank you for having us. Thank you.
Thank you, Maria. Thank you, amazing panelists. Please stay on the stage so you can take a picture. And thank you. While they do take a picture, I just want to also express my reflections and how inspired I am about this work. I often hear and see this work and think to myself, this is what working upstream looks like. And they're doing the work, and so we're excited to continue and have more funding to do so. So thank you again, a big applause, big applause. So Maria, you'll be happy to hear that you actually were not the one standing in between everybody and their lunch. Fortunately, Chairman John Lawn is, which I would like to do a brief introduction. So in the last two sessions, spotlighted two key provisions of the Health Equity Compact Bill, an act to advance health equity. But there's much more in the bill designed to strengthen our systems and advance equity in Massachusetts. We have a table on the bill out in the hall and more information on our website for those who would like to learn more about the bill and ways to support advancing this important legislation. It is now my pleasure to welcome Chair John Lawn to the stage. The Honorable John Lawn represents the 10th Middlesex District and currently serves as House Chair of the Joint Committee on Healthcare Financing. Please help me welcome John Lawn.
Good afternoon, everyone. I do realize I stand between you and lunch, and I promise to be brief. I would like to just say before I make some brief remarks, as the governor, the Senate president, and the speaker said, despite what's going on at the national scene, it is very important that we come here today and keep our foot on the pedal and don't look back from the progress that we've made. And I'd also like to just before acknowledge my Senate co-chair of the Healthcare Finance Committee, who's joined us, Senator Cindy Friedman from Arlington. Senator Friedman and I, for the last few sessions, when I took over, it was during COVID, which was kind of a lost session, I kind of feel, in a lot of ways, because of no one having new staff and not being around people, everything on Zoom, and just reacting to the COVID response and the challenges of COVID. made it really challenging, but I think we've kind of found a footing, and I really consider Senator Friedman a close friend as well, and I really respect the work she does and the passion she has for so many issues, and I know health equity is certainly one of them, and I know she'll be leading the panel on primary care, which has also been a big focus of hers, and she certainly knows the importance, like we all do, of having a robust primary care workforce. And I really wanted to just thank the Health Equity Compact for their unwavering leadership at this critical time. The annual Health Equity Summit brings us together, not just to highlight urgency, but to hold ourselves accountable. Massachusetts will continue to lead in health equity. As Speaker Mariano highlighted earlier, we made significant progress last session in collaboration with many partners here in this room. This summit is our annual commitment to keep health equity at the forefront of everything that we do. My gratitude extends to that great panel we just heard from the Brockton Neighborhood Health Center and Hometown Healthcare Academy, and that wonderful surprise announcements of funding. Your work powerfully demonstrates the essential connection between community, education, and improved health outcomes. Education that supports growth, professionally and personally, strengthens our commitments, communities, and broadly defines what health equity truly means across the Commonwealth. It is a cross-sector collaboration and a partnership in action. In Massachusetts, we have much to be proud of as a global hub of innovation. We lead in education, medicine, research, and development. We have world-class universities and hospitals. Just 1 mile from here, Vertex developed a cure for sickle cell. As we all know in this room, sickle cell is a life-threatening, inherited blood disease, and more than 90% of people in the United States with sickle cell are Black and non-Hispanic Black. Despite our strengths, we are far from being a state where every person has the same opportunity to live a long and healthy life. Massachusetts consistently ranks as one of the healthiest states, but inequities in health status and access to care persist. Less than 2 miles from here, where the treatment of sickle cell was discovered, a disease that we know disproportionately impacts people of color, the average life expectancy that has been mentioned before for this population is close to 2 decades shorter. There are pharmacy deserts and an inability to access quality health care. I'd also like to speak a little bit about medical debt. The burden of medical debt is not carried equally. Communities of color have 2 times the rate of medical debt in collections as related to white communities in Massachusetts. This exacerbates the cycle of wealth inequity and health inequity. Compared to the rest of the nation, Massachusetts has the 3rd highest gap in income inequality. We rank 48th out of 50 states. To decrease income inequality and strengthen access to housing, education, and transportation, I filed legislation that prohibits agencies from reporting medical debt on a consumer credit report and prohibits a medical creditor or a debt collector from selling that consumer information for collection purposes. Medical debt should not prohibit someone from being approved for safe and affordable housing. Medical debt should not prohibit someone from being approved for a loan to send their child to college. Medical debt should not prohibit someone from being approved for a car loan so they can drive to work, instead of having to rely on some other form of transportation. Addressing health equity requires meeting people where they are. In addition to addressing root causes to improve the social determinants of health, we must be mindful of disparities and innovative in solutions, working relentlessly to close gaps in quality of care. So how do we work outside the four walls of a hospital or a community health center before people get sick? And in partnership with everyone in this room, how do we keep people healthy so treatment is not confined to those four walls? We do it by enacting policies that support health. Safe and healthy housing, nutrition and food access, education, screenings, health literacy, language access, transportation, and a robust healthcare workforce. This precisely demonstrates the cross-sector collaboration and civic partnership that we need. I filed a bill on healthcare workforce development that because we need a healthcare workforce that looks like our communities, trained, and like the panel mentioned before, trained in culturally responsive care. We must invest in people who live and raise their families in neighborhoods that have been historically marginalized. When we do this, we not only keep people healthier, we lift families out of poverty. As I was preparing some of these speeches, when I think about workforce and providing opportunities for jobs, I realized I am in this room with all of you because of an opportunity in healthcare. My mother, Bridget, from a poor rural farm in Ireland, became a nurse because of England was going through a healthcare workforce shortage between 1940 and 1970. They were recruiting healthcare workers all over the world globally, offering free tuition, free room, free board, and also a monthly stipend to live. Her job provided a good income, lifted our family out of poverty, and combated health inequity across generations. As I stand among such smart and dedicated healthcare leaders, I am deeply mindful of this. We have so many intelligent, talented young people who are eager to work in healthcare, but too many barriers block their access. We can break down those silos together and build relationships with non-traditional partners in housing, in schools, and through faith leaders. We must continue to collect data, measure progress, and identify where we are still falling behind. No single organization can do this alone. It takes more than good intentions. It requires shared purpose, aligned strategies, and unwavering collaboration. Everyone in this room cares. Massachusetts cares, and we are here to take action to improve the health of every individual in Massachusetts. Collaboration is how we strengthen our Commonwealth, fulfilling our promise to a truly progressive and innovative state. I thank you, and I thank you for the honor to be with all of you today, and I hope you go grab lunch.
Thank you very much for those remarks, particularly around the work you're doing, continuing around the workforce development and the medical debt. We're very appreciative of that. So thank you for sharing that here today. So we are going to go to lunch. I am going to say a few other things, but please remain on your tables. Your table number will be called to lunch. So it was a strategy to keep you all here. So before we break, we also want to thank our generous sponsors for making today's event and the work ahead possible. I want to thank Takeda, CareQuest Institute for Oral Health, Johnson & Johnson, feel free to clap whenever you want, Behavioral Health Network, Inc., Boston Medical Health Center, Boston Medical Center Health System. There we go. Community Care Cooperators, AKA C3. I see the team over here. Point 32 Health, Quest Diagnostics, the American Cancer Society, the Massachusetts Business Roundtable, saw JD here earlier, Massachusetts Medical Society, and Compete Now Web Design and Digital Marketing. And just a little reminder to check out our Health Equity Movement signature wall. If you share a picture, once again, if you share a picture or a selfie or yourself at the wall with the hashtag HETS2025, you will be entered into a raffle to win a copy of Not All In, Race, Immigration, and Healthcare Exclusion in the Age of Obamacare. The author, Professor Tiffany D. Joseph, is here with us, I believe, and thanks to her for donating the books. So now we'll pause for lunch. Again, please remain on your tables, socialize, discuss, reflect on all the great things that you have heard. We'll be grabbing food soon, and we will reconvene at 1:15. We're going to shorten a little bit so that we can stay on time. So we'll reconvene at 1:15 for the session centering health equity and primary care reform. Thank you.
Please remain at your tables. A staff member will come up to you to let you know when it's okay to grab lunch. Please remain at your tables. Thank you so much.
thank you. Where are those bells, right, that you need, like, ding, ding. All right. So I'll get us started as people sit down, and hopefully we get through the afternoon. We have exciting conversations and amazing panelists to continue the discussion today. So again, welcome back, everybody. I hope you enjoy the lunch. Taking a moment to thank our catering team and everyone who made the meal possible. Thanks for that round of applause. Also, before we dive into our next session, I have a few more shout outs. First, to our fantastic staff for planning to execution, thank you for the care, dedication, and behind the scenes hustle that have brought us to this summit to life. Thank you, thank you, thank you. Let's hear it for our outstanding team. So, also to our volunteers, thank you for showing up and supporting us to make sure everything runs smoothly. We appreciate every single one of you. And of course, thank you to our partners and sponsors. Your support powers the work we do. We're so grateful for you believe in our mission. Finally, to the Health Equity Compact board members, a heartfelt thank you for your vision and leadership and the time and care you give to guiding this work. If you're here in the room, which I know all of you are, I think, please stand or give a wave so we can show our appreciation. Maybe they're still getting a cafecito or something, yeah. All right. So now that we're recharged, I want to introduce our next session, Centering Health Equity in Primary Care Reform. We're at a critical turning point in Massachusetts. After years of underinvestment, real momentum is building to prioritize and fund primary care as a foundation for a stronger, more equitable health system. This next panel will reference recent momentum, how these efforts advance our shared commitment to health equity, and how this work in primary care can be a model for how we approach system-level transformation across the health ecosystem. I'm very honored to introduce our moderator for this conversation. Senator Cindy Friedman represents the 4th Middlesex District and serves as the Senate Chair of the Joint Committee on Healthcare Financing, as well as Vice Chair of the Senate Committee on Ways and Means. She has been a fierce advocate for fair labor laws, affordable prescription drugs, and expanding access to timely, quality behavioral health care. Please join me in welcoming Senator Cindy Friedman and our panelists.
Thank you, Carlos, and thank you to the entire Health Equity Compact for inviting us here today. This is an amazing turnout. You people in this room represent the absolute best of the Commonwealth and the best of the country. So I don't know whether we should start with a group scream at the top of our lungs about what's going on, or whether we should start with a big round of applause for you. Why don't we go that way so we won't scare anybody? So I just want to start by saying a few words. I am so thankful for you and for your partnership. And I am so thankful for the work you're doing to push the Commonwealth to a place where we all need to be. And that is where everybody gets affordable, accessible health care that's really high quality. And I want to especially shout out the League. The League and the leadership of Michael Curry could not be more important and could not be more valuable in any way, shape, or form. They are incredible. They represent so many people in this room. in a way that I think is unparalleled. So I just want to thank the League. I want to thank Michael. And it's just really important to know who's out there fighting for you and who's got your back. I'm really happy and thankful for our panelists. Damien, Joe, Mike, and Renee, not in that order. And I'm really, thank you for taking time out of your busy day and for being with us here today. As most of the room you know, my House co-chair, Healthcare Financing Representative John Lawn, who is a real partner and friend in this effort. You know that he talked to you before the break, and you know that primary care is one of our critical and key priorities here. In the last bill that we did, we had a primary care task force mandated by a statute, and whose job is to make recommendations later this year for how do we put primary care first and foremost up front in the care of delivery. We know the role that primary care plays. We know that without keeping people from getting sick, helping people when they are early in an illness is the way that you provide equitable health care. It is the way that you make sure people who work in the Commonwealth, kids who go to school here, families stay safe and stay stable. We know all that. And we also know that it saves money, right? It puts care in the right place at the right time at a much lower cost than getting real sick, ending up in an emergency room, and sticking you in a bed in a hospital. So we know all that. We know it in our bone, we know it through research, we know it through everything. So what's going on? And let's find out today what's going on and what we need to do to put what we know up front and make sure that primary care is able to do their jobs and that the providers are able to do their jobs, because we've made it really hard for people to be primary care practitioners. So before, as part of the start of this, I want to start with Renee. So probably everybody knows who Renee Critchlow is, right? But just in case, Renee's practiced full-spectrum family medicine with obstetrics for more than 20 years. She's now the Chief Medical Officer at Codman Square Health Center in Boston. She's the Vice Chair of the Boston University Medical School Department of Family Medicine, and she also lectures at Harvard University Chan School of Public Health. I don't think you lecture hard enough because, I think they could do a little better job, but, get that mother lecture kind of thing, right? So you are uniquely positioned to give us the context of primary care today. So I want to pass it to you.
Thanks, Senator Friedman. Totally appreciate it. First off, I'm going to just do a quick temp check. Anyone who in their career, clinical career, has practiced primary care, please stand up. General internal medicine, general peds, family medicine. Yeah, give them all a hand. Okay, now you guys sit down. The rest of you have no idea what these people do. And that is a real challenge. The rest of you have no idea what these people do, but I'm going to tell you the consequences of what these people do. Primary care is literally the only specialty when you increase the number of clinicians in a community, it decreases morbidity and mortality. People live longer and healthier when there are more primary care clinicians in a community. There is no other specialty that happens. And that is not the way we have framed healthcare in this country. When I looked at I'm one of those people that takes pictures of slides and then never looks at them again. You know who you are. So when you look at the two bold measures for the Health Equity Compact, save lives by reducing premature deaths and advance shared prosperity by reducing economic burden and health inequities. So save lives by reducing premature death. And they said, let's focus on the primary care drivers of disparities and premature death and economic burden. So cardiometabolic health, maternal and perinatal health, mental health and substance use disorder, cancer. You know what I call that? An afternoon in my clinic. Yeah, that's what primary care's power is. I literally looked at this and I'm like, I have one patient that actually qualifies for all these. Now think about how many different places that person would have to go. One of the big problems in Massachusetts, and I'm here to tell you about yourself, is that the people with the resources think primary care is about physical exam and otitis media. And that is the problem. The people with the resources do not have the vision or the will to change the system. I'm not going to ever get another job.
You can work for me.
Okay.
It's not a problem.
Yeah. So when you think about it, one of the challenges that we run into is, yes, the workforce, yes, the administrative burden, but the fact is we have a lot of primary care clinicians in this state. MGB is posting that they have 900,000 people in their panel, and they have 1,300 primary care clinicians. And yet their practices are closing because there's not sufficient access. Why is that? Because the burden of carrying that panel, every hour you spend facing a patient generates 2 hours worth of work. And if we put that work into the clinician's hands alone, what do people do? They cut back on their clinical hours. Literally, with 1,300 primary care clinicians, if they all worked an FTE, a full FTE, they could see 1.8 million people as opposed to 900,000. Less than 20% of primary care providers work patient-facing full-time. They work 40 hours a week, most of it at home with their computers. Practice redesign can only happen if there's payment reform. Payment reform can only happen if there's an increased investment in primary care. We do increased investment in primary care. We do practice redesign to make team-based care. The workforce will fill the pipeline themselves. So we have opportunity.
So, amen. So let's dig deeper into that. So what does that look like? What specifically should we be doing differently? It's dollars, it's policy, it's the whole range of levers we can pull. What should we be doing? What are the priority pieces that we, as a Commonwealth, should focus on to address the lack of access and ability to provide primary care? What are some of those details, but the priority pieces we should be focusing on? Damien, do you want to start, and then Joe?
Sure. So, following behind Renee is always a hard deal. But she calls out those things in the very big buckets that exist. From my experience, and from what I think we need to do to address this problem, is we have to untie the knots, right? It's like when you have your iPhone or a headset, it's not even connected anymore, but those of you that have to untie a string of a cord, it's hard to do, but you don't want to do it unless you have to do it. And that's where we are. You could plug in with tied knots and it could still work, but it's not going to actually give you the length of cord that Renee was talking about. And for me, that means addressing why our clinicians are spending 20% or more of the time, if they're a full-time FTE, doing administrative work. We're one of the only places in the world in a high-income country where that occurs, right? The challenge does not usually come with how to bill and how to code. It comes with how many patients can be seen in the day. And you have to incentivize people to get into that type of work in the system that it's designed to have more specialists, have more expensive care. And the provocative thing that I have to say is really that healthcare is a business here. It's not a social service. That's why it doesn't make sense, but it does. If you realize we have to make the business align with what our people need, and that can be done. The solutions are here. You could talk to Renee for 2 hours and she'll tell you how to get it done, right? But we have to make the commitment as a society. Massachusetts can lead the way. It has led the way all the time in making these changes happen. So why can't we be the first place that does something that makes sense when it comes to primary care?
Jill, you're someone who's on the front line. You're delivering care. You're a very valued and elusive resource of a PA, right? So what do you see as, in your job, what are those levers that we should be focusing on?
Absolutely. Just to piggyback what, and thank y'all for having me. To piggyback what off of my colleagues here said, and with Renee, first of all, primary care is significantly underfunded. From a frontline perspective, it feels underappreciated, but not from the patients, from every other front. Like I myself, on a day-to-day, I have an individual patient panel of 2,000 folks serving South Central Massachusetts in a little town called Southbridge. Famous and infamous for better or for worse, but loving community, and I do live in Worcester. But part of it is it's the burnout. The clinicians are absolutely burnt. There feels like the people that are left are doing it off of pure passion, and it's. I just got off the phone with my fiance actually at lunchtime, and I was telling her, sometimes I come home feeling down, and even just being here, it's so encouraging to show that there's a sign of hope. 400 individuals all focused on talking about health on different fronts is awesome. So things like this are what we need to continue to fund and fan rather. Programs like the Mass Health Subcap, speaking of not having a job, I might not have a job either, but the numbers are just not there. Clinics are struggling, not only in Boston, right? Massive clinics, MGB's massive, lovely organization, great producer for the state, but in Worcester Central Mass, big organization, UMass, or even little clinics like us, I'm part of a 5-provider medical group, the VP, but we pack a punch. There's not primary care in miles and miles of radius, and then leave alone specialty care. You can't even get an ophthalmologist who takes Mass Health, right? Not because they don't care, but they just can't. They won't be able to open the clinic. So if we can just continue to speaking to our leaders on all fronts and motivating our support staff, because my support staff keeps me going, and a lot of clinicians, everyone that stood up, and just to echo Renee's point, would probably echo that sentiment.
Sure. I'll just jump in here and first of all say thank you for having me today. As somebody who got his medical care at Dorchester House, now called Dodd House Health in Dorchester as a youngster growing up in Boston, I know firsthand the work that the Cobham Squares of the world do on the front lines. And to echo the senator's comments, right now you're keeping everything together and keeping it working. I'll start first on health equity. And it needs to be said, health equity is an American vision. It's not a resistance effort. It's the core American value that we have to move towards as a society. And that's true across all of our geography, across the whole Commonwealth. Low-income communities are at risk across the state, and we need to address the levers of why we are where we are. Primary care is an incredibly important tool to do that. So I was really happy to be included in this panel, and if those of you who may know me, I have some thoughts. First of all, I would say the economic value here. Speaking for health insurance, the industry, and for health systems, I think there is an economic value in avoiding emergency room care, for example. And there's 36% of emergency room care that could be avoided by having a primary care practitioner or services being offered right at the point of need, as opposed to letting the needs go unaddressed. And that's in every community in the state, every community really in this country. My philosophy on what we need to do is pay for primary care and get out of the way. And so there's two different versions, two different visions here that I think is important to follow up on. We have to find a way so that all the system participants understand the value of actually getting the dollar flow to the primary care practice. Not stuck up here or stuck over there, but directly to the practitioner so that they see that value for their panels, for the people that they're seeing. And get out of the way, we have to make it easier, to the point just mentioned, to have people actually practice and give care as opposed to fill out paperwork. There's a responsibility on the insurance side to do that, but there's also a responsibility on the system side to get out of the way. And they're both equally important, and there's a lot of bullshit in both sides.
We're best friends now.
So,
I'll be as brief as I can.
that's not saying a lot.
I know, it's like, that was great, Mike. And it hits with what, Michael Curry, is he here? Yeah. Always says, pay now or pay greater later. And that is the key. My kid's name, I'll have fun. And the thing is, I'm really clear. I'm a family physician. I make good money. I don't need you to give me a raise. To all the young pre-meds, guess what? You go into family medicine, you'll still pay off all your loans, your mom will be proud of you, and you'll have a good credit rating. What I need people to realize is the fixed cost of running a clinic. That's where we need to put the money. We need to double the investment in primary care so that our clinics can do team-based care. Dr. Guy Fish, CEO at Codman, he's one of those MD, MBA smart ecologists. I was trying to explain to them, it's like we have a lot of part-time people, and because of the burden of and we need to be able to support them with team-based care so that we can do the administrative work, and if we do this, they can expand their panels and see patients as opposed to just pushing papers. And he just looks at me with that look that he gets, and anyone who knows him knows this look. He's like, yeah, okay, so panel size is a function of team support. Full stop. That is it. Investment in primary care allows us to increase patient access because panel size is a function of team support, and team support has to be paid for. And proactively is the best way to do that.
So, I think you all have been very clear on where we should be focused. But here's the deal. We know all this. We shouldn't be spending any more seconds trying to, quote, show people or convince people. We have a system that is so embedded in the way it does what it does, and the system has been set up so we all compete, and the bigger and richer you are, the more you get, the more you get the ringers in there that can get you the money, right? And right now, the money's going to the hospitals, it's going to fill in beds, it's going to great, new, innovative, wonderful things that we care about. It's not going to preventative care, it's not going to taking care of children, it's not, who aren't sick yet. It's not going to those things that we all know from research and years of trying to have this conversation, we're not showing isn't working. So we run the world. How do we shift those dollars? How do we not only shift those dollars to where we know it should go, but how do we track those dollars, right? So there's been a lot of, and the context that I'm talking about is there's been a lot of talk over the years. we're going to put 30% more money into primary care. Well, the world of primary care now is so focused at the system level, so many primary care practices are part of a system, that you can give money to a system, but you don't know where that money's going because it just ends up in the system. So how do we, it's like your mother, I'm done. You go to your room, you go to your room. When you're ready to tell me what happened, come out, right? What should the state be doing to get to that point where we decide what the dollar should be and we know where they're going?
I'll start. Number one.
Oh, by the way, this is the commissioner of the Division of Insurance. So listen really carefully to what he says. Take it down.
I wish you hadn't introduced me just then. Number one, I would say there's a collective need for urgent action now, and if we wait for government to do something, that'll be another year or two that we lose. So first of all, there's an imperative for individual leadership on the topic. I've had the privilege to work with many of the organizations in Massachusetts that have embraced that level of reform. My former employer, Blue Cross, is one of them that is paying for equity right now, and it needs to be noted that that's the type of action that is being repeated in other places, but not enough. And so that's number one. Two, in terms of government work, we have to make sure that the dollar flow is actually getting into the practices. So you can put in a percentage increase demand on payers to pay for primary care. I think they'll gladly pay for it because pound for pound, they'd rather pay for a primary care service than an emergency service. But there needs to be a bilateral commitment on the system that the dollars go back down to the primary care practice. We don't really have independent practices in Massachusetts. They're part of large systems, and we have to push that dollar flow. How do I do that? If I were the czar of the world, I would put number one, an ability for the health plan to audit the health system on the payments, give them the ability to check the math. Number two, I'd give the state the ability to check the math. Where does the dollar flow at the system level so that they create an asset and liability filing the way that my health insurers, my life insurers, banks in Massachusetts with the banking commissioner have to file detailed information. That's not going to make a lot of people happy, but if we want to advance true primary care reform, we have to dislodge the status quo.
Yep. Very good. Excellent. No, I'm serious. We're besties now. I totally think that that is critical to have that audit trail. That's important. But you did mention something else. We need to create the kind of change that allows independent practice to come back. And that's simplification. That is, you know what? I roll out of residency. I'm a lively, happy, snappy family med doc. Me and my 3 friends go off and start a practice. That kind of thing can be done. When that is done, when we create an atmosphere where billing is simple, when the metrics are simple, we can do amazing, complicated healthcare with simplified billing. If we do that, I guarantee you the health systems will put the money into the health care of the primary care clinics. Because if they don't, their providers will come work for me. Because they say, oh, Renee's got team-based care. Renee's supporting, and we have reduced, Renee's using AI to do pre-visits so that we get to come to work and go home and don't take any pajama time. So that's the thing. Definitely audit trail. But if we create in this task force, what I'll be pushing for is if there's simplified billing with that increase in investment, independent practice comes back to Massachusetts and we become a model of healthcare.
So transparency of where the dollars are going, reduce the administrivia. Joe, do you have? add to that?
Yes, just to pick up on both those points. Yes, transparency, that will increase accountability and public trust. That's always a good thing. And speaking of, independent clinics, that's exactly what we're trying to do, rural area, South Central Mass, but it is a challenge. It really is. God is great. The pay's okay, but the cost to run the clinic, let me just clarify my statement from earlier, that's what bogs things down. The red tape is there. And someone earlier this morning asked a question on, different areas getting different reimbursement rates for the same things, right? So probably in the more affluent, area, I'm just speaking generally without any data, you can see a little higher reimbursement, and, as opposed to some of the more rural places. But all in all, I reassure myself that we are in the greatest state in the country, with the best healthcare in the country, furthermore in the world. So we just need to keep pushing this train. We need to continue to have these dialogues. We need to stick together as a unit. We need to compete a little bit less amongst each other, and hopefully the future is bright.
Yeah, and I just want to add that I don't think it has to be a zero-sum game. It's not primary care versus specialty care versus other things. We spend the most money on healthcare on the planet, and we get much less in return. I dream about a future where we spend a little less, but people get what they pay for, right? Because I don't see, I did anesthesia for like a minute before going into primary care. And I can tell you, primary care will make the life of an anesthesiologist, the cardiologist in the hospital, everyone else, much better in terms of their practice because they see what they need to see, not the unnecessary things that could have been prevented way down the line, and there will still be a need for more. I don't know any country in the world that can say that they've met the demand for healthcare. I use my mother as an example of this. Sorry, Mom. My mom would talk to a doctor every day for 2 hours if she could, right? I would prefer she talk to her primary care doctor, right? Sometimes me. But in that vein, there is enough to go around. And why don't we just double down on doing the best that we can with the most resources and not just lead this state, lead the nation, lead the world?
Let me just add one thing, and I know we're close to time. The notion of that I want to resonate here today is that affordability is equity and equity is affordability. If patients cannot afford to go see their practitioner, primary care, other parts of the system, because the premiums are too high or the deductibles are too high, we're not doing a good job. Our coverage rate is an illusory rate if folks are starting to self-ration care. And so this is really linked together to the work that we're doing. We need to advance our primary care philosophies, but we also have to make sure that patients are able to go see their doctor.
Yeah, I think that you've all just, everything everyone said has been so critical. I have a fun fact I always like to talk about, though. This is a fun fact. Our commercial insurers pay less than Medicaid for delivery done in a community health center. So just think about that. That's kind of where, and it really, you're right, Damien, there's so much money in this system. There is so much money. There's enough for everybody to do their jobs really well. We just have to push to get that money more equitably spent so that more people get care, more providers do the work that they have been trained to do, and the system can sustain itself. So we have 5 seconds left. 5, 4. No, we have 3. So no, we have 2. Okay, we're done. We could talk a lot more, but I think we are required to take questions.
We'd love to take questions.
And we actually all like questions. So, I can't.
Oh.
Oh, hi, there you are.
Thanks to everyone who have been submitting your questions over Mentimeter. My first question that I'm going to read here is, Can you speak about the primary care bills that have been filed in this legislative cycle?
I'd love to speak about the primary care bills that have been legislated. So the primary care bills in this legislative session, I guess I'm the person to answer this, right? I feel bad because I'm the moderator, but
It's all yours.
primary care bills seek to do a couple of basic things right now. One of them is to move more of the care into primary care, make that easier. But it's also to develop a model that's a financing model that can, A, keep the practices going, but also reduce the administrivia of what's happening. And there's some very interesting models out there. One of them is the Mass Health subcapitated model, and to see, that's been out for a while. We have a bunch of learnings on that. We can look at it. We can see how we can make it stronger and better. And then what's really important is that whatever we come up with and however we engage the commercial payers, that whatever that plan is, whatever those benefits are, they are equal and exact across all commercial insurers, and Mass Health, because unless you take the burden off, take the nuances, the differences from between one health insurer to another, you will never get the providers to a place where they can spend more time on care than they are on billing. So that's a very high level of what they're trying to do, but it's to require money to be shifted, to track that money, to be specific about how we track those dollars going through the insurers and through the providers, and then also coming up with a payment system. There is another bill that does something very similar, but it looks at building a primary care trust fund that different entities would pay into, and then there would be a distribution to primary care providers so that they would bypass all of the commercial pieces. So those are I think the two really big differences in the primary care bill space.
I think I'd give the senator a shout out for her leadership, legislative leadership on this topic. I'd also note we're fortunate as a state because of CHIA's leadership on the collection of the data in the primary care field, and I know Director Peters is here. We have some building blocks that we can now leverage to actual action, to the senator's point.
Yeah, and so there are 3 bills that are addressing primary care payment reform specifically.
There's really only one important one.
There you go.
I'm only kidding.
The important thing that they all have in common is increasing the investment. The rest is sort of the devil's in the details. I would also say that an act for advancing health equity should be considered, in a way, a primary care bill. Because the fact is, if we use health equity the way it's supposed to be used, which is as a lens to monitor quality and performance, if you use health equity as a pursuit for health excellence, which is what we use it for, then primary care is just a foundational part of that. And that's going to be important for people to realize.
Next question.
All right, so we're moving away from legislation. The next question is, how do you see primary care redesign moving forward and best practices being implemented in a time when the healthcare system is facing so many challenges? For example, there have been significant layoffs from health care organizations this year.
Maybe I'll start just by saying I think action is more important now than it was even 2 or 3 years ago on this topic. That's not just because the problems have gotten worse, but because the need for self-action has never been clearer. No one is going to come from anywhere else to save us. We have to save ourselves on these issues. And we're lucky. You heard today so much alignment across the Speaker, the Senate President, and the Governor. I'm proud to be part of that work at the Division of Insurance, and we need to take action. Just in the last 3 months, we've issued new guidance to our health insurers on limiting cost share, so that cost share can no longer grow. I think 2 years ago it grew at a rate of close to 14%, your deductibles increasing year over year by 14%. That's not okay. And so we've now put the health plans, and they've been very supportive of this issue, on a diet, on a metric where they have to essentially keep their individual cost share to below the rate of inflation. That's hard work, but they're doing it. They're executing on it, and we need everybody to execute on their own hard work.
I would also say, from the perspective of this being a CEO at a health center in a rural area out on the Cape, that COVID was a warm-up for this period, and that's how I look at it. And in every crisis, there's an opportunity, and I think the opportunity is not to run away from what we are seeing now is the existential crisis for all of us. And it means we are all in this together. We are going to get through it because we've done it before, even though this is probably the ugliest thing I've ever seen, right? I thought that was COVID. But now we have the chance to say, if we can really redesign things to make sense, if we can put equity in the center, which means primary care, as Renee said, that is at the foundation of what an excellent healthcare system does. Primary care is done well. So let's do it. And building off of things that people are doing in silos, like team-based care, these are things that we whisper about in the primary care space and family medicine, because we've had to be the most innovative, because we have the least amount to do the most amount of work. So if team-based care actually is something that is invested in, and we're able to expand panel sizes, make it more enticing for people to have private practices, but not necessarily, because community health centers need docs too, right? And at the same time, that is the moment. I think that that is really what we have to see. We have to see that this is not something that will overwhelm us. This is something that we can overcome.
Yeah, I can't reiterate enough what you said. I mean, it's such an adage, and it's so true. In crisis, there is opportunity. And I think if we let this opportunity go by to really shift this system, then it's shame on us, because we can do this. And it's really asking people to look at what their real needs are, look at what their real values are across the system, and asking them, are you true to your values? Because there's nobody in healthcare that'll say, we don't care about the patients. They may think that, but they're never gonna say that. And most people in healthcare, I find, really, really care about delivering care. And so if it means somebody takes a little less and someone gets a little more, and what is important, and we keep that in mind, we can really solve this problem, and we don't need the person in the White House to tell us how we're going to do it, or what we can and can't do. We can figure this out. If there's a will, there's a way. So
yeah, no, this is really an opportunity for a Massachusetts moment. Yeah. Dr. Archer, Damien's 100% right. This is an existential crisis for primary care, and if primary care goes down, the rest of the health system goes down. And this is the thing. I don't think it's a coincidence that we are right now in JFK's library. One of the things that I wrote a year ago was, we called it the primary care moonshot. And the moonshot for primary care is a joyful practice. A joyful practice is made from effective systems. Effective systems comes with appropriate investment. When they did the moonshot, when they said in 10 years we're going to put a man on the moon, JFK used that as an organizing principle for change. A joyful practice is an organizing principle for change. We have the ability to make this happen in Massachusetts. Our challenge is this: the money comes from a system that benefited from fee-for-service. The people with the resources have all the money. The people with the ideas and the needs have only influence. So part of what this task force needs to be able to do is get the people with the resources listening to the people with the vision and the will to make the changes. The state has to lead with that, because power doesn't ever give up power.
Amen. So I want to go off script just a little bit. You have 500 people here. There's 300 people listening. I want each of you to tell them what to do.
Yeah.
What? You have 2 sentences. I'm looking at the clock.
Yeah. Well, looking at you, Senator Friedman, people need to vote. They need to vote in alignment with their values, and they need to support and share their voice with their local representatives, because there is so much power in this room alone, right? If you sent 1 email a week, they are read, right? And advocate and tell your stories and talk about the importance of primary care to you, because we all have a primary care story, right? Some of them not so good, some of them amazing, and showing the value of what happens when there is good access to primary care. And I think that that's really what I'm also learning, is that nobody's coming. So you have to step up, you have to speak up, you have to shout and say, we demand better.
It will be well. That's what I'll say. It will be well. Everyone just do their job. Clinicians, politicians, business leaders, insurance leaders, academia, everyone just do their job. Let's stick together. It will be well. And healthcare or health does not discriminate. So even folks on the other side, no matter what opinion you have, healthcare does not discriminate. We're all human ourselves. We all have family members. We all need help.
Yeah. And I'll just piggyback on Damien and Joe. Yeah, let's do the work. Let's do it together. I mean, the other quote from JFK is, we need your help, we need your hands, and we need your voice. Those are the things that are going to allow us to make the changes.
The last thing I would add to all of that, with which I agree, is Massachusetts has tackled hard things before, and we'll do this. We will do it. We will do it.
Well, while we have 17 seconds left, I don't think I could say it any better. So I want to thank everybody. I want to thank you all. You're a wonderful panel.
Thank you very much. While they clear the tables, take pictures, just wanna, and yes, thank you again, and a round of applause for the panelists and Senator Friedman. I also wanted to respond. I love that last question, what should we be doing now? And I also liked how Senator Friedman framed, all right, so give it to me, like we say in Puerto Rico, en arroz y habichuela, simplify it. All right, if you are a parent and you're sending your kids to the room, you're not gonna come out of it until you tell me what happened. So for me, I take that also, listening to what this amazing panel has stated around what we need to do broadly, but also look internally to see what in our organizations can we do with what we have right now to continue to affect changes, and also listen and learn so that we can continue to advocate from the challenges that we have, but also from what we're doing well. So thank you again for, for the panel and for Senator Friedman. So next up is our session, Meeting the Moment, the Executive Office of Health and Human Services. We will hear from senior public health and healthcare leaders on how the state is responding to the ongoing crisis draining our health systems, and how we continue to center equity in the response. This conversation builds on the themes from this morning's statewide health equity benchmarks presentation and discussion, underscoring the need for a shared North Star to support coordination and accountability in times of upheaval. Even as the national landscape shifts, Massachusetts has both opportunity and the responsibility to lead with clarity, unity, and purpose. Guiding us through this next panel is our moderator, Monica Burrell, former commissioner of the Massachusetts Department of Public Health. Please help me welcome them.
Hello, good afternoon. Lovely to be here with all of you today. I was really waiting all day to get up here because everybody says it, and it's true. When you sit up here, you just want to sit for a minute. So I hope you're all enjoying each other's energy and presence. I'm going to introduce our group in a second so you can hear from these esteemed leaders. Just as I was thinking about the day, wanted to frame the discussion that we're having, but I'm going to call our group up on stage, and then we'll get to hear from them, and I'll give you a couple of thoughts. So first, I'd like to call up Dr. Claire Felice, the Chief Medical Officer of Mass Health. Next, I'd like to call up Secretary Walsh. Kate Walsh is the Secretary of Massachusetts Health and Human Services. And last but not least is Dr. Robbie Goldstein, who's the Commissioner of the fabulous Massachusetts Department of Public Health. As Dr. Goldstein sits down, I have a public service from the two of us, which is that public health probably saved your life today and you didn't even know it, so you are welcome. You know, I've been listening to the talks this morning, and a couple of themes have come through for me as our panel members get to take in the audience, sharing a couple of thoughts with you. So we've talked a lot about data. We've talked a little bit about cross-sector collaboration. And we've had a couple of people give us examples of narratives. And I'm thinking many of us who are in this room go back a long time, and many of us have been working on these issues for a very long time. So how can we meet the moment that we're in, and from whatever seat we are in, take that moment and have the outcome be different? We are all here committed to justice and fairness in health. And we all come from multiple different sectors. And now in my work across multiple sectors, when we work towards justice and fairness in health, the underlying issues and themes are the same, and what we can bring to it from each of our sectors is the same. So I hope you're thinking of that as you're at this meeting about what can I personally do no matter where our seat is, because for this to change and for it to be a different tipping point, we're going to have to do something different, even though we're in this time of crisis. And perhaps, as in the last panel was discussed, because we are in this time of crisis. When we think about the data, you have in front of you this sheet. Everybody has it on their in front of them. And you know, there's data here. 23 years average, you can see that. So that's individuals living within 2 miles of each other within Boston have a life expectancy difference of 23 years. This number, by the way, has been like that for a long time for many of us working in this space. But, you know, it's really important, especially in the narrative of the greater picture we're dealing with outside of Massachusetts now, that this is not okay, right? So when the status quo is not okay, acknowledging that and thinking about how we change that is important. And here, you know, as a member of the Health Equity Compact, this piece about adding in the economic burden and how, if we look at things beyond just the health piece and look towards our social determinants, our social drivers of health, can that have it be a different approach? So the other number on here is $5.9 billion. In the current environment, it's important to remember that not addressing these issues costs us every year $5.9 billion. And with all of this data, you know, we heard this beautiful example of the work being done in Brockton. There's the narrative and listening. I was outside speaking with Secretary Santiago and I were catching up with Dr. Thea James, because she trained both of us at the old Boston City Hospital, and talking about what we've learned from our patients or residents or community members, and how do we as a collective community take that data and narrative together across our different sectors and really take this moment. I do a lot of work now across the US and globally, and health equity, public health is in crisis and on fire, and many people across states tell me that this feels worse, as we learned in the last talk as well, worse than the COVID pandemic. So we're in this moment, it's a pivotal moment, but we have these leaders, these fantastic leaders in our executive branch who are thinking about this every day and really being solution driven. When Governor Healy spoke to us this morning, part of her remarks were finding joy and celebration. Carlos, you said you spoke to your patients about what's going well. So I'd like to start with talking about what's going well. We've heard a lot today about the amazing work that you all are doing with the 1115 waiver and with AHAM and other initiatives at EHS. Could you help us understand a little bit more in detail about those different programs and how they're focused on health equity?
Sure. And then you do AHAM. So I can start by speaking a little bit about the 1115 waiver that you've heard glimpses of throughout the day today. One of these tipping points for us at Mass Health, and I say one because there are so many of them, we're in another one today, was about 5 years ago in the light of the COVID pandemic, the George Floyd's murder, the racial justice movements that followed afterwards, and we realized we need to be doing so much more to address health inequities. So we built a program both internally at Mass Health and also asked our plans and providers to participate with us in doing three major things. The first is building an infrastructure around data so that we understand, identify, can monitor and track progress on disparities. The second was really taking what we already knew about inequities for our members who are experiencing homelessness, our members who have food insecurity or housing insecurity, primary care, investing in our primary care subcapitation program, and began implementing programs to try to address some of the root causes of inequity. And then third, we really focused on collaboration. We're working with AHAM, we're working with the Department of Public Health. We're trying to build these kind of cross-sectoral collaboratives that we know are going to address equity. And then we turned and looked outwards and said for our plans and providers who serve 2.3 million Medicaid members across Massachusetts, we want you to work with us. We know you know the solutions in your own communities. It's going to look different in every city and town that you're in every primary care clinic. But we want to put our money where our mouth is and make equity an equal pillar of value to quality. And so we invested $2 billion over the 5-year period to say, let's build data infrastructure, let's reduce inequities we observe in perinatal health and preventive pediatric care, let's increase access for our members with disabilities and those who prefer a language other than English for healthcare, and let's build and work together, break down some of the silos that we know are preventing us from achieving our goals. And we've seen real progress. We're 2.5 years in. We don't have all the answers yet or all the data to support what we hope is transforming, but I can tell you what we hear from our providers and our plans is incredible. We know that 100,000 people have been trained to improve disability competent care, serving our members. We know people are tracking language access and making sure that interpreters are being provided when they're needed. We're already beginning to see progress. We have 100 projects underway addressing perinatal health disparities in access for behavioral health. So we're seeing really incredible work, in large part due to many of you in this room. So thank you.
I'm going to pick up on the AHAM piece, and I just want to say I actually really like that we're starting with the successes. I think in this moment, we keep feeling like we're losing, but the truth is we're winning. We're winning in a lot of areas, and we should keep fighting for those wins, and we should keep pushing. And AHAM is one of those areas where I feel every day like we're winning. I don't know if actually Kate has seen this yet. I had to do my end-of-year review where I comment on all the things that I'm proud of and the things I haven't achieved, and AHAM was the thing that I wrote that said, I am most proud of this work because we've actually achieved something in the past year. So I think folks know that AHAM has been focused on cardiometabolic health and also on maternal health. And we've seen significant progress on both, but I want to just highlight what we've done with maternal health over the past year. We recognize the disparities that exist in maternal health, and we're doing things to eliminate those disparities, to narrow those disparities. Through Mass Health's work, we have doulas that are getting paid for their services all across the Commonwealth. I think they far exceeded the number of doulas that they thought would sign up for the program, and we're going to make it even more in the next year by certifying doulas through the Department of Public Health so that we have standards and quality and we can get people paid for the work that they're doing. We recognize how important it is to have midwives in the workforce, and so we're pushing forward with a certified professional midwife board. They had their first board meeting this past month. We're going to put forward regulations. We're going to make sure that those folks can go practice and provide care all across the Commonwealth, whether it be for home births or for birth centers. And in birth centers, the Department of Public Health, I will acknowledge, is oftentimes slow with regulation. We moved rapidly to update the regulations for birth centers so that people across the Commonwealth can come together and form groups that are going to open up birth centers, whether they be freestanding birth centers or associated with a hospital, because we know that birth centers provide a high quality of care in community with the right people. And for many women, for many pregnant people, they are exactly the right place to deliver. We have a lot of work to do ahead of us, but AHEM is really energized to keep moving. Just earlier this week, we had a large meeting of the Secretariat to talk about AHEM, to push us forward, to continue our work in maternal health and cardiometabolic health, to think about place-based investing, and take us to the next step. So I think there's a lot to celebrate here. There's a lot of energy and engagement around AHEM, and it's a win that we should celebrate all year long.
I'll just add one point to something Clara said. You know, I think the most important part of this journey is that we no longer separate equity and quality. Equity is quality care. And until we, sever those, or knit these together in everything that we say, it'll be really easy to pick it apart. And so I think, if you want to deliver the highest quality care to the people you serve, equity, looking at it through the equity lens is absolutely fundamental to the work. And if you think about it that way, it's pretty hard for people to dismiss it as a fad or woke, or because it's fundamental to the care processes, which I think is what we're trying to build into our part of this, which is how we pay for it and what we regulate.
Thank you. And somebody's clapping. Let's clap. It's after lunch, Secretary Walsh. Taking up on that point, right, because we're trying to build foundations, and you clearly have these amazing examples of through quality work, through equity work, and bringing them together, what you're actually doing is improving people's opportunities to be healthy using the tools that you have. And it's amazing to see the progress that you're making. This morning, I want to talk a little bit about data and working cross-sector and how that might be helpful to the work that you all are trying to do. So this morning, we talked a little bit about benchmarks and data and the role of data. And Dr. Rao from Blue Cross Blue Shield gave this example where they started to report on their quality data, to the point you're raising, Secretary, in a way that they stratified it in ways that you could see where there could be a disparity that could lead to an inequity. And that then allowed outcomes to change because it was seen in a different way, in a different light. And one of the goals of these benchmarking process that the Compact is talking about is to be able to have these places where, to have this quantitative ability to say, what is it we all collectively should be doing to help you in the work that you're doing? So I wonder if any of you could comment, when you look at the big picture, because being sensitive to having been at the state, you want the work to really align and be able to augment what you're trying to do, as opposed to, we just talked about primary care when I was in my primary care clinic and the multiple different ways we had to report hemoglobin A1C, right? And how tedious that became. So how can these benchmarks be something that elevates your work, enhances, allows you to do it better? And what would be most helpful to support your efforts as we think about these benchmarks and how it could be something that moves equity forward?
Yeah, everyone's looking to me, DPH to the data world. Yeah, I mean, underneath this question is the reality that the disparities that we see aren't random. And the data are helpful for us to understand exactly where we need to focus our efforts. I think what we've seen at the Department of Public Health, and I want to credit the Secretary's leadership on this, is that we have tried to align on a strategy that looks at high-level benchmarks and push it across the entire department so that we're all working together towards the same goal. So an example is, I have said to the department, a metric that we are going to follow every month, every quarter, every 6 months, every year is severe maternal morbidity. And whether you work in the Bureau of Family Health and Nutrition and your job every day is focused on maternal health, or you work in the Bureau of Substance Addiction Services and your job is to deal with overdose and opioid-related deaths, which we know are contributing to severe maternal morbidity, everyone can see themselves in that number. Everyone is working towards the same goal. And I think what would be best coming out of the work that we're doing at EOHHS and what's happening with the Health Equity Compact is for us to come together and find what is the right benchmark for all of us to be focused on. It doesn't mean we're going to get rid of the 12 ways you measure hemoglobin A1C in a clinic, but what does that roll up to? And how do we hold ourselves accountable to that higher level number? We've seen it work within state government, which I think some people thought wouldn't happen, but it is actually working in state government. I think we can make it work across the Commonwealth.
I can add to that too. At Mass Health, we've had experience setting equity benchmarks through our equity incentive programs over the last 3 years. And I would say with quality, we have the advantage of looking at national data and picking benchmarks based on what's out there already, and we kind of have a playbook to go from. When it comes to equity, we had to start from scratch and try to identify what's fast enough, what's too fast, what's not fast enough. And collectively, I think with all of you, have tried to identify what that middle ground is. I will say it's been really hard, and it's really hard to get to the right number that's fair and accounts for the different places that people are starting. But it also has really sparked this discussion about making sure that we're holding ourselves accountable. So I think if we do that at a statewide level, it's going to spark the same challenging discussions about how to get to the right number, but it forces us all to really put ourselves in a position to think quantitatively about what are our true goals and how can we get there.
The only thing I would add to this is to stay rigorously focused on outcomes. Government is really good at process measures, how many, how often, and I think that what gets lost in that are really the outcomes of the people we're trying to serve. And for me, it shows up kind of across our secretariat where people will say, you know, that's a DCF kid, that's a DMH mom. You know, those are artificial distinctions we put on a family. And so how can we collectively across Mass Health, across the Department of Public Health, across the Secretariat, have a couple of things that we're all working on together? And I think those kinds of issues are ones that can galvanize the people in this room. I mean, one of the hardest things was to choose just 2 things for AHEM to focus on. I mean, it is, you know, there's a lot of need out there. And, you know, there's 1,000 things we could focus on. And I think sometimes, you know, you can demonstrate effectiveness and outcomes through rigorous focus. I mean, you know, I think the food security work would be a good example of that.
Yeah, I'm happy to share. So I think folks are probably, some of you are familiar with what we've referred to previously as our flexible services programs at Mass Health, which are programs that we do provide to our members to provide food and nutrition supports and housing supports. So medical adjacent services that are, we know, foundational drivers of health. We've been fortunate in that we just finished kind of a review of the first several years of the program, and we're able to identify that by offering people food and nutrition supports in particular, we can save money, $2,500 for those participants who are in the program versus those who are not. We reduce ED and hospitalization use, and people experience better outcomes. It's hard to argue with something that does all of those things at the same time. And we took a chance on it and wanted to invest in it, and now we've been able to show that it actually works. So it really is bringing to bear the importance of data, as well as also just continuing to push the envelope as we continue to build that infrastructure.
And I really appreciate the last few examples you gave, because it's talking about what we spoke about in some of the earlier sessions about moving upstream, right? So we look at the access to healthcare and what happens within the healthcare system, and then say, how can we impact and change this based on going across our different programs? Secretary, you mentioned, you know, is it a DMH kid or a DDS kid, right? So how do we think about it across the spectrum and what impacts each individual and their families, and keep going up to the why, and this food example seems really relevant to that and how you guys are doing that work. So it sounds like you're saying that if there was a way that rolls up to some measure, and then there's a lot of detail underneath that, that could potentially help serve if done in collaboration, I think Commissioner Goldstein, you were saying. So moving a little bit, we talked a lot today about the current climate, And, it's really inspiring to hear about the work that you all are leading. And, the country's watching because these are really revolutionary programs, first in nation, many of them, the way that you think about data, the way that you bring alignment across your different agencies, and the way that you embed quality and equity as one. And we're in trying times. We spoke about the COVID pandemic, and it would be interesting to me, knowing where each one of you were during the COVID pandemic, how do you think about where you were and what you learned, and how you're potentially applying that to this feeling of crisis where there's not enough funds, things are a threat, people wonder if they can use the term health equity, all of that, as you continue to move forward these impressive programs?
I can start. So I was at Mass Health during COVID, and so this feels, for better or for worse, very similar. So we've learned a lot of things during COVID about how to be nimble and quick and how to keep our eye on what's most important. It's caring for our members, it's caring for our families, it's caring for our communities. That is the same today as it was then, and it helps keep us grounded, I think, in what's moving forward. One of the hardest things for us at Mass Health has been the level of uncertainty around what's going to happen with our federal partners, for better or for worse. We are a state-federal partnered program, and we work with any new administration, because that's the way our program works. What we learned during COVID is sometimes that uncertainty can be uncomfortable, but we can push through it. And we came through on the other side making incredible strides to do what we could for our communities, and that keeps us going today.
So I was at Boston Medical Center during COVID, and I'm trying to be sort of upbeat because that's the theme of the day. Thank you, Dr. Goldstein. But I'm actually so worried that we're going to have to relearn the importance of public health, just like we learned it less than 5 years ago. And we had vaccination efforts that literally saved the world and saved lives. And we're still sort of like arguing about it, and I don't understand that, and I torture Robbie about it all the time. But for me, I just want all of us to kind of go back and kind of, everybody wonders, like how many times did you have COVID? Do we really need a vaccine? Aren't we done with this stuff? But we're not done with the fundamentals of public health, and we will never be. I mean, we can always be healthier as a city, as a country, as a state, as a nation. And I think that that we shouldn't have to go back and relearn these lessons. And I think, you spoke to one, which is sort of speed to action. Pilot things, try things, come back. And we've talked about data, which was so important to getting our arms around this, because not only did it help us figure out how to care for people who were sick, we figured out who was sick and what communities they were coming from. It wasn't what we expected. It wasn't a normal infectious disease, and it had very specific impacts on specific communities that we've all learned a lot from. And that's where we could focus our vaccination efforts, which I think was one of the things that Boston Medical Center did extremely well, in addition to a video that went viral when the vaccines first arrived, which I'm most proud of. But
so when COVID first started, I was practicing at MGH. And the lesson I took away from there was that equity isn't optional. Right? When remdesivir hit the market, it wasn't optional about being equitable in distribution of that drug. When monoclonal antibodies became available, it wasn't an option to think we had to be equitable in distribution. I then made quite the leap from being a practicing clinician over to CDC, and the same message was there. I was fortunate to work in the federal government at a time when equity wasn't optional, when it was very clear that the work we were doing was the work of health equity. And that's how we drove the COVID response. That's how we thought about vaccine distribution and vaccine recommendations. It's how we thought about Paxlovid when it hit the market. It's how we thought about Mpox when it popped up in the middle of the COVID pandemic and presented us with another challenge. It was that we had to put equity first. And I think in this moment, when we're seeing the swirl above us at the federal government and this really, the only word I can use is insane conversation that they're having in the federal government right now, we have to just push back and say equity isn't optional. Equity is what we're doing. It is the work of public health. that's the lesson we've learned time and time and time again. And I'm really not willing to lead an agency to relearn the lesson, right? We're here to implement the lesson, and that's what we're going to do.
Thank you. So equity is not optional, right? Equity and quality, the same. Boy, I hope we don't have to relearn all those lessons because they were hard ones. Chair Mariano this morning was talking about healthcare reform and how everybody came to the table and they had different needs and asks, but coming to the table and understanding the limitations and working together is how we did that first in the nation work. And I would say during COVID, we had a very similar thing where we came to the table, healthcare, public health collaborated in ways we had never seen before. So it's possible. And the community level organization and ability to advocate for what is needed for us to use data to say these are where our vaccine deserts are. It's possible, and I really see in the work that you're describing, even though it may feel like we've forgotten the lessons, I see the work that you're describing as a continuation of that. It is building on that base, and you are continuing to build and really bravely taking the state forward at a time where your leadership is so crucial. One thing, I have a couple of, as you look out at the crowd here, at this wonderful crowd, right? It's really fantastic. What advice would you have from where you sit? I mean, you guys see things, Secretary Walsh, you have such a large view of what's happening in health, what the global picture is, the federal picture, what you're trying to do, what individuals in this group are trying to do at their individual health centers or systems. What advice would you have? I was going to ask you what you fear most, and you talked a little bit about that, but what do you hope to see in the year ahead that we could do together, and what advice would you have for this group?
I'll start. I was thinking about this when we were talking about data, and specifically in this time with this administration, I think data integrity, program compliance, all the boring things that nobody likes to do, and the committees you don't want to show up for are going to be critically important. Because these guys are looking for reasons to deny people benefits they are entitled to. I always talk about entitlement programs for the unentitled. I mean, so it's our job, and I think you'll see much more of this coming from our offices, to get these data elements right. Because if we don't, people will get kicked off. And we know people are going to get kicked off, for reasons that make no sense. And we really need, and I think about this with Medicaid. There'll be 150,000 people probably gone tomorrow. SNAP is going to, it's an impossible application. It's a ponderous process. WIC, we have got to get the programs that the people we serve, that they count on. We've got to get the data right. And that's going to mean we, the government who's here to help you, will be torturing you. Because we're going to, if you put ST instead of street, that claim could be denied. I mean, it's going to be, it's just going to be a really challenging time for all of us. So I think we have to continue to invest in a little bit of the boring stuff to preserve the really important stuff. And so I just ask you to bear with us as we all work through this together.
Do either one of you want to add anything?
I'm always happy to give advice, free advice. That's how I became a primary care doctor. I think my advice to the folks, I'm looking out at this room, these are amazing people, right? And people, and apologies for folks who were at the breakfast last Friday and heard me say this, but we are all people in this room who are in this cycle of worry, right? We're in this cycle of fretting about what is happening and internalizing everything that's in the news and every news alert that comes across our phone, and we're reacting to it. And my advice to people is to just stop, right? Stop fretting, stop the cycle, get off the mat. It's time for us to fight. We've got to push back. We've got to recognize the wins that we've already achieved and the wins we can achieve when we all work together. That's the advice I'm giving people. It's a little bit the advice I give myself when I look in the mirror every day, because it's like, I need the pump up too, but I think we've got to just break this cycle and break this, this constant sense of depression and anxiety that we're holding. We all held it for 4 years, from 2016 to 2020. I'm not willing to hold it for another 4 years. So let's get out there and fight.
Do you want to add anything? Okay, so everybody ready with their fighting stance? You know, I'm just reflecting, hearing these leaders talk, and it's making me emotional because I started as a primary care doctor at Boston City Hospital and then Boston Healthcare for the Homeless. And then I went on to study health policy and became really interested in how do we go beyond the exam room, right? Because these where's the root cause of the problem? And when I went and got my degree in public health, I was like, wow, Massachusetts is really amazing. There's so much that has happened here in health policy that we have led for decades. And if you take all of the power and the energy that is up here and in the room, there's really nothing we can't do. And a lot of people are depending on us. So really appreciate the energy of our amazing 3 leaders here and all of you in the room. So thank you all. So the HEC group, Lindsay Tucker, who we worked very closely together at DPH, I was like, can I just ask people in the room questions? We want to hear their voices. And she said, nope. We have a system. Please stick to it. So could you please enter your questions into Menti? I was supposed to say that at the beginning. I forgot. I'm really sorry. Please enter your questions into Menti. And as you're doing that, I'm sure we have a few already for our wonderful speakers. So
We do.
Can we have our first question, please?
Absolutely. First audience question. Could the mass health equity measures be used by other payers across the system? How do we avoid the burden of multiple measure slates that has been experienced with quality measures?
I think that's for you.
I can jump in on this one and give my opinion. We like our measures. We think they're important. But they also were crafted to be universal in a lot of ways. There's nothing unique about improving cardiovascular disease outcomes for mass health members that isn't true for people who are not mass health members, right? There are some measures that are very specific to our population. We know we have a lot of members with disability, and so we focused a lot on that in our waiver. But again, there's no reason not to focus on disability competent care for other people who are not mass health members too. So we'd certainly be happy to continue to part with others. And we've worked a lot with other plans and providers to talk about this and think about this, and also to learn from their experience. We aren't the only ones thinking about how to measure equity and would love to continue to collaborate.
Next question.
Next question. This panel affirmed the value of picking a few shared goals that we are all driving towards across public and private sectors. How does the Secretariat view the Health Equity Compact's proposal to focus on 4 primary drivers of disparities in premature death: cardiometabolic health, maternal and infant health, mental health and substance use, and cancer?
Thank you. So I think we mentioned a little bit the benchmarks and how can we think about this rolling up to premature death, right? Because that's the preventable death. And then based on data, that much of it is which you release at the state level, there were those 4 areas that seem to be the drivers of that premature death. So I think the question is related to that and how focusing on that might or might not align with some of the work you're doing.
I mean, 2 align perfectly because we're already working on them. I think the behavioral health substance use disorder question is sort of being dealt with, and it was one of the big debates in AHEM, should that be a primary focus? But we had other mechanisms, specifically the Opioid Remediation and Relief Fund, which is a state and municipal partnership around opioid remediation and relief, and I feel like that we had funding and a process underway there that was rooted in the community. I think where we all need to do more work is cancer, and I think particularly the growth in cancer diagnosis, particularly in young people. Knitting it into the broad work of public health. As I said at the outset, why do we have to keep relearning these lessons? So, I mean, I'll turn to Robbie for more clinical specifics because I'm out. But I think that the 4 areas you've identified are clearly the areas where the disparities are the worst and where there's more years of lost life and where there's more opportunity for us to improve.
I don't think I have anything to add. You don't want to hear me rattle off statistics.
I think they're all the right areas to be working and so interrelated to the work that we're all doing in other areas as well, so I can't argue in any way.
And it's interesting, if you think about those 4 areas related to the work that you all have mentioned, they are places, those 4 disease areas and illness areas, there are places where you already have programs and where you've already thought through, number 1, get access to the health care, and let's go beyond that to the social drivers you were mentioning earlier and the social determinants, and to get to housing and food security. So it's interesting that through this process of the Health Equity Compact, a lot of the conclusions are those that which you've already reached and are actually actively working on. Next question, please. Where does the questions come from? It's like Darth Vader.
Oh. My name is Tamar Kame.
There you are. Hi, Tamar.
I help to staff the Health Equity Compact, and the questions are coming from all of you.
Thank you, Tamar. Next question.
What is the role of the community work in health equity? I want to recognize that many of these initiatives sound like they may be very top-down. How are DPH and EOHHS centering the voices of community members?
I'm happy to start with this. I mentioned earlier this AHEM convening that we had this week, and this was actually the focus of that convening, was how do we engage community in the work that we're doing. And what we came to at the end of about a 2-hour session on this was a recognition that we already have some programs in place. Many agencies across the executive office have divisions of community engagement or offices of community engagement, and we need to leverage those offices and divisions better so that we're doing this all together, we're getting feedback from all of the different constituencies. A second conclusion we came to is that what we really want to do is listen to communities. We wanted to listen to the people with lived and living experience. It's not necessarily the same as the advocacy groups. Right? It's important for us to make sure that the community members have a seat at the table and they're informing the work of AHEM, and they're also able to get feedback on what is working with AHEM and what is not, so that we have a bi-directional conversation with the community. I think we walked away from the session with a commitment to doing a better job of engaging community across the Secretariat. We also came away with a commitment to making sure that we know the best practices in community engagement. I think there are a lot of parts of the Secretariat, and I'll reference DPH, there are parts of the Department of Public Health that don't know how to do the work of community engagement. And so we have to actually invest in those skills. We have to teach people how to do it better so that we can get the results that we're hoping for. But I think there's a lot you'll see from AHEM over the next year. One thing that I hope you will see from AHEM is a real commitment to that bi-directional community engagement.
And the only thing I would add is it's bi-directional community engagement, and it's also, wherever possible, consolidation of funding in a way that makes sense to the community, the so-called place-based investing. We spend, there are zip codes in Springfield where we spend hundreds of thousands of dollars per citizen, and on an annualized basis. And what are we really accomplishing for that family or that household or that person? And they've got somebody from DMH who's helping them, someone from DPH who's helping. Like, we've got to find a way to look at those resources and have them not be the work we like to do in state government, but the work the community actually needs. And that will take a lot of change. It's an incredibly powerful but challenging change management process that will take real leadership on our part and real connection involved with the community. And finally, there isn't a person, and particularly a person of color in this room, who knows that if we're going to do this work, we have to stick. And instead of being there while we have a grant and then we're out. And so figuring out a way to hardwire state resources so that they can do the most good is really, I think, what we've been trying to focus on across the Secretariat.
Yeah, it's a great point around, we were talking earlier about the data versus the narrative and really understanding, where the issue is for the person. And Secretary Walsh, you spoke about, it's not about equity versus quality, it's about quality. And, with great humility, we come forward and say, if a service is available but it's not accessed by somebody in our community, what is the reason for that? And when I was younger and experienced, I would, buzz around telling patients in primary care, oh, there's this 10,000 steps, and this is the data, and this, oh, and if you eat this food, and many patients sat me down and would say, I know what I'm supposed to be eating. I know how much activity I'm supposed to have. That is not the issue. And the issues were around the economics of it, right? And around wanting generational improvements based on education. So I hear a lot in the programs you're saying, listening to that piece of it. Like, we're here talking about health equity, and Secretary Walsh, your point really resonated with me around the quality equity and how do we frame it internally and externally. And we're just trying to improve people's quality of life, right? And how they live healthy among their community. And of course that includes listening to what they need, sure, transportation to the appointment very concretely, but then beyond that, what is stopping, right? What is the interfering with their ability to have good quality? So appreciate that. Next question, please.
Next question. I have enjoyed the calls to action, but they do feel like they're not concrete enough. What are the concrete spaces, initiatives, or communities people should invest in, support, or work with?
I don't know. I was thinking if you find out, let me know so I can show up. But I'm going to ponder that, because I think we owe it to you. And I think I heard a little bit in the governor's speech this morning that we've got to find a way to keep doing this work. And I think we all have. But maybe there's more common purpose that we could create. Maybe there's I'm struck whenever we get together, to review our progress in AHEM, that a lot of the meeting is just supporting each other. And some people, like me, can observe these challenges, and some people literally wear on their skin what's happening. And how do we support each other and show up in a way that's actually helpful and action-oriented enough? And I don't think anyone's found that yet. Maybe people in Los Angeles are doing it right now. But it's a really good question. I don't have a good answer, but you've given me food for thought.
Well, I have some specifics.
Okay, go ahead.
Well,
I should have let you go first.
No, if you're asking me for where people, I think people have to stand up and say truth. And I think there are a few spaces where we're hearing a lot of misinformation and disinformation, and this group of healthcare providers and people in the health space can stand up and speak truth. I think number one, vaccines. Vaccines are safe, vaccines are effective. Everyone can say that 15 times today, tomorrow, the next day, to as many people as possible. We need to just keep pushing back and make sure that everyone understands vaccines are safe, vaccines are effective. That's health equity work. Right? We need to get everyone vaccinated. In particular, we have to get Black and brown communities vaccinated to protect them from the diseases that they're at risk for. I think we know that maternal morbidity is a crisis in this country, and there are disparities that exist that are unacceptable. Addressing those disparities is not, quote, woke work. That is the work of public health. And so all of us should get out there and push back and speak truth and say we are doing the work of public health by addressing the maternal morbidity crisis in Black women in this country. I think speaking truth is the call to action, pushing back on the false narrative that exists in this country. I feel bad saying this in this library, but from Secretary Kennedy, I think we have to all stand up against this and recognize what we're doing is not partisan and it's not political. This is public health. This is the work that we do. We speak truth. We say what is actually affecting health and how we can prevent the harm that people will experience.
And I think this question on misinformation and disinformation is a good one because, we were talking a lot about what can we all collectively do to supplement the amazing work that you all are doing. And, flooding the channels of information with accurate information, right? Good quality information that will help people. That is part of our call to action in a place where, right now we're in a place where a lot of chaos is purposeful and disorientation is purposeful to have us lose track and our sight
of where we're going and why we're going and what our daily work is and how to support each other and how to do the work. I mean, we have these incredible examples you've heard from our Executive Office of Health and Human Service partners about how they are continuing to do the work because it's the right thing to do, because it's high quality work, because it's what the community needs, because it saves money, because it's what Massachusetts has always done, and because it's what these three leaders in their heart feel is the right thing to do to meet the current moment. So please join me in thanking them for this incredible discussion.
Once again, well, we take pictures, few things among a lot of the things that we heard that stood out for me that I want to just reiterate. Equity is not optional. Equity is quality. So thank you to the panel. Thank you, Monica, for facilitating the conversation. We are going to take a break, but before we do, we wanted to share something around, if you have not had the opportunity to go to the activation wall, we will be having some some volunteers come around to the table. So if you want to sign any sticky notes so they can put them back, please stay in your tables and ask them to do this. So we will be taking a break. We will be back, so please stretch, grab a refreshment. We will be back right at 3:05. Thank you. equity-focused efforts across sectors, this panel asks healthcare CEOs, how do we double down instead? Our moderator will be Dr. Sandro Galea, who is a fellow Compact member. Dr. Galea is a physician, epidemiologist, and author. He's a former dean of the BU School of Public Health and currently at Washington University in St. Louis, serving as dean, professor, and vice provost. Please welcome our moderator and panelists.
Good afternoon. Thank you for inviting me. Thank you all for being here. I think it's actually extraordinary to have so many people in the room following up on this agenda. It's great to all be here. So as you heard, my name is Sandro Galea. I currently serve as Dean of the WashU School of Public Health in St. Louis. I was in Boston for 10 years before, where I've been involved with the Compact at that time. Just very briefly, by way of biography and also perhaps perspective on the moment, I moved intentionally to a red state in January 1st of this year. That was, of course, before I knew what was going to be happening to the world. And it's actually been giving me quite an interesting perspective on some of the questions that we're talking about here today, which I can inject in our conversation. So the point of this panel was to bring together health system leaders to discuss health equity, and we're very fortunate to have three leaders who I'll introduce in a second. The challenge with bringing health system leaders together is that they're very busy. So we actually had hoped to have three other leaders with us. So I'll quickly just send regrets and regards from Dr. Ann Klebanski from MGB, Sarah Iselin from Blue Cross Blue Shield, and Eileen Owen from Point 32 Health, who we had hoped to also be on the panel. They all send their regrets. We have with us, still an outstanding panel, Dr. Alistair Bell from Boston Medical Center, Dr. Kevin Churchwell from Boston Children's Hospital, and Dr. Rob Fields from Beth Israel Lahey Health. Everybody, thank you for joining us. Wow. The last panel didn't get wolf whistles, so that's good. That's a good start.
Someone whistled there. Like,
yeah,
really?
that was awesome.
That was
we encourage that. Okay, so let me start by let's start by sort of with the current moment elephant in the room. So all three of you spoke at the 2023 summit, and you were part of the Roadblocks and Resolutions Healthcare Leaders Commitment to Health Equity panel. So let's talk about both how your equity work has advanced since then, and given the unexpected challenges of the moment, how do you see your system maintaining the commitment to driving equity forward? And maybe we'll start from my left and we'll go to the right. Alistair.
So, I mean, obviously, everyone will have said, I think everyone in the room recognizes this is a massively challenging moment. And in some ways, it sort of reminds me that the path forward isn't always linear. We had several years where we made a lot of progress. At the time, we even spoke about the likelihood of regression. People spoke of the half-life of the energy around health equity. I don't think even then any of us, I think in this room, could have quite imagined just how precipitously that energy would change as it has with the new administration. You know, from where we sit at the moment, there's obviously been a lot of focus on health equity, DEI initiatives. You know, when I was last on the panel, I observed that one of the biggest challenges actually to equity was how the care for communities of color, which are way disproportionately represented on Medicaid, is financed, and the relative magnitude of that. And so it's sort of odd to be comparing relative levels of harm at the moment, but as harmful as the rhetoric changes are, I find myself looking at some very direct and quite practical changes to how we are funded that could really substantially impact both our organization but also the care that we're providing, that others are providing in. And by extension, that in and of itself, it sort of feels like very remedial on some level that you would get paid to do certain bits of work. But we're back at that point again, not just talking about under reimbursement, but talking about yet further cuts to that, which is just an incredibly challenging moment for, for our health system to be in.
Okay. So I think that over the past year, as you've described, Sandro, that there sort of has been a change in terms of the viewpoints of the encouragement or the strength around the work that's been happening with health equity, DEI, and et cetera. And at times it goes through, when I approached about it, is an attempt to change the definition of what we have put in place, what we're trying to develop, right? And so you go to, so I went to AI to get a definition. And it says health equity refers to the principle of ensuring that everyone has a fair and just opportunity to attain their highest level of health. Well, I don't think you can argue with that in terms of what we, as a industry, what we're trying to do in all of our hospitals and et cetera. What we had recognized is that we weren't really doing that, and that there were obstacles, there were viewpoints, there were not programs, there were not processes. There was, we were supporting one part of the population that we're accountable for, responsible for, but where we're really investing in and supporting our entire population. At Boston Children's, it's every child that walks in the door. It's every child that's in our clinic, it's every child that's in our community. And we continue to work to define what our community means. Our community continues to grow and expand from the standpoint of who is reaching out to us, who's asking us to help improve the health of the children in their community. And the question was, how good of a job were we doing? Well, we asked questions. We asked the question to our families and to our patients, and we found out we weren't doing as good of a job as we thought, right? There were some populations that said, you're doing great. We appreciate what you do. We appreciate the experience. What my child is getting is what we expect and what we want. And then we had populations, we had neighborhoods that said, no, when I come to Boston Children's, when we come, no, we don't feel supported, we don't feel welcomed, we don't feel that we're getting what we need or what my child needs in terms of their care. And that was a aha moment for us. And that was like 3 to 4 years ago that we really started to ask those questions. And so that's not what we were trying to do in terms of the care that we need and want to provide across the board. And so we have been working to put programs in place, processes in place, outreach in place, support in place to change that dynamic, to improve that dynamic. How are we doing? So how are we doing? I think we're doing better. If you ask our patients, ask our families, we're doing better. If you ask our staff, we're doing better. Have we reached that peak in terms of, as described as the highest level of health for our kids? No, we have not. But, that's the opportunity. And so we try to keep that, and I try to keep that as the North Star in terms of the work. To Alistair's point, we were getting more help than previously than we're getting now from outside entities and et cetera. And I was asked this at another group, well, how do you deal with that? And my point to that other group was, well, we just got to keep focusing on why we're here, our mission. What is our mission? And things will vary up and down based on outside forces, but we stay true to that North Star. And in doing that, we will be successful from that standpoint.
Rob.
Yeah, unfortunately, I wasn't here 2 years ago. I just joined BLH over just shy of 2.5 years ago. But I know Kevin Tabb, who has a lot more hair than I do. I think that's how distinguished us. But I can imagine what Kevin would have said in that instance. And in the 2 years that I've been here since that panel occurred, I know what we are trying to do. And I think I heard it in Robbie's comments earlier on the other panel, and Kevin alluded to it as well. What I get most concerned about is a loss of focus with all the rhetoric and spin, I think, as Robbie put it, and spin. that we lose the focus and the mission of what we're trying to do. And I think, as Kevin just said, I think our work in the last 2 years, on top of what the work that Juan has built with his team and in our system, is really about intention and clinical design. We're here to provide care. The fact is, if we're self-aware enough, the way we provision care in the United States and Boston is no different. As great as we are in so many things, has failed our most disadvantaged populations, right? And it hasn't changed. The model of care across ambulatory, inpatient, et cetera, hasn't changed in over a century. With all the technology, you know, I'm originally from the South. They say if you put lipstick on a pig, it's still a pig. And for the most part, that's true. With all the technology and everything we've got, it hasn't really changed that much, and it's mostly failed the folks that really can't access care in the way that we would like. So a lot of our focus in the last 2 years on the care model is really thinking about how we're designing care models that actually achieve and improve access or reimagine access for those that find it difficult to engage in the way that we would choose. We have designed our system to engage folks, whether that's how we leverage technology. We just make, often in systems, we make assumptions that technology is not available. It often is. We just don't use it in a way that's really purpose-built for our most disadvantaged patients. How we engage community members into operations, things of that nature. That's what we've been focusing on the last 2 years, and that hasn't changed since January for us. I mean, I think with all the spin, remaining focused on what we need to do to imagine it from the point of view of the patients who most need our help, and then design care that way, is what we're most trying to focus on, despite all the other nonsense that's occurring in the world.
So let me move to a not too difficult question, then I'll ask a really hard question. But let's start with the not too difficult. It has been a really challenging time to be a leader in any system, and but particularly around health. And from COVID, now moving to this time when we're with these disruptive federal changes. So maybe Rob, we'll start with you and we'll come this way. Can you talk a little bit about where there are lessons learned during COVID to try to sort of find positives in these crises that are applicable to what we're dealing with today, particularly around the function of all your systems, but also specifically around health equity?
Yeah, there are a couple lessons. I was in New York City at the time. I was at Mount Sinai. If you recall, I think Sinai might have been the hospital with the first case of COVID in New York at the time. It was March 17th, if I remember pretty clearly. We also are the ones that had the hospital in Central Park right on the backside of our hospital. So it was a crazy time for all of us. And while I wasn't here, I have a sense of what would have occurred here. I think there are a couple big lessons for all of us. One is that if we're self-aware, what we were hit in the face with was the inherent lack of trust in our health institutions by the communities that are most disadvantaged. We clearly don't know how to engage appropriately in our communities historically, and hopefully we'll continue to learn that lesson. We haven't established the right appropriate relationships and functional relationships. And linking it to what I was saying earlier, we haven't been intentional about designing systems of care with our communities that repair that relationship. There are a multiple decade history, very terrible history in healthcare on abuses and lack of ego, honestly, if I would to say it bluntly. And that I think we came face to face with that during the pandemic. And I think it's been well studied, it's been well documented, and I think it has pushed the best systems to rethink that from a point of view of humility and self-awareness. And so I hope that's one big lesson. The second big one from my point of view is that the decision to provision care in the way we've always done it versus thinking creatively and collaboratively with community, with government, with other health systems is a choice. It's not set in stone. It's not set by policy in many instances. It's not set by anything other than our own choice to decide to collaborate, because we were able to do it for a brief period of time. We were able to coordinate together. I'm sure the same thing occurred in Boston, occurred in New York. We had venture, we had health systems, we had policymakers on group calls trying to figure out how we're going to provision vaccines, how we're going to distribute food. It was amazing. That was a choice that turned on a dime, and then it turned off almost as soon as it came on. But it was a lesson that said we can do it, we just have to choose to do it. And what are the spaces in which we can actually extend that beyond a crisis moment? Because we were a young system. BLH was a year old when the pandemic hit, It brought a lot of folks together in crisis, which was a silver lining in a terrible mess. But it was beyond just our system. It was with all the systems, I'm sure, here as it was in New York. And again, I just can't emphasize enough, we could choose a different path if there's enough will to do it.
You know, what I would add to that is lessons learned from the pandemic were the lessons around communication and the need and the importance of communicating on a consistent basis and being consistent in your communication. And this, what we're dealing with now, continues to bring that to the forefront. We thought we were communicating before the pandemic. And that was an email maybe once a month or something along those lines. And during the height, we were communicating every day, town halls every week, and et cetera. And we realized that that's what our staff, our faculty, everyone at Boston Children's was craving for in terms of that ability to have the conversation. And so we've continued that. We have scheduled town halls on health equity, where our leaders come and present on Zoom. You have 300, 500, 1,000 folks, they'll come on the Zoom. And what they hear is that the programs, the processes, the people we recruit hasn't changed. That we're still consistently doing what we've defined as our declaration around equity, diversity, inclusivity. And we give them the progress of those metrics. We define metrics in terms of, okay, here's what we're going to achieve this year, and here's where we are in terms of our work, in terms of recruitment, in terms of education. We created and developed, with support from philanthropy, an institute around health equity and inclusivity, and the research that that institute is doing to really further the advocacy, further the views on how to recruit, and et cetera, is what is in place and what we continue to work to communicate and provide support across the board. So that's one of the big things that I think we learn and continue to utilize is communication.
Yeah, I think what I found interesting about this question was, Sandra, we were talking beforehand, is actually that it prompts a framing of the current problem in the right way. Initially, I was kind of like, how do you compare this to COVID? Well, COVID was obvious. I mean, you could describe that in many ways. It was a clinical crisis. It was a financial crisis. It was a moral crisis at some level of how society responded to that. And I found myself thinking, going through that, like, what's the comparison from the current situation to COVID? And it's less direct, and it has different contours to it. But I do believe, like, the situation we're facing at the moment has the dimensions of a crisis, which are of that scale, not managed correctly. I guess how we respond to that, I think both my colleagues here, I think just what was remarkable in COVID was actually, particularly our experience in Boston, was really how we came together to actually solve this problem. I still remember very early in the pandemic, some hospitals were disproportionately affected by virtue of the patient populations that they were serving. BMC was overwhelmed early. We made calls to colleagues across across town at BI, at Brigham, others, and transferred patients out. And it was sort of a collective call to action. We shared supplies, we shared ventilators at different points. There was a degree of kind of working together around a common goal and aim. And when I look at the current sort of landscape as it's evolving, we're going to have to do that again. There's a different problem to solve, but, you know, coming out of the federal government at the moment is, you know, somewhere in the order of, I think the state was estimating like a $1.75 or so billion cut into the Medicaid program. And so collectively, we're going to have to think as a health system about how we actually respond to that. What are the answers that we have? What choices are we making through that? And how do we actually put ourselves on a pathway to thrive through that situation? Because actually, you know, the biggest rebuttal of all that's going on, the biggest rebuttal is for us to be really successful. And I actually think that there are parts of the country where you couldn't actually get like 3 leaders like this on a stage together. That's not how we operate in Boston. It's not how we've worked together. COVID accelerated that, but it's even before that, that's not how we've worked together. And so I think that part of it is now is coming together, thinking about how we're going to solve this problem collectively. And I'm pretty confident we can do it, but how do we rebut the set of circumstances that we're being handed and show that actually in spite of that, we can be as successful, we can thrive out of this situation? Because I actually think we've got the talent, the collaboration to do that here in Boston.
Let me just elevate 2 things that our panelists have said. Number one is, Kevin, I think you made a very eloquent point that I think sometimes we think of health equity as sort of a thing out there. But I think the point, Kevin, that you made is, well, I think it's not a thing. It is just the core of what we do. The aspiration for us who are in the business of health to make sure that everybody can live long, healthy lives is fundamental to what we do. Now, we have labeled a lot of that health equity in no small part in response to the fact that many groups were lagging behind because of our inattention. But fundamentally, there is an important conceptual shift from moving to saying health equity is something extra that we do to it is just what we do. So I thought it was an important point to surface. And then Alistair, you made the point about sort of the best response to a difficult time is to thrive and do well, which I actually thought was a really inspiring thing to say, and I think it's important to frame for a conversation like this. Now, that leads to my hard question. So let's talk about my hard question. So, you know, we are in Boston.
I think this one's going to Kevin.
No, Alistair, you're next to start. You know, we're doing the snake back and forth. So we're in Boston, the city of universities, and we've seen a wide variety of responses to these federal policy changes. Talking about universities and law firms, some have capitulated to demand, some have quietly capitulated, some have countersued, etc. Now, we just heard in the first Meeting the Moment session about how Health and Human Services sees its role in the moment. So I suppose I want to push us now from a health system point of view. What is each health system's individual responsibility and role, and what is our collective responsibility and role in standing strong, advancing equity efforts in this moment when these aspirations are being explicitly threatened by the federal administration?
So some parts of this question are actually pretty easy for BMC, honestly. Hypothetically, even if we tried, we could not back away from this. Like many organizations, I think legitimately, and we did too, have a moment of questioning what we were doing. But like when I look at BMC's history, we were working on this before it was even called health equity, before it was described that way. What we've had more recently is a better language to describe the work that we're doing. But like I can think back over decades. I mean, this is so woven into, so the organization response in a way is like, actually, we're just keeping doing what we're doing. And the irony of the actual current situation is the last 2 years have actually been an accelerant for us, in fact, rather than sort of slowing down. And arguably, we're still in that moment because we embraced some of the comments that both Rob and Kevin were making and sort of, we're pretty introspective on what we were doing. And, if you lift up from all of the reasons to do this work, we exist to provide excellent healthcare to communities, and we recognize that we have a problem with our product ultimately because you have these disparities in outcome that and so we need to be doing something that's different. And that's as much an organizational imperative, a business imperative, beyond all the ways that this is sort of framed in the media. I think the collective part of this for us, I think what we have to recognize is that an attack on one is an attack on all. And I don't mean that in just a sort of a trite way of like, oh, you know, like we stand together. Like practically that is true. What COVID again revealed was that actually we are radically more interdependent than we probably thought we were beforehand. What happens in our organization, it affects what happens in Boston Children's, it affects what happens in BI Leahy, it affects what happens in MGB. The Stewart situation really like highlighted that. You know, as organizations come under distress, like we all collectively felt that. And so the system is an interdependent one. And so I think as we look therefore at the response, we have to think about how we're acting together. I think we also have to think about how we're doing that in a smart way. The administration has shown that they have the capacity to be punitive in a very direct way. And that how we respond either individually or collectively can also endanger certain bits of the work that we're trying to do. And so how we think about talking with a common voice, how we think about using trade organizations as well to advance a common perspective on things. Like we've already dealt with this. We dealt with this when the research was getting challenged, who would bring, and literally in the last sort of several months, BMC has been asked to be the named defendant on lawsuits, national lawsuits on this. And you sort of find yourself, it's like the risk to the patients, you want to stand up for what you believe in. And so I do think we have to think about how we collaborate again across our organizations, how we think about responding as a community to these things, and recognizing that, you know, not that this would be true, but if you guys are doing okay and we're getting hammered, then that's not good for us, yes, but it's actually not good for us collectively as a system or our shared values. So I think a lot of that kind of comes together in again, collective action.
You know, one of the things that we have to continue to recognize is that what happens here, from the collective viewpoint, what happens in healthcare in Boston, in Massachusetts, is recognized. It's more than recognized, it's viewed as leading edge. It's viewed as, okay, what are they doing? I had a chance to present on the West Coast to another university's board, and what fascinated me was that they were very much interested about what Boston Children's Hospital was doing, what we were going to decide upon, and how we were going to deal with the issues of the day. And their point was, we need to know what you're doing, because if you're doing what you're doing, we will follow, because we trust you. Because we've trusted you for 80 years. We've trusted you in all aspects. And so we really want to know how you're dealing with this. And that's an opportunity and a burden and also a responsibility that we collectively have to take on. And it's across the board. It's not just, collectively, to your point, there is no negotiation here. There is capitulation. There is a view and it's based on belief. I'm going to make you do this, okay, and I'm going to force you to do this. And so our response has to be based upon understanding that. If we believe what we do is important, and I do believe what I do is important, I will stay at that forefront and continue to do that work. And I believe what we all do is important. What Harvard University does is important. What MIT, what BU is important. What they do is important. And so if the challenge is across that spectrum, then we need to be collectively working together to make sure that our voice is heard, our viewpoint is heard, our definition of what is important is heard and put at the forefront in this discussion that is occurring.
I agree on all fronts, and I don't find the question that difficult, honestly, because it goes back to, I think, what we've been saying all along. It's about core focus. I think the worst thing we can do is to get distracted in the spin and the chaos and not really focus on the things that we all want to do, is getting the best outcomes for every single individual that we care for, period, end of story. There's nothing else that matters than that. And doing that with a high degree of humility and a high degree of collaboration, which was not true of our system before. Because again, going back, we have failed as a health system to deliver. The issues of disparities occurred long before this administration. They have occurred for many, many decades. And we need to own that and then figure out how to do better. That's all that matters, right, from here forward. And it doesn't, none of the rest of the words and all that matter as much as that. And so that's our focus. And that's our collective focus as a group, because it's core to what we do, as Alistair was saying. And I think that what is different now, and again, going back to the lessons after COVID, and the collective responsibility and collective action, there are concrete examples of that. I was just telling Kevin before we came on the panel, we had lots of questions about how we were provisioning care with some of the new executive orders and attorney general statements, things like that. Reached out to some of the folks on Kevin's team to figure out what you guys are doing. Did the same thing with my MGB colleagues. That kind of conversation is a type of collective advocacy, collective voice that we need to continue to have, much like the lesson learned from COVID, is how we work together, because it is that strength that will kind of get us through this insane time right now.
I just want to underscore something that Kevin said, actually, because I think it's like really important. The work, our organizations have a disproportionate leadership impact in the country. That's kind of essentially what you were saying. In different fields, whether it's children's hospitals, whether it's essential hospitals, whether it's premier academic medical centers, you know, like these are, it's hard when you're sitting in this room to understand the full value of you all and the work that you are doing, even coming together to both, because we get support from you as we come here to this and see the energy around this conversation. But it's like super important. This is not a Boston issue that we are ultimately solving for. People across the country are going to look at what happens here. And because they're looking to these organizations in a sort of a odd way, actually, in a way, but there's a disproportionate number of organizations here that what we do will be seen in others. What you do and what you encourage us and support us to do and what we do collectively together will be seen in other parts of the country, and that is the groundswell of resistance to all that we're encountering at the moment.
We're going to open it up to questions from the audience. There's the Mentimeter right there. But before that, I'm going to do one last question for the panel from myself, and very quickly. A year from now, I don't remember any other time in my professional life where it's been so hard to answer this question, but I'm going to ask it anyway. Where do you hope your health system will be at a year from now? Where do you hope the state will be at a year from now? Rob, we'll start with you.
I would say very concretely, we're focused on the top 6 clinical conditions, and I think where I hope that we will be is to have demonstrated outcomes to achieve that goal of the best outcomes for every single patient we care for, and that we will be able to measure that and demonstrate that the intentional work that have started on this journey will yield some fruit and can actually report back to say, this is the work, this is the outcome of the work that we've done. Again, independent of everything else, that I could report back to say, this is what we did, and measure it and say, this is the impact we had in our community.
A year from now, I'd love I tell my team, I'd love to make sure a year from now we know what the rules of the road are. Not that I will follow all the rules of the road, but when I know the rules of the road, I know how to get around them and how to utilize them for the best benefit for our patients and families.
That's great. Alistair.
Yeah, at the state level, I hope that we have, it's a very relevant question actually, because like a lot of the impacts will start really hitting in 2027. I hope that we will have collectively come together to solve the problem, the crisis that has been created from a financing standpoint, and resolve that in a way that supports and actually further enables the care into the communities that are most affected by that, and by definition that is a health equity effort. Organizationally, I think that, you know, it's difficult because when you're looking at so many organizational pressures, I hope that we are staying positive. I hope that we're still leaning in as aggressively and vigorously as we are at the moment on health equity. I hope that we are kind of continuing to set our bar very high for what we're trying to do. I hope that, to Kevin's point, like, we kind of understand the system, whatever that is, that we wind up in, and we're actively both working within it and around it to achieve the goals, which is almost the entire story of a lot of health equity work, you know, when you really get down to it. And I'm very confident that like that part, I'm actually, on both of those, I'm actually quite confident that we will be successful on both of those. So I look forward to reporting back positively next year.
I'm glad we snuck that question. It was really terrific answers. Okay, we can move to some questions from the audience. I believe the voice of God will read those questions.
Surprisingly, that's me. We've heard the words collective a lot in this panel: collective focus, collective responsibility, and collective action. In COVID, it was clear that the shared goal was to save lives. There was collaboration across organizations to do things like sharing ventilators. What is the current ideal equivalent of hospitals collaborating together on specific actions like sharing ventilators? Is it data sharing, grant sharing, provider sharing? Could you please share your thoughts?
Maybe I'll direct this one to Alistair.
It's specifically resolving, I would say in the first instance, I mean, there's lots of responses around how we deal with rhetoric and attacks on our values and so on. And so if I take that and put that in one bucket about how we collectively respond, I would say we share a lot of values across our organizations. We're all at different points in a journey on working on health equity. I think we have to support each other in that and support a space where we continue to talk about that work in a positive, proactive way rather than doing it quietly. Very practically, though, when you get down to financing, that actually is where does money flow in the state, and how do you support organizations that are disproportionately delivering care into low-income communities? And so there's some real discussions that we'll have to have. We're seeing it at the moment around the resolution even of the health safety net a program funding challenges. We hope relief is coming on that. That is very disparate across different organizations. Everyone's affected. But I think that we're probably going to get to a point where we have more choices to make around how we support each other in terms of how that financing system establishes a degree of stability across individual organizations and therefore the system as a whole.
Let's go with the next question, so we can get a couple of questions in.
We have a few. In the current environment, you are being asked to hide words. Your data is being challenged. Your research grants have been cut or are at risk. Science is no longer guiding us. How do you protect health equity programs and research if work is defunded and the federal government requires attestation that you're not doing it?
Kevin, maybe I can... Rob, why don't you go ahead? We'll get Rob and Kevin. How's that?
It's a happy picture.
Well, you know, that's...
Oh, sorry, go ahead.
No, you know, that's the issue right now, right? In that the attestations and et cetera are there. Actually, yesterday, they said it was okay to do DEI, and then a couple of hours later said it wasn't okay, or something along those lines.
Those were a good couple of hours.
A couple of hours? So we got all our grants in those 2 hours.
I think someone made a mistake there.
That's the answer to the question.
Not okay.
So, no panic. That's the first thing, right? It also, you know, the idea is sort of flood the zone in terms of the issues. And then taking a step back to continue to answer the question, are we doing what is important to do? And if it's important to do, okay, how do we do it? And so the short term is the mechanism of funding. Funding is being taken away. And then how do we deal with that? Do we do that with internal support, philanthropy, or et cetera? Understanding that, you know, is this going to be forever? Or is this for the next 6 months? Or is this until November of 26 that the world will change again? And given that, is what we're doing important? And if that's the case, we need to figure out a way to continue to do it. And so we're thinking about it in that way, in terms of our work around work in equity, diversity, inclusivity.
And the only thing I would add to that is that this is exactly the thing that I worry about, and there are many risks, as we've described, and as all of you are aware. Well, we can choose to be victims of this and decide that we're paralyzed because we can't do anything, which is just not the case. And I don't think it's actually correct that we can't do health equity work or can't drive to the best outcomes or have programs in our most disadvantaged communities and our poorest communities. There's no rule out there that says we can't do any of those things. And so I continue to say the focus on continuing to do the work that we have started and to do better at it than we have historically. We have to continue to improve. It's not just continuing the same, it's to improve and actually get to those outcomes. And there's nothing that's happening right now that's keeping us from doing that. So I would just encourage us to, as you know, it's normal and appropriate, as we all do, to feel anxious and feel mad and all those things, but to just sort of succumb to the victimness of this from a policy standpoint, I think is fraught because it can lead to paralysis. And there's the core work of what we're all trying to do remains true today, and we need to continue it.
We'll do one last question from the audience.
The question that I have for you is, how do you address the collective trauma our communities, your staff, your patients are facing by the relentless attacks on equity?
Wow. Who would like to take that?
So that's an ongoing piece of work, to be honest with you, because the trauma continues and the stress related to that. And we have worked to provide resources, outlets, communication, discussion, and support for what's ongoing. But the trauma is real, and the stress is real. Uncertainty and what is being described and what's happening to our patients and families. You know, we have our own emergency management system like all the hospitals have. And I was in a board meeting in the past month, and there was an alert that ICE was in the building. It was in the Children's Hospital. It turns out they weren't in the Children's Hospital. But I would have never predicted that I would have to react at a board meeting to that as a text. And so the frontline staff, what they're having to deal with is the issue that, you know, we're putting resources to and support to in this ongoing evolution of what we're seeing.
I'm going to do one last bonus round. Very quickly. Hope. In the moment, what gives you hope? We'll start from Rob.
I think I will say what we talked about earlier is that we have recent examples where we can overcome in healthcare and make different choices than what we've historically made to have impact. And again, going back to that lesson learned post-pandemic, those are choices that we can make, and I'm encouraged actually already by the amount of collaboration, conversation, advocacy that's starting to happen as all this unfolds across our systems. And so that's my hope, is that we will find creative ways to get to the thing that we're all trying to do, and that work doesn't stop. And I feel that in a time of crisis, there's a core of us that stays united in that mission, and we get hyper-focused. That was true in the pandemic. I am very hopeful and encouraged by the idea that we could do it again.
Kevin.
So, you know, it's that quote about the arc of justice. It's long, but you've got to stay on that arc to get to what you want to achieve and what you see as the end goal. And there are going to be bumps in the road. There's no doubt about it. And the goal and the work is to stay on that arc, right? You know, my dad was born in 1917 in Western Tennessee. My mom was born in 1931. And I look at their lives, they've passed, but I look at their lives and what was achieved during their time through work, through hardship, but sticking to it. And so we have to continue to, I believe, stick to it because where we are and what we're trying to achieve is the right thing to do. And given that, it's going to take work, but it's that arc that we're on.
Two things. One, and this is kind of maybe a slightly different way of saying what Kevin said in a slightly more wonky fashion, maybe, but like there's a lot of irrationality to health inequity and a lot of rationality on multiple dimensions, of which health is just one. Economic empowerment, thriving communities, the economy as a whole, for the work that we're doing that ultimately, like, actually, I think will prevail. And so there's sort of rational. The second is the people in this room, people on stage here, you all as well, and the collective community that we have, I think, in Massachusetts writ large, that's and how we're thinking about this, and that we're here meeting the moment, problem solving, how to think about how to get through that, how to support each other. So I'm not quite sure, I don't know, have all the answers of exactly how we're going to get from A to B on this or what the next 2 or 3 years looks like, but I'm pretty confident that together we will get there, and we'll make progress, and we'll stay on the arc that Kevin's describing.
To have a room like this filled all day discussing this topic should give us all hope at the moment. Someone who chose to take what I've learned here and go to the middle of the country, try to replicate this. I want to underscore something that came up in this panel. The ideas that are forming here, the ideas that emerge from days of conversation like this, the ideas that each of you are seeding in all your daily conversations matter to the rest of the country. So please keep doing what you're doing. Thank you to our panelists. Thank you to everybody for being here.
Just as I'm getting used to speaking to you while people are taking pictures, I'm introducing the last session, but before I do, actually, during this conversation, I heard two words very clearly: collective action. And it reminded me of something that someone said at a previous session as well, is that you can't have collective action without collaboration. What I at least got from this conversation, that is happening within these healthcare systems. And I think we need to continue to build on that, not only what we learned during COVID, but also what we're going to continue to learn during these hard times. So thank you again for the panel. Another round of applause for our leaders. Before I introduce also the next panel, I just wanted to mention we will be having a reception right behind us in the terrace at 4:30 with light snacks. We hope you all can join us and continue the conversation, keep connecting, and continuing the conversation. So that's it. Now we are honored to feature the important work of the Massachusetts Attorney General and her office in protecting the health, safety, and dignity of residents across the Commonwealth. We'll begin with a special video message from Attorney General Andrea Campbell, followed by remarks from members of her leadership team, Abby Taylor, Chief Deputy Attorney General, and Sandy Wolitsky, Assistant Attorney General, and the Chief of the Healthcare Division at the AG's office. They will speak about the office efforts to advance strategic priorities, close the health equity gap, and defend communities of color and immigrant communities during this critical time. Let's start with the video.
Hey everyone, of course I wish I could be there with you in person to extend gratitude to the Health Equity Compact for everything you're doing to protect access to health care, ensure it's high quality, and most importantly, affordable for our constituents all across the Commonwealth. I continue to want to be a partner in this work, not just in name, but in substance. So we will continue to hold the federal administration accountable for standing in the way of our efforts to advance health equity. And at the same time, we will fill the void where the federal government is walking away, continuing to work with you to close the health equity gaps that exist in the state, not just through litigation efforts, through legislative efforts, continuing to put out grants in the community to advance your efforts and our collective causes, and most importantly, to do what's necessary so the next generation has access to healthcare that is high quality and affordable. Thank you for everything that you do while being on the front lines with us. We are grateful. Thank you.
Good afternoon. It's wonderful to see you all. I'm Abby Taylor. I'm Chief Deputy Attorney General in the Attorney General's office. Always a hard act to follow my boss, who I know would have loved to have been here, but was so excited to have Sandy and I talk about the work that we're doing in the Attorney General's office in this moment where we have a federal administration that is so hostile to all of the values that I know we collectively share in this room. Just to sort of talk about where we see where we are as a Commonwealth and as a country, we see a federal government that's attacking our values, that's attacking our institutions, and that's attacking our people, particularly marginalized people, from immigration to education to voting rights, reproductive rights, disability rights, trans rights. The list could go on, and that could take up all of my time, just listing the groups that have been targeted by the federal administration. And I've been thinking about this in the context of presenting here at a health equity conference, where I know there are so many people in the room that are really focused on public health and focused on doing public health. And I think broadly, a lens that you could think of all of this through is that it is all an attack on the health of the public. Because there's a belief in this administration that we cannot come together for the common good, that we cannot lift up and protect vulnerable people, marginalized people, that we can't empower some groups because that will somehow harm others. And we know this not to be true when we think through a public health lens. We know that the truth is that by protecting, empowering, and serving everybody in an inclusive society, that lifts us all up, and that creates a greater public health for all of us. We know in Massachusetts that it's not a zero-sum game, that when we value diversity, equity, inclusion, and belonging, and when we believe that everybody should be able to live as their true, authentic selves and have the opportunity to reach their potential, that we all will thrive. And so that's sort of the lodestar that we've been bringing to the work as we address the Trump administration and sort of think about the role that we can have as Attorney General's office. So what are we doing as the Attorney General's office? There are basically 3 buckets of work that we're doing. One is we're suing them. We're suing them a lot. Thank you. We've sued them over 20 times now on a broad variety of issues. The second thing is we're providing information, we're providing guidance, we're providing truth where there is an effort to obfuscate that, where there's an effort to say that things are illegal that are not illegal, where there is an effort to sow fear and misinformation. So we've been trying to provide accurate information. And then the third thing is we're trying to make sure that Massachusetts is and will be a beacon for what is possible, not just in Massachusetts, but across the country. So I'm going to talk about the first 2 buckets, which are kind of the more defensive buckets in the moment, and Sandy is going to talk about some of the more sort of offensive, how do we take a step forward in terms of Massachusetts playing that role. So first, suing the Trump administration when they're breaking the law. What we're seeing they're doing in terms of sort of like how this is coming down the pike is in a few different buckets. One is funding. They've really figured out that funding is the key to everything, especially when it comes to the federal government. And by trying to sort of go to the absolute limits of what they can defund, what they can pull back, what they can make sure that our institutions and our nonprofits don't have, that is a lever for them to try to remake society in the way that they might want to. The good thing is that we have a Congress that holds the purse. We all learned about this in Schoolhouse Rock when we were in whatever grade. I'm dating myself. Maybe some of you in the room didn't have Schoolhouse Rock, but it is the Congress that gets to decide how the federal government spends the money. So a lot of the funding cuts we've seen have been blatantly illegal, and we've brought a number of lawsuits that have to do with funding. We've done a lot of those in partnership with other states, and we've done a number of those in partnership with private litigants, so we can get sort of as broad as possible relief for the most number of entities in our Commonwealth that we possibly can. And the second category really is about where they're trying to threaten people, where they're trying to threaten institutions, where they're trying to enforce the laws in ways that scare people. So we've seen this in the immigration context. We've seen this in the context of them trying to sort of take the identity away from trans people in the Commonwealth. We've seen this when it comes to DEI and DEI programs and the way in which they are trying to frame all efforts to promote, think about those words, diversity, equity, inclusion, belonging, that somehow promoting these things that are sort of central to what any institution knows is essential to its success, that in and of itself is illegal. So we brought lawsuits challenging from the birthright citizenship ban to the cuts in the Department of Education of DEI programming. We brought lawsuits there. But these efforts to intimidate and to scare people is another area where the second bucket of work that I described, the bucket of providing accurate information to people, is really, really important. So we've done a number of guidances, most recently around immigration enforcement, because we know just the fear in communities around immigration enforcement. The truth is that the Trump administration has broad discretion when it comes to immigration enforcement. And we know, as a law enforcement agency, that just because you have broad enforcement discretion to detain people, to prosecute people, to put people behind bars, doesn't mean that you should always act on that discretion. And that is not in the interest of public safety, the way that they're carrying this out, both because of the large number of people who are being arrested who pose no public safety threat whatsoever, and because they're carrying this out in ways that are designed to terrorize communities, to cause the kinds of protests that we're seeing, to cause people to sort of engage in civil disobedience, to cause children to not want to go to school, to cause parents to be afraid to take their children to healthcare facilities. So we're seeing that being played out in a way that is meant to engender fear, and we put out guidance not because we can stop all of it. We can't. I just want to be honest about that. But because we want people to understand their rights, to understand what is lawful and what is not lawful, and to be able to come forward with information when what they're seeing is not. So that's sort of one category of guidance, and I won't go through all the different things that we've put out to just sort of provide information. There's another kind of guidance that we put out that sort of includes somewhat of a, I would say, call to action in the context of the guidance. So DEI is a good example of where we've done that. If you listen to the Trump administration, again, all DEI is unlawful. You can't possibly engage in it. But when you actually look at where institutions have legal liability, because that's what that's about legal liability, where they have legal liability is where they're not engaging in practices that allow everybody to be welcomed and to belong. Because it is those kinds of environments where discrimination and harassment can fester, and where ultimately you're going to have the lawsuits that are going to cost you a lot of money, not to mention you're going to have employees that don't want to work for these organizations that then are not as strong in being able to fulfill their missions. So we've tried to put out some guidance that not just provides the information, no, DEI is not illegal per se, but also sort of put some pressure on the other side in terms of we are also a civil rights enforcement authority, and where there is discrimination, where there is harassment, where there are these kinds of practices happening, we will take action, and private litigants can too. So I think that's most of what I wanted to say about the sort of federal landscape when it comes to the litigation and the guidance and the response directly to the Trump administration. Hoping to turn things over to Sandy now to talk a little bit about what we're doing proactively, and then hopefully we'll have some time for a few questions from all of you. Thank you very much.
Thank you. It's an honor to be here, and it's been a privilege to be in this space with you all today. Thank you to the Health Equity Compact members, leaders, staff. This is a really inspiring day. So, as Avi said, while our office is working hard to defend against federal attacks on our healthcare system, at the same time, we are working to continue to improve that system through our law enforcement work, policy work, grant making, and community engagement. We are very busy in our state law enforcement work right now, protecting Massachusetts healthcare consumers from scams and fraud. But today, I want to talk about a few other priority areas for us in the health equity space and the ways that the AGO is using unique tools in our office to move those issues forward. I want to hit on three themes that have been core to today's discussions: affordability, investment, and maternal health. So starting with affordability, the legislature has given the AGO powerful transparency tools that allow us to collect and review information from healthcare market participants and make that information public in reports that we issue. Now, this is a unique in the nation authority that allows us to shine a light on ways that the healthcare system is not working and create ideas about how it could function in a way that is more equitable, more affordable, more accessible. We all know affordability issues are urgent right now, and as Commissioner Caljo said earlier today, affordability and equity, they're two sides of the same coin. State healthcare spending grew 8.6% in 2023. Health insurers in the merged market just proposed average premium increases of over 13% in the coming year. So our team recently used our transparency tools to examine how affordability challenges impact individuals and families through cost-sharing burden, deductibles and co-payments, and ultimately medical debt. We found that commercially insured Massachusetts households in the lowest income zip codes spent the highest percentage of household income on premiums and cost sharing, and spent nearly 5 times more than the share of income spent on healthcare in the highest income zip codes. Many lower income patients get some relief from hospital financial assistance policies. Well, we analyzed those policies and found significant variation across those policies of different hospitals, leading to a patchwork of different eligibility thresholds and discounts that may be very difficult for patients to navigate. We also studied hospital data on medical debt and found that Black and female patients were the populations most likely to be burdened with debt. In addition to data analysis, we put out policy recommendations that speak to these issues, including increasing protections for consumers around provider financial assistance policies and the collection of medical debt. We've also put out a call for indexing and monitoring how much Massachusetts households, are paying for healthcare in relation to their capacity to pay, and applying these measures against a target healthcare affordability benchmark to help identify overburdened communities. Speaking of benchmarking, I want to thank the earlier panel for a thoughtful discussion on health equity benchmarking and putting together a really important framework. We are excited to participate in further conversations about how the AGO can collaborate on this really critical work. There's been a lot of discussion today about the importance of investment. So one important AGO tool in this space is our oversight of the nonprofit hospital and HMO community benefits program. For those of you who don't know, community benefits are investments by nonprofit hospitals and HMOs that further their charitable missions by addressing their community's health and social needs. So the AGO develops and maintains community benefits guidelines that set standards for hospitals and HMOs on how to develop community benefits programs that track demonstrable community health need. These guidelines provide transparency on the content and impact of these programs through annual reporting. Our current guidelines encourage hospitals and HMOs to think upstream about the barriers to health in their communities and to assess in their community health needs assessments which social determinants of health are priorities for local investment. The guidelines encourage filers to promote investments in built environment, social environment, housing, violence, education, and employment. And to give you a sense of scale here, in FY25, Massachusetts hospitals and HMOs reported $1.2 billion in community benefit spending. So this is a major investment in community health in Massachusetts. All of this information is made available through the AGO website, including information about the programs, the investments, and free and discounted care. Another area where the AGO has been supporting health equity work through investment is our maternal health equity grant program. So we're now in the second and final year of this grant program, which aims to reduce maternal health disparities by increasing access to culturally competent maternal health support services. This grant program is funded through settlements reached by the AGO, and I just wanted to lift up a couple examples of the fabulous work that our grantees are doing in this space. The Cambridge Health Alliance is using grant funds to provide updated training for doulas, including how to lead culturally and linguistically responsive childbirth and postpartum classes. Mother's Milk Bank Northeast is using grant funds to promote equitable access to donor milk to support lactation. And Berkshire Medical Center is using grant funds to expand culturally competent maternal health support services, including perinatal support groups for families in Berkshire County. Thank you so much for inviting us to be part of this day. Abby and I are happy to answer questions.
We also won't be offended if you just want to get to the reception, but if anyone has any questions, we're happy to answer them.
Just a couple of questions have come in, so please continue to submit them if you have them through Mentimeter up there on the slide you can see. So first question is, where is the guidance that you spoke to earlier, especially around immigration?
Yeah, so we have a whole landing page on the various immigration-related guidance on our website, which I'm sure we can figure out how to share with all of you through the conference organizers. We had the guidance I mentioned was specific to communities and bystanders in particular, but we've also done a lot of work to provide guidance to institutions. So K-12 schools, healthcare institutions, as well as higher education institutions and social services institutions more generally. We have separate guidances for each group that speak both to sort of how to be prepared in the event of potential ICE enforcement at those institutions, which luckily we haven't seen much, if any, of in Massachusetts, but has happened in other places, and people really do want to be prepared, and also how to best protect the privacy of students, of patients, of others who might visit those social services organizations. So happy to share more on all of the various guidance we've put out around immigration. On the other types of guidance, they are all on our website, and again, happy to send sort of an enumerated list of the various guidances we've put out for all of your use.
Thank you. What actions can non-attorneys do to support the work of the AGO?
It is a really good question. I think one thing is sharing information with us is critically important. So where you are seeing things. I know a lot of you work for institutions that may be seeing grant cuts. We want to hear about them. We want to hear about grant conditions. We want to hear about any potential enforcement of grant conditions that you may be seeing. That really helps inform where we bring litigation and why. We can't take action on every issue, but I think just sort of hearing about that is really helpful. The other thing that I think is really important is like we are, yes, involved in a legal battle, but judges are people, and they are affected by what they see and hear in the world, as are politicians and others. So I think lifting up and sharing stories of the impact that the current administration's policies are having on real people, on small nonprofits, on small businesses, on schools, is just incredibly important. And we don't always have direct lines into that information. So I think that that litigation in the court of public opinion is just as important as litigation in the courts, and people who aren't attorneys can be incredibly helpful with that and probably more effective than most attorneys who think themselves to be good communicators to the public, but are not always.
And if I could just add to that, to plug our online complaint portal, we have, through our healthcare division, a link on our website that lets anyone submit complaints to our office. You are really our eyes and ears, and sharing your experiences, even if it's as an FYI, is incredibly helpful to our team in identifying trends and concerns, either for enforcement or policy responses. So please don't hesitate to share your concerns, complaints, experiences through our website.
Thank you. Federal actions are resulting in dismantling of progress made, particularly in data transparency and goal setting to achieve equitable workplace representation. Can state AGs regulate such efforts, or what tools do you have to work with?
Yeah, I think we have a few tools. I mean, one is litigation. I think where they're rolling back initiatives that are congressionally mandated or that are otherwise unlawful to be dismantling, we can take those on. I think the other thing that the other tool that Sandy mentioned briefly is an enforcement tool. So I think where there is discrimination, where there are things that are happening that are not correct, we can regulate those. When it comes to information sharing about institutions, to the extent that that's going to be required, it probably requires the legislature, though I have not done deep thinking about that. But certainly could be something that Massachusetts require, whether that be through regulations or through legislation.
Hello? Yeah. Last question. Where does the AG office envision their health equity initiatives in 10 years? What is your long-term strategy?
That's a great question. I mean, honestly, I'd want to reflect more, I think, on the conversations from today, because I think any one institution's strategy is going to be less effective if it is not coordinated across the incredible work across other state agencies that are working in the health equity space. We've heard a lot today about EOHHS's AHEM initiative. Of course, the Health Equity Compact is leading us forward in thinking about coordinated benchmarks, and I think these all have to be part of a kind of coherent long-term strategy. But I can say, we have powerful law enforcement and transparency tools that are, I think, unique across the portfolio of tools that we all in this space bring to these challenges, and are really committed to staying in conversation with all of you to move forward towards measurable, accountable progress across all of the domains that we talked about today.
Thank you so much for having us. Really enjoyed it, and looking forward to meeting some of you afterwards.
Thank you very much for your work. Thank you for sharing all you're doing to protect our communities and to continue the work around health equity. We very much appreciate and look forward to our continued collaboration. So, all right, folks, we're now at the end. What a day, right? Yes, please. And I get to be the last one to say how awesome it is to see all of you in the audience and how much I got all of the energy from all of you. And I'm sure every single person that has been up here has shared the same thing. So thank you for that. Thank you for your collaborative work. Thank you for your commitment to doing this. And so for those of you that were here all day and heard me share a story about what I used to do with my patients when I got stuck, if you were to have a session with me right now after this entire day, if I were to be your therapist and I were to ask you, what's been going well? Would you say something different? Would you share? Would you share? Yeah? So, I don't need any answer. I just need you to reflect on that. I learned them from multiple years of practicing, right? But think about that. I think we need to continue these conversations. We need to continue to collaborate and think through. I heard so much of that collective action and collaboration, and there's no better space than now. And I encourage you to keep that going into that reception that we're going to be having behind us. So, want to close up by adding some thank yous. Thank you again for all the speakers, the attendees, all of your time, your insights, and energy throughout the day. Thank you, and another round of applause. We came together not just to share belief in health equity, but again, collective action. And one more thanks for amazing sponsors, staff, and volunteers. Thank you very much. I also want to specifically thank Rosemark Productions. They've been amazing today, especially for someone very new to this role. They made it very seamless, so I appreciate all the work that you've done. And so before we go into the reception, I want to invite the Health Equity Compact board members to the stage, as well as Lindsay and Sona. So please, board members.
Oh, there we go. Okay, so before we take this picture, and then we have a fabulous reception out on the patio area, I want to do two things to just acknowledge some of the leaders who are behind the compact. A few of us are like students of history, so we study a lot about how movements start. And one of the things that I'm a student of is the Medical Committee for Civil Rights and the Medical Committee for Human Rights, which were physician activists who went down south for Freedom Summer to really work on providing medical care for those civil rights activists who were risking their lives to advance civil rights. And you always ask the question as you look at their individual profiles, who were they? They were doctors like Jack Geiger and Count Gibson and Dr. Robert Smith in Mississippi, who are literally sacrificing their careers to take time away, to leave Tufts Medical and others and head south to do that work. And you wonder about the conversations they had up until the point someone asked them to do it. Like, what was the compass? Not their gut, the compass. What they read, what they saw, what they believed that inspired them to do the right thing. We are fortunate in the Health Equity Compact to have some phenomenal leaders who, when we call them, and asked them to do this work, they said yes. Some of them had just left government jobs and wanted to retire and take a break. And we said, you don't have time to take a break. We got a movement, and it's time for you to be involved. That's Lindsay Tucker. Give her a round of applause. And some were in, large institutions, making good money, doing good work, making a difference in those institutions. And we said, hey, come to this nonprofit. We got less resources. We don't have all the frills and all the other stuff that you got at Blue Cross Blue Shield, and more work. But we want you to come work with us. That's Sona. Give her a round of applause as well. So we have a special gift for the two of them because they're the force behind this work. And I say this sometimes about Lindsay, but I want to stress this. Civil rights was not just about black people. If you ever thought that civil rights was about black folks, you didn't read the news. Because when they marched in Selma and in Birmingham and in Greensboro at those lunch counters, they were actually making sure that democracy worked for everybody. The reason I say that is people are often shocked that we're a group of 85 leaders of color with a white woman running the compact. But I'm not shocked because I know history. I know James Reeb answered Dr. King's call to go to Birmingham, to Selma, and he was murdered. I know Sherna Goodman and Cheney answered the call and they were murdered. I know I can go on and on with the list of people. Mary White Ovington started the NAACP, a white woman, partnering with black folks and folks of color to make a movement. So I just want to acknowledge Lindsay because her compass is right. She wouldn't have survived with 85 A-personality black folks and brown folks unless her compass was right. So last but not least, before we get off and take this picture, Angel, JSI, where's Angel at? John Snow Institute. If you don't know who they are, they're a force behind a lot of good stuff happening in this country. And when Jeffrey Sanchez called me and we were talking about starting the compact, he said we got to have JSI involved. The first person that stepped up to work on this health equity compact was Angel. Give her a round of applause as well, please. Angel Burgoyne.
Angel brings an amazing team who helped to create this day. Sona led all of the work with Tamar, with Leanna. I hope Katie's in here, but she might be outside. We've got a phenomenal intern this summer, Benny from HCC. Leah Perlman, who has just given so much of her time volunteering through BILH with us, and so many others. Gia and Lauren from Jeff's team, thank you so much, Jeff. This is really a team effort. This is a community. These are the board members, and there's compact members all out here. This is your community. This is our community. Thank you so much for being here, and see you at the reception. Yes.